three of us, four of us, six of us, depending on the sphere that we're discussing, we disagree, and it's healthy to disagree, but the center is that person in front of you. Never miss that. If we are rushing, Dr. Nim is not pushing to go faster because he wants to have another coffee. He is pushing to go fast because every minute counts to that patient. Never forget that. We are rushing for a very specific reason. We're rushing for a human life. And that puts us, we happen to do 10%. This is not our number. Somebody else from that connects a register said, you guys do 10% of the thrombectomies in the whole state of Florida. That's not bad. For a single, we're not even on the largest city, not even on the second largest, not even on the third largest. We do 10% of the thrombectomies in the state of Florida. And we have best door to recanalization in the whole region, twice as fast as number two. This is hats off to what the hospital put together. Baptist has a very strong group of hospitals and a freestanding ED. 300 plus. I'm always quoting a wrong number because primary care doesn't stop growing. So we have a huge number of primary care physicians, and this is all connected. When Eric and I started, we hire what is the name of the specialties on call, and then we learned right away that this was not the way to go. So we create our own inbred telemedicine that Mohammed, my son, is our director, that connects all our doors plus whoever wants to be connected. Dr. Nima, since Mohammed is not here, do you want to talk about telemedicine?
I think telemedicine is a very, very important tool that we have. So let's say, as you can see in the map, in Southeast Georgia, resources are limited, right? So the fact that you can actually reach a vascular neurologist and figure out whether or not that patient can benefit from thrombolytic, but not only that, let's get advanced imaging, CTA. Let's see if that patient has some sort of, for example, carotid disease or large vessel occlusion, obviously. Then we can take care of those patients. And for us to do that, we are a group that provides care to all this facility. So obviously we know each other. We have M&M, so we are learning still. And the good thing is, like I said, it's homegrown, and I think we have a great telemedicine team to be able to do that.
Yeah, this has been kind of an evolution. So like you said, we use the imaging. We started deploying Viz at our telestroke sites so that we can triage those patients better. We work with their hospitalists, their ED providers, so that we can keep patients that don't necessarily need to transfer to the kind of the mothership. So we can leave them in their hometown where they can get care and have access to resources closer to their home. But these, a lot of these hospitals, it's far, it's hard to get the patients here. It's a lot of work with the EMS providers. Our whole stroke coordinator team actually goes out to do education at these sites, and we educate their staff along with EMS in the region. So it really is kind of a comprehensive program in a very under-resourced area. And so it makes, it's a big impact for that region. I mean, South Georgia is definitely challenged in terms of healthcare resources. So it's a big need for them, and it gives their patients access to the care that's here. There's still room. So there's still room for growth and change. So exciting.
Since Shamsan is not here, I'm going to say that what's the impact, you may ask. If you look at Brunswick, for example, when it comes to stroke treatment, it's about penetration, for example. So you have this many stroke patients present within thrombolytic time window. How many percentage do actually get thrombolytics? So if you look at the penetration of thrombolytic by itself in Brunswick, it has significantly increased the number of patients who now get thrombolytic after we implemented ultramedicine in that system. The other thing I'm proud of is, you see a lot of Baptists obviously around, and the goal here is with telemedicine, provide the same care to any patient when they walk into Baptist. So our goal had been, and that was something that was very important to me. If you go to Baptist, if you have a stroke, you should go to Baptist, right? So, but the patient's not going to know at the end of the day, downtown, beaches. So when the patient goes to Baptist, we have the same protocol for all the patients to treat the patient as a cold stroke. But obviously we cannot be there, so then telemedicine is there. And obviously if thrombectomy is needed, they have to come downtown. That may change in the future.
You stole my line. That's my punchline about this. Telemedicine clones Dr. Nima. He's on call today for Baptist Downtown. Telemedicine. He is in every single 14, 16 and growing doors. So to replicate the quality of that provider is very hard to find providers of that caliber. He is available to all 16 at a click of a button. So I think that's just phenomenal. When Eric and I joined Baptist in 2014, one of our role models was the Barrow Neurological Institute, where a guy that was frustrated because he lost a race to be chairman at Cleveland, Case Western, got frustrated, said, I'm going to go away from this politics of academic medicine that can be pretty heavy and cutthroat. He brought this to a different environment. So he brought the tripod of academia, that is patient care, education, research, to a private sector, private practice environment. And it happened that this was 1983. 40 years later, they have the largest neurosurgical program in the world, I would guess to say, if you don't count China. China is a different category, but in the US for sure they have the largest. So we both trained at the Barrow and we saw that, and we knew that we could deliver patient care, but we thought it's not, you cannot be cutting edge in patient care if you're not doing education, if you're not doing research. The young samurais on the back of the room, they're always asking, what about this? What about that? What about this? What about that? So they keep you, and it's cross-fertilization, right? So a trainee comes from one hospital, bring different ways of doing things and bring that to us and challenge the way that we do things, and we grow together. So I don't know if you want to talk about this one.
So all that started in 2014, as Ricardo pointed out, and it was a really good I think confidence from Dr. Spetzer, in fact, to allow one of his residents, Rick Williamson, to come with us for the first year in Ramesh Grandi. So we're fortunate now to have Dr. Sue, who is about to leave us, unfortunately. Fortunately for her, Victor and Dr. Muse, who will be with us again next year. So it's been part of the journey, training fellow, as Ricardo mentioned. It's humbling to listen to their opinion, their input, learn from that as much as we hope they learn from us. And part of it as well has been the research fellow, who have been doing a tremendous job. Here they are, helping, with publication and advancing the field further. So thank you.
Yeah, I just I put Ramesh Grandi. I always that slide. I love when that triggers. Dr. Grandi was first-class fellow. He is the sole reason that we connect to our foster child here, Dr. Nima. When we're looking for a neurologist to hire, Ramesh said, you got to interview this guy. He's gold. And there's not a single time that I don't talk to Ramesh and say, you are right, that guy is gold. I'm so glad we connect. And you saw the impact in what he does here with us. Erica.
And if I could add, the only thing is that we did our homework. We check around and ask for his mentor. And one of his mentors say, there's only one problem with him. He just chose the wrong specialty. He should be a neurosurgeon. So that.
That's Brian. Eric start talking about the research fellows. I think the research fellows with our, what we call now Baptist Health Research Institute. I saw Dr. Gubi, where are you? Oh, here. Do you mind standing up? Dr. Smita Gubi is our director for the HRI. When we came to Baptist, that did not exist. Cardiology was doing some research, and there is an independent group of physicians doing research, but nothing organized like this. It happened that during our time at Baptist MD Anderson also came. Cannot tell you how many physicians we have at Baptist MD Anderson today, but I'll tell you a lot. And they keep growing. It's a phenomenal operation for the community. So eventually they will do more research in stroke and cerebrovascular, but I think today remains that what we do in the stroke and cerebrovascular is number one, as a line of research inside of Baptist, from research from disparities in the stroke to latest drug in the stroke treatment, from what we did yesterday, first in Florida, first in Southeast, a new procedure called e-shunt. There are 5 centers in the country doing that for new treatment of normal pressure hydrocephalus. It is super cool that we're bringing this to the community. And what research does, we're about to start another one called RTs. What research does, Medtronic wants a product approved, Medtronic is going to pay for that. And with that, I can treat people that cannot afford aneurysm treatment under that research. So you see how these things just connect together and we push the envelope forward. Couple of our publications, we are very fortunate to be part of Dawn that changed the landscape. Raul Noguera is somewhere in this building, so kudos to him and Tudor to put this together. We changed the guidelines in the country. We are part of this one with Amru Siraj, again, likely to change. And we finished this one with Raul and published that. We're about to finish this, looking at genetics of familial aneurysm through Trinity Hobley Foundation. We got funded for about $1 million from the state of Florida. We're going to enroll 1,000 family members of patients with aneurysm. We're going to have blood donated from everybody, imaging from everybody, and then we're going to run genetics of these people, see if we can find. Wendy, do you want to talk about WeTrust?
Yeah, always. WeTrust it's been a lot of fun. It's a lot of work. We worked with the stroke coordinators and a big interdisciplinary team from the rest of the hospital, from the ED to pharmacy, ED physicians.
What is WeTrust?
Well, I'm getting there. Hang on, I'm getting there. So WeTrust it's direct to angio, right? So instead of stopping in the ED and doing all of the imaging and doing all of the assessments, it's basically a quick stop with the neurologist, the ED physician, the stroke coordinator to get an NIH on the patient. And if they look like a large vessel occlusion, rather than spending 40 minutes imaging them, we're going to take them directly to the angio suite. We're going to image them on the table. And then if there's no hemorrhage, we're going to go for it. Maybe give them TNK in the meantime, in the 3 seconds before the groin puncture. But basically, it really streamlines the workflow even further, right? So we knew there was time to save based on how quickly we can intervene on our transfer patients. It's a solid, 40 minutes? I think our first 2 patients that we enrolled, the door to puncture on those patients was 25 minutes and 26 minutes respectively. So it's very, very fast.
I just want to say how motivated we are.
Yes.
You have no idea. So I'm pretty motivated. Obviously, Ricardo, Eric, very passionate. I know Chimisani just joined, and Wendy, but the whole team is very passionate, right? Now, let me tell you how passionate our team is. As we're doing this, Wendy's asking me, because one of the vascular neurologists asking, can we enroll in WeTrust?
Today.
And think about it. We're here. Thankfully, we have Dr. Akito joining, who's covering, and we have the stroke neurology covering. But I just want to say how motivated our team is, because they're still thinking about this which is very important.
Mm-hmm.
Dr. Chimisani is our director for telemedicine. We went through a couple of slides, Mohammed, but I would love for you. Our high-speed Lebanese man, he's always comparing Teslas to Porsches to BMWs. We need to find another Lebanese so we can compare them to each other.
Lebanese are unique, man. I think with the WeTrust, we're always talking about the next step. I think the next step we're trying, hopefully, we want to figure out all the technical difficulties, how we can start our stroke evaluation in the ambulance. That will fit very nicely with the WeTrust. So we can start the process there, and then we can be better able to triage patient be a good candidate for WeTrust. So that will be the goal. And obviously, the goal for the next couple of years, keep adding more campuses. I think 2 freestanding yards are adding up in the next 2-3 months. We have a trip in 2 weeks to Archibald, and we're looking forward for more expansion.
Thank you, Eric.
And one thing I would like to point out as well is that, the growth of the program would not have been possible early on with the fantastic neuroradiology group. I see Dr. Shemel there. Unfortunately, healthcare is changing, so it has some recent challenges recently. But again, they've been instrumental in delivering high care to our patient. Another thing that, most of you, I mean, obviously the conference is dedicated to cerebrovascular care, but as Ricardo pointed out, I mean, one part that has progressed quite a bit here is with MD Anderson is, tumor care. I think it's been exciting as well that we've been part of some cutting edge research there, affiliated with institution that usually it's hard. You would not expect Baptist to be next to UCSF or Hopkins or Duke for glioblastoma research, but fortunately, we're part of some viral vector therapy for glioblastoma and some new molecule with direct implantation with a pump and all this. So it's been really exciting under the leadership of Rob Cavalieri, neuro-oncologist. So that has been something as well that it's been nice that we could offer other thing to this patient population.
Awesome, guys. I think you got a good snapshot of our 10-year journey here.
Can
you guys, yes. Please.
Sorry, one more thing.
Please.
I have this. I just want to, before I know where Ricardo's going, thank you for being here, but I wanted to highlight a couple more things. So to do what we do, obviously we talked about the team, right? Neuro ICU, I think, is a very strong part. So I want to make sure that, not if we didn't have the dedicated Neuro ICU, Dr. Naval, like Chamisani, Dr. Murati, Dr. Shaw, and the nurses and the APPs, then I really think that, and those are the backbone of our program. I see that our neuro techs are over there. I'm not going to name them all, but I know their name. But coming from a different place, you appreciate if you have a dedicated someone who knows the system, who knows the program, and it makes such an impact in how we treat the patient. So I want to thank them as well. In addition to our stroke coordinator, all the APPs and nursing and techs and everybody else, that really give the strength to what we can do for our patients.
So I was about to be done at just before 30 minutes, but since we're over, it's just like an airline, you're over anyway. So here we go. I miss Dr. Naval coming to the room. So it's a landmark day for him today, right? Somebody's turning 18.
Yeah, my daughter.
Yeah, so we convinced this guy that was a director for a small institution in Baltimore, Dr. Hopkins. Everybody made this confusion when I went to Buffalo. Yeah, are you at Johns Hopkins? No, I'm training with Dr. Hopkins. So Naval Niraj came from Johns Hopkins, not from Dr. Hopkins, to join us, and he changed the face of our critical care program. Happy birthday, Daddy. We're proud that you're here. And again, we have to run through things because you guys know me. I can talk for 3 hours about that. I'm very passionate about this team. Everyone in this room that is part of that knows that we do this at a super, super intense, sometimes cranky, sometimes in a better mood level, but always try to focus in what needs to be done at a super high level. I'm going to go back to this last slide and I'll finish. You saw we talk about We Trust. Nobody asked what is FastCat. So We Trust is being done in Turkey, in Buenos Aires. FastCat is Baptist only. We have soon to be IRB approval. We're going to be the only center in the world doing direct to cath lab up to 24 hours because we went through this journey, 6 hours, 24 hours, small core, large core. This is all past. We know that the small core, 6 or 24 hours is the same. Got to go get the vessel open or get GTF. I forgot the Canadian acronym for that. Just get the vessel open. So if you have chest pain, you don't stop at the ER. Oh, let's do a CTA to see if there's a coronary fluid. Just get that vessel open as fast as possible. I have no question the future is really bright. We're at the dawn of a new phase. You're going to see a lot of these things here the rest of the day today, how we're going to push the envelope again. This is Wendy. I'm giving you credit for the picture. This is Wendy's picture from yesterday.
Very nice.
The future is bright, and thank you everybody in this room that is part of that. Baptist administration for making this possible and believing in a crazy dream that a Brazilian convinced a Canadian to join and start something special. I think this is really special. And I appreciate you guys being here to celebrate with us and to learn with us and exchange all day long. Thank you guys. Let's start work.
I could so. So.
Let me introduce our first speaker. So talking about Canada, always nice to have some Canadian visitor. I think they may enjoy this time of the year here. So Dr. Michael Hill is the director of the stroke unit in Calgary. So for people who may not know, Calgary is one of the leading center for stroke care. So, most of you are probably aware of the aspect. The aspect, in fact, come from Calgary. So they've been at the leading edge of stroke care. And again, Michael will show you why and what is coming our way. So thanks again for being here. We appreciate it.
We have to hold on while the slides get loaded. They're coming. How do I, is there a controller for the, Eric, is there a controller for moving the slides ahead? Aha, here it comes. It's coming. Thanks. Let me know when you get the first one up. Jeff picked me up at the airport, which was really nice. Thank you, Jeff. I don't know if you're here. I don't see you yet. But one of the things we talked about was differences between academic programs and what makes an academic program versus regular community care. And I think one of the things that you just heard from Ricardo and Eric and Nima and the group is that actually you have all the three components of a really strong academic health sciences center, right? Which is you provide excellent care, you are doing clinical research, because that as Ricardo highlighted, one of the key reasons we all do it is to make treatments available to our patients, which are not routinely there, right? It's the up and coming stuff. And the third thing is you're educating new people, right? So it's fellows and students and that kind of thing. It doesn't you don't have to be tied to a top tier medical school to be a really effective academic health sciences center. And I was saying to Jeff that one of the things I've observed, working with many sites around the world in clinical trials, is that it's not the big academic centers, the big well-renowned, the Mayo Clinic down the road from you guys, or Johns Hopkins and others that are the best enrollers, the best clinical trial groups. It's people like you guys, right? So don't think that Mayo Clinic down the road's any better than you guys, because I can tell you for sure they're not. Okay, so I got two brains, so I can throw them at people if I need you to answer questions. This is that's me actually and the dog. We were skiing this winter on the lake up in the mountains. So I'm gonna start with the medical side, right? Thanks. That'd be great if you can. Thanks. And I know we heard from the two neurosurgeons who think everyone should be a neurosurgeon, but of course it isn't true. I'm a neurologist. So I'm going to start with the medical side. I'll give you a little tiny bit of history, and then I'm going to end up with some new stuff that I'm hoping to work on. I'm hoping to involve you guys in this trial, and Smith and I and Nima hopefully are going to talk about a bit later on. So just some disclosures for me. Our group in Calgary has been funded by lots of different folks, both public and industry funding. So just a list there, and then in the background is the Northern Lights over Moosonee, which is up near James Bay in Ontario. So acute stroke. So this is what we do now, right? This is our acute thing, and I'll give you the acronym, Eric. Right? We want to keep it simple. We want to move fast. So you heard Eric talking about We Trust and fast cath. That part of this is about speed. So it's really great to hear you embracing that, and we'll talk a little more about that. We want to get treatment in quickly. So we're giving thrombolytics. And then when you're off to the cath lab, you have to get the vessel open, right? And there's the acronym, okay? So that's what we do now. And I don't think fundamentally a lot of that's not going to change. Stroke, the biology of stroke is you have to be fast. You cannot force the disease into the system that you want, so it's convenient for you to be on call and you to you to get imaging, or you have to adapt to the disease. And the disease is a fast-paced thing, so you've got to move fast, you got to work as a team. So, but we're not there yet, right? And what are the if you think about what are the reasons people don't do well, one of our problems is that we don't get the arteries open all the time, right? And we've done a lot. It was interesting, you know, when you look back at all of our data, particularly the thrombolytic data, it's remarkable that we didn't go imaging vessels afterwards to figure out how well we were doing. It seemed it's a sort of a strange thing, but it took a little while to start imaging vessels, understand even how well medical treatments were working. And people were imaging at 24 hours because it was convenient to image at 24 hours. But of course, that's irrelevant, because what matters is the vessel open in an hour or in 2 hours? And so you can see some, if you go and look at the early studies, they're giving you 24-hour recanalization rates with IV TPA of 80%. But of course, that's useless, because if the brain is already infarcted, it doesn't matter if the vessel's open or not. And we've learned, though, that clots mature, and the speed of treatment therefore matters. Clots mature over a period of minutes to hours. We've learned about the nature of thrombi. I'm going to show you a bit of data on that. We're moving to a new standard with tenecteplase, and you've seen that evolving in North America particularly, and now in Europe. Tenecteplase is now approved by the European Medical Agency. It now has a label for stroke. The FDA is currently considering the data on this now, and so we may have a US label for stroke for tenecteplase fairly soon. And there's been other agents tested. I'll show you a bit of data on that stuff, and then I'm going to end with a new drug. So here's some data from an older study. It was a minor stroke study, but just to point out, this is true for big strokes as well. If you get the arteries open, people do better. So if you're in blue, you have a better outcome because your artery is open, right? And I think that's what we all know this. Our reperfusion, this is the data from Hermes, showing you what the TICI-2B3 rates were like. And you can see that in all of Hermes, that was the big 5 trials. So this is data from now, it's now 9 years old, of course. But you see it was about 75%. And then TICI-3 rates, you know, were in the low 30% range, right? We're not getting arteries open all the time. So we're way better with EVT, and it's improved. There's no doubt in the last number of years it's improved, and you'll see data that are much better, but we're not there yet. If you look at what happens with medical therapies, now just to give you the comparison, you can see why IV thrombolysis doesn't work as well as it should, or we would like it to for large vessel occlusion, even medium vessel occlusion, is because the arteries don't get open enough. So if you look at this, these are data from ESCAPE. I think ESCAPE was the only one that where we did this. We did so ESCAPE randomized patients to EVT or not, right? And in the not part, most patients got thrombolysis. If you look at the medical arm on the right-hand side of that table, you can see of the patients who got IV thrombolysis at 2 hours, we did a 2-hour CTA. So we did that early follow-up vascular imaging to find out, so it was like a control to find out how well patients did. About a third of patients, 37% there, had open arteries. If it was an M1 occlusion, that M1 was now open. And of course, 37% is not enough, which is why you need EVT. We need to get to 80 or 90% open. If you look at the speed of opening with thrombolysis before on the first angio run, you see it's only about 5%, right? And I think you all know this. So, you know, for example, in the concept you were just showing earlier, Eric and Ricardo were showing earlier, of going straight to cath lab, you're not likely, if you're going to be already going there, you're not going to be giving additional lytic, most likely, because you're gonna get the artery open with the EVT. But you can see why IV thrombolysis works, but not that well, not enough, which is why we need EVT. Okay. So we move to tenecteplase. Is tenecteplase any better? There's some theoretical advantages of tenecteplase. As you may know, remember that tenecteplase is just another version of TPA, just like alteplase was a version of TPA, retaplase was a version of TPA, lamoteplase. There's lots of different versions of TPA. In theory, it has higher fibrin specificity. It might be a little bit better, longer half-life, theoretically safer because it has this specificity, but I think the data would suggest that it's about the same as same as alteplase. But we do have a couple of interesting studies, both done in Australia. The first one is the one on the right, which Mark Parsons led, and they used, this is very early on. It's more than a decade ago now, where they 25 patients in each group, and they randomized patients to receive IV alteplase or two different doses of tenecteplase, 0.1 and 0.25, as you see there on the slide. And they found that in the 0.25, way more people had reperfusion at 24 hours. So again, not imaging early enough. On the left-hand side of the slide are the data from Bruce Campbell's study, which is the Extend IATPA. So what he did was patients were in a community hospital. They had a CT angiogram, proven M1 occlusion or proven large vessel occlusion, randomized to receive IV alteplase or IV tenecteplase, then shipped into Royal Melbourne Hospital for endovascular. Okay, so that was a drip and ship model. And the data here show you the first imaging assessment of the patient when they arrived at the Royal Melbourne. Average time was about a little over an hour. So the lytic had about an hour's time to work. And you see that with IV tenecteplase, they had about a 20% opening of the artery rate versus 10% with IV alteplase. So that's an hour's time. And that compares, it actually is rather similar to what I showed you before with Escape, because they had more duration of time for the lytic to work. So there's more dwell time, so to speak. The bar graph on the right is pooled data from the British test study and Mark Parsons' test study at 24 hours, showing you again that the arteries open up over time with lytic. But once again, I'd emphasize that's probably too late. So you don't get the arteries open. The bottom line about all this is you don't get, here's the actual numbers from Bruce Campbell's study, 20%, 22% versus 10%. But the bottom line is with the lytics, you don't get the artery open enough, early enough to make the difference, right? What else could lytics do? Well, there's this idea of cleanup, right? So you've heard about the no reflow phenomenon. We open an artery, but the microcirculation is not open. Or despite Eric and Ricardo telling you how great they are, when they do put up an aspiration catheter, they fragment all kinds of crap out to the distal circulation. They'll never admit it, but they do. And so the question is, what happens? What do you need? What do you need to improve that? And is that part of why some patients don't do well? Probably it is in some. I was teasing one of our fellows the other day because we did have a difficult case. It was a carotid eye occlusion, and when he went up to get out, it fragmented stuff all over the place. So he spent the next hour cleaning up all the distal occlusions. But we did look at this also in Escape, and we did find that there were only a small percentage of the time you did find that there were these distal occlusions. You could identify them on both the angiography and based on follow-up imaging at 24 hours. In the patients who got thrombolysis, they seemed to do a little better. There was less problem. Whether it's true or not, I don't know. I don't have the data to support it, but this is a theoretical reason why additional drugs might be helpful. I'll skip through that one. Finally, with the IRIS data which is the 6 trials which looked at going direct to angiography, or sorry, not direct, or just direct to EVT versus giving lytic plus EVT. So they randomized away from giving lytic. Those trials suggest that there's no difference, that it's non-inferior to go direct to EVT, yet the direction of effect favors adding lytic by a small margin, a few percent. For me, this fits with what we know about the existing data, right? That the overall benefit, if you have a cath lab immediately available, you get there, the overall benefit of adding lytic in the population is small, and that fits with what we know. So here's some interesting data on time. So speed's really important. We taught you guys, but you guys both emphasized that just now. On the graph on the left, these are interesting pooled data from the Australians again, looking at those. Do you give IV tenecteplase or do you give IV alteplase? And what happens over time in terms of does the artery open? So on the left-hand side, the y-axis is the artery opening or not. Again, look at the numbers. You're still small. You're in that 20 to 40% range. the top line is tenecteplase, the bottom line is alteplase. But over time, the probability that a thrombus will recanalize, even up to, 4 hours or so, you got 200 minutes along the bottom, declines quite rapidly. So the speed that you're able to administer a lytic impacts whether the artery is going to open or not, which then therefore impacts how well somebody's going to do, right? But the timing, you can see the numbers is pretty dramatic, right? Even over 20 minutes, Nima was talking about running quickly for patients. The speed that you give lytic matters. On the right-hand side is the graph from, again, this is from IRIS. So this is that, again, the pool, and you've got those patients who got IV lytic plus EVT versus just EVT alone, 6 trials. And this is Johannes Kasmacher put this together with Urs Fischer and the group and showed that it was only beneficial to give lytic if you could give it within about 2.5 hours. So you can see in the first graph, the first line there, the bottom confidence interval crosses just before 150 minutes there, right? So you're saying, so in other words, if you're at 3 hours, 4 hours, even 4 hours and a half, it's probably not that useful to give lytic if you're already going to go straight to EVT on average, right? This is on average. Remember, there's a lot of variance in individual stroke patients. But the point here is that even the thrombus is sensitive to the speed that you're going to deliver your lytic therapy. Why? Because thrombus mature, right? So last few slides here. Clots are dynamic, right? They are under pressure, right? There's 120 millimeters, or in a stroke patient, 180 millimeters of pressure on them, right? We want to, with a thrombolytic drug, we want to break up the fibrin, yet what's in a thrombus? There's red cells, there's fibrin, there's platelets, von Willebrand factor, which is linking all the platelets together. There's neutrophil extracellular traps, all kinds of biological things. We're only attacking one part of it with the lytic drugs, right? If you look at some of the data, these are data from Shai Nimji from Columbus, looking at what is actually in a thrombus. So here on the right-hand side of the slide, you can see nicely illustrated, the green is fibrin, the yellow is platelets, and the purple is von Willebrand factor, which is, as you know, a protein which links platelets together. It helps platelets form that net upon which the clotting system works. Fibrin is developed and that kind of stuff. So the histopathology shows that there's lots of different components to a clot, and when you pull them out of patients, we know that they have different properties, and they respond more or less to lytic depending on not only their age but what's in them, right? So we are working on, and I've been working with Shai to develop a program looking at a new compound. It just has a number right now. It's called BB031, really novel pharmacology here, and it actually interferes with von Willebrand factor cross-linking, so it stops the another part of the clot working. And in a mouse model of a carotid artery occlusion, you see here that it opens up arteries really, really well. This is a small trial showing control versus TPA, and you can see on the bottom the mouse arteries on the right-hand side under the red bars are wide open really quickly with BB031 after 15 minutes. In a large animal model, in a dog model, using angiographic injection of a autologous clot, the bottom line was the arteries were open, so they had 6 hours after 6 hours of having a clot in the artery, you could give BB031, and 75% of the time you got the arteries open just giving this drug. So it seems that disrupting the matrix, which is binding platelets together, may be an additional really useful factor in opening up arteries. So we're going to, you can see it going away there with the, if I can show that again. Okay, maybe you didn't see that, but we're hoping to use this compound to in humans. The pharmacodynamics look pretty favorable. After a couple hours, it seems to have largely resolved. And in addition, there's a reversal agent. So unlike, like we have with dabigatran, we developed Boehringer developed an antibody which would bind dabigatran, and then instantly it was all mopped up. So if you had someone who had a bleed associated on being on anticoagulation with Pradaxa, dabigatran, you could give an antidote. We have andexanet coming, but it's a bit more cumbersome to use for the DOACs. The same principle here. We have a reversal agent. So if something bad happens to the patient, you can instantly give a drug to reverse the anti-von Willebrand factor effect. So we're in the process of just starting. We've done a first-in-human study, and we're going to start a dose escalation safety study to give this drug to patients with stroke, and then move on to a larger study with a chosen dose. And hopefully we can get you guys involved in that study in due course. So I'll end there. Stroke doesn't change, right? It's still simple. You got to move fast. You got to get the drugs in quickly and incredibly quickly. Speed really matters. You need to run from the car. And I don't know, one of you guys had a really fast car, Lamborghini. Perfect. That's what you need to get here quickly, and you got to get the arteries open. So I'll stop and you guys can move on. Thank you. You want to take questions, Eric, or do you want to just move on to the next one? Yeah, any
questions?
Yeah. Lamborghini man.
Hey, thanks for the talk. I have a question. So, I mean, obviously it's early in the design, but probably you're going to design it in a way where the drug should be given only within 3 hours of last known well, right? Because beyond that, probably the success of recanalization, it's going to be less likely to be successful, right? Is that the thought behind it, or what's going to be what's the time window?
So I first thing I'll say is I think I don't know how you guys are feeling about stroke, but increasingly I don't care about time window. What I care about is what the patient looked like and what's the imaging look like. So I'm really interested in which artery is blocked and what's the parenchyma look like. And the reason I say that is we've got in stroke, we've got so hung up on time window because that was what was in the regulatory label for the original for alteplase, right? And the truth is that's not how the biology works. And the variance in individual stroke patients is huge. So I showed you those nice smooth graphs and stuff like that. Lovely, right? Beautiful, gives me the average thing. But if you actually look at the individual points on those graphs, they're all over the map. So I'm not so worried about that. But strictly speaking, in a trial design issue, at the beginning here, we're going to use the first trial we're going to look at, our outcome is going to be, is the vessel open or not? So it'll be a surrogate. In that situation, we're less concerned about time window for the initial phase of the trial. I agree with you. In the long run, we'll need to, largely speaking, look at earlier patients, right? That'll be whereas. But I really strongly encourage. We're so hung up on this time window issue. We need to move away from it. And it sounds like you guys are, because you in your study FastCath, you're not interested in time window. You're interested in what's the patient look like, what's the imaging look like, and which arteries blocked.
One more quick question. You
Yeah.
gave the analogy with the endovascular throwing clots distally and microthrombus. What's your experience with the TNK? Our experience with
Same. Like, I mean, thrombolysis, whether you use alteplase or tenexplase, I mean, this is one of the things that, I showed you. Again, I'm showing you data that from Bruce Campbell says, did the artery get open? M1 was occluded, and then we did a follow-up study. It's not the M1 was occluded, we gave tenexplase, and then everything was beautiful. It's
Sorry.
M1 was occluded, and now it's a distal M3, or now it's a distal M2. You see migration of thrombus all the time.
We're seeing more with that.
And of course, well, maybe we are, maybe we're not. I think what we're looking with alteplase, we didn't look, right? Now we have routinely available CTA. We're doing angios more. We're paying a lot more attention to what's happening to the vessels. So I'm less convinced that tenecteplase is somehow, resulting in a difference in what happens to those clots. But we are looking, and we're seeing that this happens. And of course, sometimes, as you know, that makes it worse, right? Someone's an M1, they've got good collaterals flowing back, and now you plug up a distal M2, and there's no collaterals there, and it's now an end artery, and you make the patient worse.
Thank you.
Yeah. Matt?
Michael, thank you. It was a wonderful talk. And as you highlighted in that one slide, I mean, clots are incredibly heterogeneous structures. So as a brilliant clinical trialist, I think ultimately the right solution is a cocktail, something that targets fibrin, von Willebrand factor, and NETs. And I think Bruce Campbell's doing a DNase trial. So my question is, how do you pragmatically test in a clinical trial a complex cocktail like that?
So, Matt, we've started a new initiative called Act Global. It will start enrolling, hopefully, maybe later this month or next month, in which we're following the lessons from COVID, and we've developed it's a platform trial, and we'll be able to do essentially N-way factorial design studies. So we'll be able to give lytic, go to EBT, give DNase 1, give BBO31 all together and assess the differences amongst those. So we're in the process of developing that platform. Bruce is doing the phase 1 study with the DNase 1, which is, is a drug used for cystic fibrosis. Can be safely given intravenously. DNase 1 seems to break up the nets. Once we've gotten through the phase 1 part of that, we'll be bringing that into Act Global, and we'll be giving it with lytic, 2 different doses of lytic, and we'll work it out. So I think that's the way you do it. You have to do it with a multi-way factorial design study to understand the interaction effects of the. So we'll just stay tuned.
Your cocktail cannot come soon enough. We're aging fast. Dr. Sauvageau tell you the tau protein deposit, if you don't sleep, is much, much higher. It decreases the turnover of the tau protein. So thank you, Michael. So I want to go back to your, Mohammed Soft alluded to that. We have a publication coming on that, anecdotal TNK breaking more clot. We've seen this with TPA. We've seen this by shaking the patient on the ambulance. Do you have any data in all your clinical trial, all the Calgary men and girl power, that this is real, or this is just smoke?
No, I think it was, maybe it started, Ricardo. I mean, you remember Andrei Alexandrov used to say this with his TCD stuff. We never really believed it because we didn't clearly, no one was good enough at TCD, with technical to really see, but we heard a lot about the idea that, oh yeah, the artery opened and then 15 minutes later it was closed again, or distally occluded, and there was a change in the ultrasound signal. And we don't have any other way of dynamically monitoring the thrombus other than what you see it at angiography, right? We assume that things that happen are related to mechanically putting a wire through, or a various catheters and things happen, but some of it may be the lytic as well. There's lots of times when I've given a lytic and then you come to angio and then it's changed. It was an M1, now it's an M2 or it's an M3. As you say, the bumpy ambulance ride, like for us from the mountain, someone's 2 hours from us. Nothing like, man, getting lytic on board and going on a bumpy road and then by the time they get to you, everything's open. Yeah, totally. I think it was there with alteplase. I just don't think we looked as much. Possibly, possibly the fact that tenecteplase has a longer functional half-life allows this to be more evident. I don't know. I'm not sure. I do think though that there's a bias. We are paying a lot more attention to what happens to the artery, right? Whereas we weren't before.
But there's also the fact that tenecteplase seems to open vessel more efficiently. So if you do that, obviously you probably increase indirectly the risk of distal emboli.
Yeah.
And contrary to what you mentioned, we're well aware of distal emboli and endovascular. And this is
Eric, I know that.
This is where, still to this day, I think the worst thing for us is NIH of 1 with the M1 occlusion. And a lot of time people say, oh, but the truth is that you can make those patients worse.
Yeah. No. Well, we'll see. I'll just share some data with you that we just finished the Tempo 2 study in which we gave randomized patients to receive tenecteplase versus control with minor stroke. Right, so minor, they all had NIH less than 5, and we were stopped by the DSMC because it's totally neutral. There's no benefit whatsoever. We had over 100 and so M1 occlusions in that study. No benefit, nothing. It's absolutely flat. So I'm not sure that I'm pretty sure Endo Low will be a neutral trial on that basis. And I think we have to be careful about this, right? For the reasons that you say, because it's not that you can't get the artery open, it's that enough times you make somebody worse that you get into trouble.
So I think my very first lecture at your meeting 8 years ago was about distal emboli during thrombectomy, and we measure it. And these guys may say it doesn't happen, but there's hundreds of thousands of very small emboli being launched into the microcirculation. What do you think about choice and about, I mean, I know it's a small study, but about giving post EVT intraarterial thrombolysis?
I think should be tested. I mean, I don't believe choice. The effect size was far too large to be real. And remember, the control was not saline. The control was and this is one of the reasons they stopped. Everyone forgets this, right? The control was arginine in solution, and that's why they had to stop, because they couldn't obtain the control. If you deliver L-arginine to the circulation, you know, maybe that turns out maybe that's bad. It's theoretically it's a nitric oxide donor. It should be opening arteries if you give L-arginine, but I don't know. That's one thing we people, again, chemistry. Excuse me, both tenecteplase and alteplase are packaged in about 4 grams of L-arginine. So when you mix up and you reconstitute it, you're giving not only the lytic, but you're giving a big bolus of L-arginine, which is a nitric oxide donor, which should open up arteries, right? It should result in opening of the, sometimes you see that you get a little drop in blood pressure when you give your first bolus of lytic. And the reason is you're giving a big nitric oxide bolus, like it's like giving someone nitro paste, right? Slapping it on the skin. That's what you're doing. It's short-lived, but you know, I don't know. I mean, I wonder whether the placebo was bad. So but should it be tested? Sure, it should be tested. We should see. Yeah.
Thank you, Mike. I
Okay,
think
super good.
we're gonna move to the next one. Thank you. We have a little change on the program. I don't know if that was projected earlier. Rono Gary's on a little bit late, and Matt Gunas, frequent flyer here with us, professor of all matters at University of Massachusetts. The Brazilian has to slow down to say that. Matt is a friend from many dawns ago. And he's going to talk to us. Seeing is believing, another genius idea from his lab that can potentially impact us. Matt, thank you again for being here.
Ricardo, Eric, Nima, thank you so much. It's been an honor to be a frequent flyer here at this meeting, and just so much admire what you've done with this program, and inviting people like Professor Hill from Calgary, and in the past, Professor Saver, and all the, myself and AJ Waklu. What you're doing for your community is amazing. And that's one of the pillars is education. And so I'm going to talk today. I changed the title because when I gave Ricardo this title a couple of months ago, I thought I would have more data, and I don't. So actually now I'm going to pose the question to you. I'm going to show you what we're doing, and I want to ask you the question, to see or not to see, do you think it really matters? And this talk actually goes really well with Professor Hill's talk that just came, because instead of doing a thrombolytic, I'm going to try to do an imaging agent that links to the clots. And by the way, thank you very much, guys. You gave me an honorary MD. I'm not an MD, I'm an engineer. And I've been focusing my career on preclinical modeling. And we always get banged because we say that in our preclinical models, everything works. And then it goes to clinical trial and it fails. But if you flip the question and you look at the two things that actually do work, which are revascularization strategies, one being TPA, showing here on the left, Justin Zivin and Mark Fisher did this experiment at UMass in the 1980s, where they showed in a rabbit model of stroke that giving TPA actually improved neurological outcome after that stroke. Fortuitously, AJ and I were working in the lab and we were coiling this pig aneurysm, and the artery clotted off. And the reason this is fortuitous is because the day before we had done a training program on a new closed cell stent called the Enterprise stent. It was the first closed cell stent that was introduced into the market. And AJ had this crazy idea. He said, grab that stent and let's see if we can't pull the clot out. And this was the first picture of a stent retriever thrombectomy that Thomas Liebig showed at Val d'Isere that same year. And a bunch of Spanish guys said, hey, we have closed cell stents. Let's go pull clots out. And so in 2009-10, they published their first series of 20 patients. So I was funded by the NIH in a 2007 timeframe, and I've presented this picture for 8 years at this meeting. So I'm just going to briefly go over it. Our model system for simulated use thrombectomy, and it starts with a vascular model. We take medical images, we create a computer model of that, we send it to a rapid prototyping machine, and from that we build what you're seeing here. It's basically a mold. And we inject plastics in it. Actually, more recently, we're using hydrogels, which are really impressive because they look and feel just like an artery. But currently, we're using silicone. And so we get a vascular model. And we've really upped the ante. So now we take patients with really complex anatomies and we stitch them together. So we try to make the thrombectomy procedure in certain anatomies almost impossible. So you can see here are more complex models that we can print out and do simulated thrombectomy. And then this is a case AJ did in 2008. It was using a penumbra aspiration system. He sucked these clots out. For the first time, our PhDs took stroke call. And by the way, that permanently cured them from ever doing what you do every day. And so they went to the cath lab, they grabbed these clots, they took them to a mechanical testing laboratory, and we did what's called dynamic mechanical analysis. So basically what you're seeing, these are all clots from patients, and you're seeing their stress strain. Clots are, of course, viscoelastic. What that means is it's not a line, right? It has a two-phase curve. So you see that there's a lot of range. These are calcified clots, so they're really stiff. And these are more elastic, fresh clots, and then you have everything in between. And we also did what's called stress relaxation, which is we measured the propensity of these clots to fragment. Now, why did we do this? We can't do our testing on clots from human patients. We'd never have enough specimens to do the thousands of thrombectomies that we do every year in the bench. We did this because we make clots in the laboratory. We use our own blood, we use bovine blood, porcine blood, and we mix different things inside of it, fibrinogen, calcium apatite. And what we're doing is understanding where our clot analogs are in the human spectrum. So we can make really tough clots to get out. So we can really test worst case scenario for how to get a clot out. And then what do we do at the end? We connect this to Chester. Chester is our model. Chester has a heart, a cardiac pulse duplicator. We plug our model in, we introduce the emboli, we perform the thrombectomy procedure, and importantly, we measure all the effluent. And I'm not going to talk about that because I've been telling you guys about that for 8 years, but we measure all the distal emboli that are generated during the thrombectomy procedure. And so here's a simple case where you have, you introduce the clot. We have another feature that you guys don't have is we can measure simultaneously all the pressures and flows. So we get all the hemodynamic information from our model. And here's a picture I want to show you. So this is an aspiration. We're pulling on this clot. Now I'm going to pause the video here. You're seeing that clot. What we've done is we basically corked a little piece of the proximal aspect of the clot and we're pulling on it. And what you're seeing is that clot stretching, stretching, stretching. I argue that if you could see this clot and you could see this phenomena, you would probably stop and say, listen, I'm going to break this thing. I'm going to fragment it distally. And then maybe opt to do another procedure like put a stent retriever to get the distal aspect of the clot so that you could potentially have a better. And this is something I'm just proposing to you. I actually want your feedback. So of course, what you're seeing is we're stretching. Of course, the clot breaks. And now we have a saddle embolus in the distal M1. Another observation, and by the way, these are supportive data to my hypothesis, which I think are incredibly weak, but again, they're here. So this was our very early experience, 2012, in our model system. And you can see with the stent retriever, the solitaire system, we had 100% recanalization after 3 passes. With penumbra aspiration system at that time, we had around 80%. And with Mercy, we had about 65%. Now, if you look at the clinical data, we were consistently beating the numbers from the clinical data. And these are with rather complex models. So I had this idea, why are we better in our simulated use experiment than we are with our clinical data? And I thought, well, maybe it's because we can actually see the clot, right? And you can adjust your technique because you see what's happening with the device and the clot together. And you can say, wait a minute, I got to go slower, for example, when I'm going through the siphon because the clot is rolling off my stent retriever. Just a hypothesis. So clot visualization for diagnostics is not a new field. I work with Peter Caravan. He's at the Martino Center at Harvard. And he's been doing work for years and has a clinical trial ongoing with a peptide that targets fibrin, and he labels that peptide with copper-64. So that's a PET imaging agent. And you can see here, looking at left atrial appendage thrombus, that in yellow, it glows. The thrombus glows. And you see a negative case. And this is all confirmed using transesophageal echo. So this is a great potential, but unfortunately, we're not using PET to pull out clots, right? So using a nuclear imaging technique is probably not ideal. This is work I saw and it really excited me. I saw it at the stroke conference about 10 years ago. This is out of Korea, where they take gold nanoparticles. Gold does attenuate X-rays, and they conjugated it with fibrin binding peptides. And so this is a CT-based contrast agent. And I want to point out this bottom picture here. This is a mouse, right? And this is a thrombus introduced into the middle cerebral artery, actually the internal carotid artery extending into the middle cerebral artery, and it glows. I got so excited about this for the last 10 years. I happen to work with a chemist who's like got patents on how to make gold nanoparticles. We've been conjugating them with peptides from everything, and we could never get enough attenuation so that you can see these things on fluoroscopy. CT is one thing. Fluoroscopy has different technical parameters. You have to attenuate many more X-rays in order to be able to see it on fluoroscopy, and this failed. The other thing is there are some issues with fibrin binding peptides. First of all, they're not very specific. They also bind to fibrinogen, so they may not work. And as Dr. Hill just showed, even alteplase, which is like a 50 kilodalton, so extremely, extremely small, doesn't effectively, in all cases, get through the clots, large vessel clots, right? So that means fibrin is not necessarily readily available. Simon Demare was one of the first to show that clots that cause stroke are abundant in what we call neutrophil extracellular traps. This is when neutrophils get stimulated, usually by platelets, and they secrete their DNA, their chromatin. And amongst that is a lot of things. It's a protective mechanism. So there's myeloperoxidase, which is basically like bleach for the body. It kills lots of microorganisms. I don't know why that advanced. It has neutrophil elastase, and it has citrullinated histones. So this is our work, and we have a clot bank. Every thrombus that comes out of people's heads, we collect. And what you're seeing here is H&E. And of course, you have a stained nuclei, which is what you're supposed to see in blue down here. But you see how this blue is extended? These are nets. This is secreted chromatin from the neutrophils. And we know this because we co-localize it. This is MPO, and you can see in blue is the nuclear material, and in green along that blue is myeloperoxidase, which is secreted. These are granules secreted by the neutrophils. And here you see neutrophil elastase, and again, it's co-located with the DNA. So here's our idea. I'm actually getting close to the end, and I really want your feedback. So we're taking a very old technology. These are lipid vesicles, also known as liposomes. It's a dual layer of phospholipids. This is a drug delivery mechanism, and you probably have heard a lot about it because this is how mRNA vaccines, like the COVID vaccine, are being delivered. They're very safe. They've been around for a long time. And what we did is we put, first of all, a click linker, which binds to the citrullinated histones and nets very selectively. And we load it with ihexidol, right, which is a hydrophilic contrast agent. Well, when we did that, this is the fluoroscopy image. And by the way, these particles are around 150 to 200 nanometers. When we did that with just the ihexidol, we can see it under CT very well, but we can't see it under fluoroscopy. And by the way, here's the control. Here's your reference. This is a high concentration of ihexidol, which is basically the contrast agent that you use for doing digital subtraction angiography. Well, my postdoc, I have a great postdoc from the Technion, and he said, well, wait a minute, what if we double load it, right? You have the shell here. So what if we put a hydrophobic contrast agent in this shell and basically create a double contrast a lipid vesicle? And indeed, when we did that, we now can finally see these things under X-ray. So fundamentally, and this is just showing you the binding affinity. So when you have activated neutrophils, which we know that we have in clots, our lipid vesicles have high binding affinity with our click linker. So these are all very preliminary data. And here's where I want to end. So I also need your help for those of you who sit on NIH study sections. We submitted this a year ago. We got the feedback. The #1 complaint is that thrombectomy is an optimized procedure. We're done. We don't need to do any better. You guys write all these papers that show how amazing the effectiveness is. By the way, another thing I really hate, thrombectomy is the easiest thing we do. That's often something that I hear, and this is really hurting us from being able to move the field forward. Because let's be honest, first pass effect in self-adjudicated data is 50%. We all know that self-adjudicated data is overestimated, so it's probably closer to 30%. So that means we can do a lot better with our first pass effect. So what we plan to do is further characterize these lipid vesicles, do simulated use experiment. Our hypothesis is that if you can see what you're working on, you're going to be more effective at getting a first pass effect, and then confirm this in an animal model. So I guess my question, and I really would like your feedback, do you think if you can see what you're actually working on, and there's a number of interventionalists in the room, if you think you could actually see the clot, do you think you would be more effective at your thrombectomy? And by the way, this, I have to highlight this. I'm not a chemist, I'm a mechanical engineer. Alex Bogdanov has done the invention of this technique, working with my postdoc, Mark Epstein, who's really been focused on this project. Thank you. Oh, and by the way, if one thing, a really important thing I forgot to mention, if you fragment the clot, Dr. Hill was saying that we can't always see them, and that's absolutely true. But now if they're radio opaque and I do a CT, I promise you these distal emboli will glow.
Thank you, Matt. Always fascinating. So I'm a bit curious. So if you give this molecule, how would it mark the distal end of the clot? I mean, I understand the interface, but you expect that you would be able to mark the entire clot, even distally where there's really no blood flow or really indirect collaterals, or?
Yeah, no, it's an excellent question. So we do plan to give this intraarterially just because it's really expensive to make, and we don't want to give it systemically because it would be too expensive to do that concentration at this point. Secondly, we think that they penetrate the clot, and we do have a flow model where we put these emboli in a saddle embolus and we inject the material, and they do, because they're small, they're 150 nanometers, they do penetrate the clot. One of our strategies, because that's absolutely one of the big questions, one of our strategies is to microcatheterize through the clot and then inject the contrast agent as we pull back. Unanswered right now.
Thank you for a great talk. I think a very provoking thought that you asked. So to answer that question, at least for myself, I must say, there are other evidence out there, right? So for example, at ISC, there was a, I think Mark Rubu presented, when you have a clot in a bifurcation, right? So M1, M2s. Well, if you go to one M2 and M1, well, what's going to happen to the other M2, right? The idea was in a bifurcation, if you put two stent retriever, then you can remove them more effectively. Same for ICA terminus. So if you have a clot at the ICA terminus, how do you know for sure that the clot is not partially in A1 and partially in the M1? So I think if I can see the clot, I could potentially adopt my system, stent retriever versus whatnot. So I think the answer to your question obviously has to be proven. I do think that you can modify your system. And saying thrombectomy is easy, I do hear that, and we say it. I think we talk about the challenge to get the patient on a table, but we all struggle. When you have a clot that goes this way and the other clot goes that way, and some of the hard clots. So I do think that we can push this field forward. So thank you for that.
I think I agree with you, Nima. I think when you hear thrombectomy is easy, just keep in mind that we're dealing with somebody that is going downhill quick. So to treat a patient that is dying, the downside of a complication is much lower than to treat an unruptured asymptomatic aneurysm that is walking in perfect. It doesn't mean one life is more important than the other. The uphill for that patient that is dying is significantly higher, so a complication is more tolerated than if somebody's walking in perfect. I treat a lady Monday. She came back yesterday with a hand weakness. She was perfect. I gave her a left hand weakness. We're doing a thrombectomy. This person's plegic and aphasic. He's walking, maybe not talking. We're happy that he improved or she improved. I think there's tons, Matt. I think we need to organize this data better. I think there's tons of data out there that thrombectomy is far from perfect. And I think if we could see the clot, we joke with this every time we work in a model with a new gadget. I think it's so nice that you can see the clot, so you know where to go and grab. Again, Sansom, OCT, Vena, all these little new things coming to see the clot. I think they would enhance our ability to treat that. But I think there's a body of literature there that you can build, and I know you've done that, to build on your NIH to show that. And again, that's something that we can easily put in our Raul is going to be here if he's not somewhere in the back. iCure, that's a great venue to discuss that. SNIS. So I think we can put this in there and say, okay, is there any room for improvement in thrombectomy? Now you know the answer. The answer is going to be yes. So
I have another question. You had done some work in the past. So you know, until recently, I mean, a lot of time to bring the intermediate catheter, you know, you pretty much, a lot of time the stent retriever would help a lot bring that. I've always had the, I would say, bias that, you know, if I'm having a stroke, I want everybody to take the entire kitchen sink and everything that come with it. Stent retriever, aspiration catheter, and proximal balloon. Obviously now it's changing with us being able to deliver without, you know, without stent retriever to bring big catheter in the brain. But there's still, I mean, with the huge 88 catheter, the lollipop is probably way less. But I just want to say, I'm sure you play with this like in your model. What about distal emboli with a huge catheter like this? Because there's always a concern with the collapse of the distal vasculature. Like, you know, is there still breakaway of the distal pieces, or in your models, it seems to be taking care of this?
So let me show you what I presented last year here, innovations. I think this is the right one. No. I don't want to waste a lot of time. So yeah, we have done that. So based on our simulated use experiments, we have always followed the data based on our distal emboli at our shop. So Ajit comes down, he works with us, he looks at the data. We were 100% proximal balloon guide catheter, aspiration catheter, stent retriever. We call it, you know, seatbelt and airbag, belts and suspender. Really believed in it based on our data. Our data showed that that was the best way to effectively reduce distal embolization and have a high first pass success rate. Here we go. So we're now 100%.
Guys, show this slide.
Oh, thank you. So now we're 100%, I mean, inappropriately selected cases, of course. We're 100% super large bore aspiration, and I'll show you why. So I'm having okay. PowerPoint's not cooperating. So here is that case I showed you on the top. That's a 72 where you did the proximal biopsy sample and you try to pull the clot, and basically the clot falls apart because you're pulling forces and you're relying on the adhesive forces of the clot to resist that. Let me show you an 88 case. So here.
Can you stop there just to go back to your question? What you're seeing the clot, right? So imagine all these gadgets that we use. I think I'm ingesting. We're about to start a new Zoom, a new 88 version similar to Zoom, Sophia, Millipede. Okay, 2 minutes to ingest the clot. Okay, I think in 2 minutes I'm gonna ingest the clot. Am I ingest the clot? What Eric alluded, am I at the face of the clot and the vessel is not collapsed? Oh, I'm sucking, there's nothing coming. Yes, I'm at the face of the clot. We don't know that. We think we know that. So that goes back to your the title of your talk. I think you alluded to that, and I think that's super nice.
No problem. So what I
Great
show you
illustration.
on the bottom. So on the bottom, you're seeing an 88 aspiration. And here we go. So you can see the device being delivered to the face of the clot. The large bore catheter is now coming close to the face of the clot. And just by pulling out that plunger on the inside, it's like actuating a syringe. So you see that the clot is complete ingestion. And the important thing are the data, right? So this is just first pass. This is our fibrin-rich clot. Basically, nothing works on it. This thing is like chewing gum. It's dense. It's basically a strong fibrin structure. With this 88 aspiration, we're getting 90% of the clot completely out. So complete ingestion of the clot where it's not being corked and pulled in this really fibrin-rich clot. You can see here with a 70 system, it only happened once. With a 68, it only happened once. With stent retriever and BGC, we still did pretty well, but we still have some problems. This is Eric's question. So basically, the ability to get complete clot ingestion is an exponential function of internal diameter. This is Eric's question. If you completely ingest the clot, your number of distal emboli are pretty much nothing. I mean, there are some. There's never such a thing as a perfect solution, but this is like 1 or 2 between 200 and 1,000 micron. and a few super small ones. But if you look at the things larger than a millimeter, which would be your M3 occlusion, there's nothing. So it dramatically reduces the amount of distal emboli.
Just to go back to the seeing is believing. Rarely we have to retrieve coils. I was placed in a situation to retrieve a web out of a P1 on a slice by Vince Constellat. And occasionally we have to retrieve onyx. We had to do that at WNC. You're seeing what you're going after.
Right.
So you strategize for that. So if you aspirate and the clot is stop pulling, you're going to break the clot. You're not helping yourself. If you go beyond, we use a Raul and Diogo published, right? Longer stent retriever,
Right.
better.
Do you know why? The clot's always rolling on the
Roll and you
stent.
have more
So if you have
opportunity
more
to catch.
length, you're
But
gonna-
if I can see that I'm catching, do I need a 60 millimeter scraper to catch an 8 millimeter little fish? I don't know. If I can see this clot, I'll be able to design better things that can help me avoid this break. So I think this, if this works, man, I think to be. So I think that's, you got to build on that direction.
Tomorrow, we're having a panel, right, about using optical coherence tomography for cerebrovascular disease.
Yeah.
And when you can see what's going on, I think in every single case, it changed our treatment plan. So that I really do believe that the optic nerve goes to the most important part of the brain. We are visual people, period. And Dr. Hill, when we get this thing working, we'd love to work with you to load these vesicles, not just with contrast agents, but drug.
With the cocktail. Any more questions, guys? If not, Abby is bombarding our cell phones that she wants to break. So everybody needs a bio break, coffee, and others. Thank you, Matt.
Thank you.
We're actually back at 10:15, guys.
likelihood of doing better, okay, than if you don't have thrombectomy. And it gives you about a 2.7 times higher likelihood of going back to full independence at 3 months. The good thing here is most of the patients that are treated with thrombectomy in their early window, at least for mild to moderate size strokes, most of them benefit regardless of location of the clot, the intensity of the stroke, or the age. Then the second wave of trials came. We expanded the window from the early time, which is 0 to 6, 0 to 8 hours, all the way to 24 hours. 2 trials, the Dawn trial that Ricardo participated, and the Diffuse 3 trial. But we actually put all these trials that enroll patients beyond 6 hours together in the so-called Aurora meta-analysis to then show you the same thing. You are a lot more likely to do better if you have thrombectomy. In fact, you see that same number here, about 2.5 times higher likelihood of having any improvement in your MRS at 90 days if you have thrombectomy. And here your chances of a good outcome of full independence at 90 days is even higher, 3.9 times. The bulk of these trials use advanced imaging in the late window, so you see this very, very big treatment effect size. We're gonna discuss a little bit about what happened after that. The other thing again here is you can see that this dramatic benefit happens in pretty much all the population, regardless of age, whether it's earlier or much later in time, and the intensity of the stroke. Then you had the basal artery occlusion. And the basal artery occlusion was a tough one. There was a lot of issues because this is a really bad disease. Many people have terrible outcomes. As many as 80% of the patients were known to have dismal outcomes, potentially die from this. So there were a lot of issues with equipoise, a lot of work coming from China in big registries. This registry here with over 800 patients, this other one with over 2,000 patients showed that there was a very good signal that endovascular therapy would be better than the medical treatment alone. But now we have a meta-analysis of a total of 4 trials, out of which 2 were inconclusive. The BEST trial in China and the BASICS trial in Europe and Brazil were inconclusive, but then you had 2 highly positive trials in China, the ATTENTION trial within the first 0 to 12 hours, and then the BIOCHI trial in the 6 to 24 hours. When you put all this data together again, you show that endovascular treatment gives you much better outcomes with the same number again. Here is a different outcome as MRS 0 to 3, but again, around 2.5 times higher likelihood of doing well with the treatment. So when you look at functional independence, you can see that number is 2.5. You look at shift, it's 2.1. And there is a price that you pay with thrombectomy as very much like intravenous thrombolysis. There is higher chance of symptomatic intracranial hemorrhage, at least in the posterior circulation. And In basal artery occlusion, this typically does not happen in anterior circulation, small to moderate strokes, but in basal artery occlusion, there is actually a benefit in terms of mortality, okay? We sometimes say that the thrombectomy is a life-saving procedure. That's not quite correct. It is more like a disability-sparing procedure rather than a life-saving procedure. The exceptions are basal artery occlusion, potentially the very large strokes, and the ESCAPE trial demonstrate that potentially the elderly patient actually has a benefit in terms of mortality. But in general, you don't change the number of people that stay alive, which is a problem. Because if the same number of people stay alive, what is happening if you don't treat the patients is more people stay alive, but with higher degree of disability. And this actually has a much higher socioeconomic impact than many of the other conditions where people die, like MI, sepsis, or trauma, okay? So the financial implications are actually bigger because it's mostly a disability sparing. So you need to be aggressive to decrease the disability because it's a big financial burden. So moving now to the new frontiers and controversies. Where are the controversies? So there are two ways of looking at this. One is you can expand the pool of patients that you want to treat, right? To increase the number of people, treat more patients. The other way of optimizing a treatment is improving the outcomes of the patients you are already treating. So in terms of expanding the pie, right? One possibility here is the low baseline, like the patients that you think are too good to treat. There is the ENDO-LOW trial ongoing, and there is the MOST trial ongoing now to answer this. GIST occlusions, we now have the answer for the large cohort trials. Ricardo is going to be talking about these trials. And then the late presenting patients, remember I talk about the wake-up stroke trials, the late trials, down diffuse 3, but they use advanced imaging. Well, we now have trials without advanced imaging, specifically MISTRA Clean Late and Resilient Extend, but some of the large cohort trials also tap into that area. And you know that in the 6 to 24 hours, you no longer need CT perfusion or MRI selection to treat patients. So starting with the mild strokes, this is actually a very common problem. It's estimated that about 60% of the US patients have these mild strokes, meaning NIH 0 to 5. It's responsible for as many as 40% of all cases of intravenous thrombolysis and about 11% of cases of endovascular therapy. So it's a common problem. The bigger problem here is what to do if I have a mild stroke, but I have an LVO. And that is still a common problem. LVO is present in about 1 to 2 out of 10 patients with low NIH stroke scale. And the importance is that if you have a low NIH stroke scale, but you have an LVO, you are 10 times more likely of deteriorated or deteriorating over time. So those are the patients that may be good to treat, too good to treat, and you may want to pass 2 in the afternoon, but then 2 in the morning, they may deteriorate. And then if you treat at that time, you may not be as efficient and the outcomes may not be as good. So it's important to understand this race, right? When you have a large vessel occlusion, the only reason why you have low NIH, low clinical deficits, okay, or I should say the main reason is because you have good collateral flow. Then it becomes a race. It becomes a race between your collaterals failing or the vessel recanalizing. And whether it recanalizes spontaneously with intravenous thrombolysis or endovascular therapy, it doesn't matter as long as you don't have a problem. So the outcome will depend on who wins the race, right? If you have reperfusion without hemorrhage before collateral failure, you're gonna do well. But if your collaterals fail before you recanalize, you're not gonna do well. Or if you recanalize but you cause a problem, you're not gonna do well. So what to do in these patients? There is a lot of controversy. Our group favors doing thrombectomy in some of these patients. We have published about this. Other groups, including Mike Hill group here, has written that this may actually be detrimental to patients. So there is a lot of controversy. And what you need to do when you have controversy is find the right answer, right? Is to do clinical trials. Well, the ENDOLO trial now has about 110 patients. It has had overall slow enrollment, but it's moving. The French trial is actually doing a lot better. I think they have over 400 patients. So hopefully over the next 5 years or so, you're going to have an answer for this. The Temple 2 trial, which is a trial that Mike Hill is involved with TNK in this population with low NIH, has just been stopped prematurely. Hopefully, you're going to hear the results soon. This is for intravenous thrombolysis. The other two are for thrombectomy. But what to do now? We see these patients in clinical practice. What to do now? Well, you have to balance the risks and benefits. So the patients that I believe have a higher procedure risk are the patients that have a lot of tortuosity, patients that have intracranial atherosclerotic disease, patients that have calcific clots. So my threshold to leave these people alone is actually lower. I tend to observe this, everything being equal. However, there is also the risk of collateral failure, right? So yes, my NIH is 3 now, but when I was in the other hospital before transfer, it was 13. And I still have that same M1 occlusion. Your NIH is fluctuating, unstable collaterals. Maybe this is a patient that will deteriorate. You also know that the more proximal occlusions, intracranial ICA, proximal M1, deteriorate more than distal M1 and M2. Finally, if a patient has a blood pressure of 180 and NIH of 2 or 3 now, what happens 2 in the morning if that blood pressure drops to 140? He can no longer keep the collaterals, right? So the autohypertensive patient is a patient that makes me nervous. The clinical stress test, I think it's great. You typically examine patients lying flat, right? How about if you sit the patient up and exam 5-10 minutes later? If the patient deteriorates, I think it's probably a patient you want to treat. It's impending collateral failure. And there may be certain CT perfusion criteria that may be helpful also in figuring this out. So pending randomized clinical trials, I think it's balancing the risks and benefits. But what's very important is to explain to the family that these are uncharted waters, right? You don't know what to do for sure. What you can do is do a good clinical assessment based on this, but discuss, the implications with the family. Distal arterial occlusion, I believe maybe Mike Hill is going to talk about this. We don't know if you should be treating these patients, but it is also another common problem. Maybe 25 to 40% of the patients will have some sort of more distal lesions. I am a big believer that the solution for this problem should be intravenous thrombolysis. Smaller clot, come on, you should be able to fix that problem. It's different than an LVO where you have a big clot, right? We are actually doing a trial right now in Brazil called Resilient Extend IV, where you're giving thrombolytics beyond 4.5 hours in the hopes to show that's the way to go. But what the data tells us is that less than 50% of these patients with distal arterial occlusion, even though they have small clots, less than 50% of them will recanalize or reperfuse. So what are the implications of that? Well, 1 in 3 to 1 in 4 will then not achieve full function independence at 90 days. So not a benign disease. IVTP is not a panacea here. So we should try to do better, okay? And I think we have the resources. We have the technology, smaller stent retrievers, small aspiration catheters, thrombolytics to dissolve these clots. And here is a case that I think it says it all. Young man, 46-year-old, has an NIH of 5 with a distal ACA and a very small MCA occlusion. He has plegia of his leg, okay? So his left leg is plegic. He gets 4 points for that, okay? So the NIH is 5. This is a low NIH situation, distal occlusion situation. But if you can't walk at 90 days, your MRS is going to be a 4. So the baseline NIH stroke scale, it's not necessarily all the time an index, okay, of your disability. So don't treat numbers. Understand what that number means. In this case, it means that this patient cannot walk. Well, you may say it's over-aggressive to go for a distal ACA clot. Well, we have technology to the point that we treat aneurysms here with flow diverters in patients that walk to our clinics are completely normal. So what's the hesitation about doing endovascular therapy in someone who can't walk, right? It just doesn't make sense. So we've been treating these patients. Many people have aggressively, and obviously this is someone who had a good outcome, but the message here is patients do not care about their site of occlusion, about their NIH, have no clue what this means. The only thing that patients care about is the degree of disability they'll have to cope for the rest of their lives. So if you want to have a patient-centric approach, yes, you need to tell the patient, listen, we have experience with this, we've been doing this, it's an unproven treatment, but you have a bad deficit, and I think it's reasonable to treat. However, there will be blood, there will be complications. The farther away you get in the cerebral vasculature, the smaller and more tortuous the vessels are. And here it is, in my book, something that I learned in the painful way. The ACA, PCA, and inferior division distal branches, they are good. They are straighter vessels. It's easier to treat. But these guys here, the distal superior division MCA branch, they are very tortuous. It's like a roller coaster. So you have to be very careful with mechanical thrombectomy here. You can have perforations, problems like this. This is not one of my cases, but I have had similar cases, and it always happens in my experience, not only mine, but observing. This is an area where you have a higher chance of problems, is the very tortuous superior division. So again, the decision-making here, pending the trials, is risk-benefit. And I would say the risk is defined by the vascular anatomy, but not by the distance. I don't really care about the distance very much. It's about the tortuosity, then the caliber, then the distance. Obviously, you need to have a tissue that it's eloquent enough and vibrant enough to justify the risks of the intervention. But again, pending data, we need to make our best balanced clinical judgment. There is some good safety, there is promising data from several different groups. This is one of the papers, and there are, thanks God, several randomized clinical trials ongoing, including the ESCAPE MIVO from our colleagues in Canada. We just started DUSK trial recently, and the distal trials, I think distal and ESCAPE have about 300 to 400 patients already. So chances are within the next year, we're gonna have an answer about this, hopefully a positive one. Ricardo is going to talk about the large infarcts. So we know there have been 6 trials. We skip this just to say that the outcomes aren't great, okay, but they are better than not treating the patients. Some of these trials have shown a potential benefit in mortality. This is very, very important. You do not increase the chances of being alive but bad, okay? The 4 and 5. So the risk when you treat a bad patient, right, is you move that patient from dying, which sometimes is worse than having MRS of 5, right? This does not happen. Just want to give that message. And the other message is, how come you help people if they have already a very big infarct? Well, the problem is you think about the size of the infarct. You need to start thinking about the quality of the infarct, okay? It's this idea here that you can go from the white, which is the normal brain, all the way to the black, completely dead brain. But there is a lot of infarct brain between that it's in the shades of gray. And here is an example where you have a large infarct, okay? But there is a lot of islands of preservation of white matter and even neuronal preservation here. And at 6 months later, yes, this is a big infarct, but it's very different than this patient that was not treated and has a black hole. So this is a smaller infarct than this, okay? However, it is a complete infarct, and this is an incomplete infarct. So it's not only size, it's the depth of the infarct, it's the quality of the infarct. That's why I think you can't only think about one dimension. In fact, two of the studies, SELECT and TENSION, did not even show a difference in the final infarct volume, right? And in this trial show a benefit. So Ricardo is gonna talk more about that. I'm just gonna move into what else you can do in this field to improve outcomes of our patients. You can add intravenous lytics, you can remove intravenous lytics, you can add antithrombotics to endovascular therapy. The IRIS meta-analysis, you're gonna discuss about this whole idea of bridging or not bridging. We talk about the fact that these trials use alteplase. You have now trials using intravenous TNK prior to thrombectomy. The timeless trial tried to add lytics after 4.5 hours. It is safe, but there is no benefit. There are new lytics being studied. We are looking at actually giving IA lytics after the reperfusion treatment to clean up the microcirculation. And also adding antithrombotics after the thrombectomy treatment. The most trial tried to add argatroban and eptifibatide. It failed, but there is a trial in China called Rescue BT that showed that tirofiban, specifically in patients with large vessel occlusion, may be beneficial. Finally, you have better devices and techniques and simplifying imaging paradigms and adding things like neuroprotection, cooling, flow augmentation. So this is the IRIS meta-analysis. Here, I just gonna simplify by explaining this whole idea of should I give TPA or not give TPA only applies, okay, to a thrombectomy center. If the patient's in an outside hospital, you're doing a telestroke consultation, the patient has to get TPA. Also, it only applies if the team is immediately available to do the thrombectomy. If it's gonna take another hour to get that thrombectomy started, it does not apply. You gotta give the thrombolytics, right? And the other point, as I said, is you haven't tested TNK yet, but you have 6 trials, and here is what these trials show. There is no big difference in outcomes whether you give lytics prior to thrombectomy or not. There is no big difference, okay? However, there is no harm. We don't increase the chances of symptomatic intracranial hemorrhage. There is more any intracranial hemorrhage, but that typically doesn't affect outcomes. And there is a potential benefit in terms of recanalization prior to the procedure and at the end of the procedure. So I think everything being equal, very reasonable to do thrombectomy. However, my hope for the future is that we don't go yes for everyone or no for everyone, is that you apply the principles of precision medicine, you individualize the case. It's been proposed for a long time in stroke neurology. So you have to depart from the question, should I give thrombolytics to all patients before thrombectomy? To the questions, who are the patients that before thrombectomy have a higher chance of benefiting from thrombolytics, right? It's individualizing the situation. And when you look the subgroup analysis, I think it's important that you understand that in the first, let's say, almost 2 hours, okay, there is a statistical significant benefit. So I think if you get a patient within 2 hours, you should have a very, very, very low threshold to give thrombolytics because it's a statistically significant benefit. However, after about 3 hours, the point estimate is actually on the other side. The odds ratio is above 1. So maybe those are patients that, well, it's expensive, maybe it's not as beneficial, I'll pass. And then between 2 and 3 hours, it's the gray zone, right? But at the end of the day, you have to individualize the case. The other thing that I'm very curious to see is if there will be an impact of the infarct size. Maybe the larger strokes have a higher tendency of bleeding and maybe not giving thrombolytic makes sense. But the idea again is you should try to individualize the situation. Gonna go a little quicker here to talk about new treatments. So even with the same technology that you have, which is stent retriever, you are now doing Y stent retrievers, okay? So not only you have new technology, but the older technology has been adapted to develop better techniques. There is a single arm trial using 2 stent retrievers to remove clot out of Barcelona in Spain that demonstrate this is better to use the Y stent retriever, the 2 stent retrievers than 1 stent retriever in terms of achieving first pass reperfusion. Stents are going back. If you are failing thrombectomy 1, 2, 3 passes, maybe as opposed to keep trying, you should just drop a stent. There is some early data about this. Mega bore aspiration catheters. There are 3 companies, 1 in Ireland, 2 in US, using the 088 catheters. They are much bigger than the catheters that you typically use. And here for you to see a video of a large clot with one of our bigger catheter in the market here, a 07. So if you see it can't really ingest the clot, look at the 088. The same size clot gets ingested. So a big difference. It's a much bigger catheter. This actually will help you understand. Here is 088 in the MCA versus a 71 in the MCA. It's a much bigger catheter, more aspiration power, more area, higher chances of full clot ingestion. Here are some examples of these catheters in the MCA. Another neat technology is cyclic aspiration. Here is regular aspiration. Sometimes you can just cork the clot. Here is cyclic aspiration. So this is the same catheter, the same pump. The only difference is the pump is cycling on and off at a very high frequency. And with that, you can deliver kinetic energy and pretty much ingest the clot on site. So that's like a nice technology. It's almost like adding like a turbo to your engine, okay? Same size engine, but now you have a turbo booster. We've done some cases of this in Brazil. Nanotechnology, this is very exciting. There is a magnet here that you put close to the patient head, and these are nanoparticles, much smaller than a red blood cell. You can see them moving around here. So you can guide these nanoparticles, okay, to break the clot in the brain by using this magnet to attract the iron particles. And here is actually a picture of peripheral arterial disease before the treatment and peripheral arterial disease after the treatment with nanoparticles. You can see a remarkable improvement in perfusion, as you can see here in this picture. So a neat technology. It's been used in Australia years ago intravenously, but cause hypotension. So you are gonna use for intra-arterial delivery. You're hoping Baptist is gonna be joined now as in this trial as well. So we have to understand now that you are transitioned from the macro reperfusion to the micro reperfusion. You've been treating only the tip of the iceberg. Okay, guys. So when you look at an angiogram, you see this, right? But the vascular bed is out this. There is about 95% of the vessels you are not seeing an angiogram. So when you get like a TK3, you open everything, there is probably a lot going on there. And that's why, despite having full reperfusion, sometimes people don't do well because they have microthrombi still in the microvasculature. So this nanotechnology may be something that is going to clean this up. Giving intra-arterial thrombolytics after a reperfusion may be something that is going to clean this up. To finalize, you have here an example of bypassing imaging in the direct to the angiography suite. The angio suites can now give us a CT that looks like this. You can exclude blood and bypass CT and MRI altogether. You save at least 30 to 45 minutes, right? Because you go just like cardiology. The NIH greater than 10 is the EKG of the brain. These patients probably in the early window should go straight to the angio suite. You have studied that. There is a trial that it's positive, but it's single center. We are doing a multi-center trial, and Baptist is actually part of it. Neuroprotection, our colleagues from Calgary did fantastic work with neritinide. We haven't shown a benefit yet. We've been working with this compound called PP Doubles is a site, excited to collaborate. Another way to protect the brain is going to be cooling. As you know, there are a lot of issues with shivering and cooling, okay, with systemic cooling. So the idea here is you do the thrombectomy and then you use a catheter that does regional cooling of the affected hemispheric without messing with your systemic temperature, so you can overcome all the limitations of systemic cooling. Robotics and telerobotics, we've done some work with carotid stents initially with robots. Our colleague Vito Pereira has treated aneurysm, very promising technology. But what is neat about robotics and stroke is not robotics, is actually telerobotics, closing the gaps, going to rural areas, potentially putting robots there, and Nima and Ricardo and Eric can be here playing in their joysticks, looking at the beautiful ocean, smiling and treating people that wouldn't otherwise have access to therapy. This has been done in India, 20 miles away. This interventional cardiologist has done coronary stents. And to finalize, something that I'm very excited about, which is not really a treatment for acute ischemic stroke, but a treatment for those strokes that didn't do well, specifically the locking patient with basal artery occlusion, brain-computer interface. There is a lot of buzz now with Neuralink and Elon Musk, but we've been working, and Ricardo is involved with that as well, with this stent throat company called Synchron. And here is essentially one of the cases we did in Pittsburgh. You put a stent throat, which is a stent that has EEG electrodes in the big vein in the center of your brain, close to the motor cortex, the superior sagittal sinus. And here is this patient that it's locking, essentially with digital telepathy, he's controlling his cell phone. Okay, so it's absolutely amazing what this can do. This is my last patient who can still talk, but he can't move his arms. And here he's playing video game just with his thoughts, right? So the future is bright. Thank you so much for all the collaboration and friendship over the last several years, and looking forward to coming here and brainstorming and working with you for the several years to come. Thank you.
Thank you, Raul. I think you unpacked a lot. I'm gonna do a quick, I'm gonna show your slides for large core, and then I think we'll discuss both, and then we'll go for ICAD. I think it'll make more sense because there's a lot of what you just present to us.
And now, yeah, this is gonna be quicker.
Said ICAD gonna be quick.
We did 2, Mount Sinai 2, and Buffalo 2, 36 minutes.
Microphone here needs a blue pill. Can you see the slides? Can you guys, oh, here we go. So I gave this talk exactly right here when we had our Florida stroke that Wendy and Nima brought to Jacksonville. Ralph Sacco, unfortunately, no longer with us, and Jose Romano did this phenomenal organized movement of putting the whole Florida state and Puerto Rico under the same registry. So we have data for the whole state of Florida and Puerto Rico for all Gatwood guidelines. So we have a lot of thrombectomy, a lot of IV TPA information. So we talk about that. Since Demetrius could not be here with us this morning, he'll be late, so we decided to share this. Just, I think Raul already summarized this, but I'll go a little longer here. So this is what you see what happened with sleep deprivation, Eric. If this is Raul before doing thrombectomies, sorry. This is Raul after 20 years of thrombectomy. I always felt really bad that Eric and I were on call for 10 years every other day. Dr. Nima came to help us a couple of years ago, but we remain the only cranial guys. And now, thank you, Lord, for Dr. Daniel Aikida, that's our partner number 4 that joined us. but this is Raul before he joined Emory. This is Raul when he just arrived to Pittsburgh. Raul, for a while, he was the only neurointerventionalist giving service to a thrombectomy center, doing close to 400 thrombectomies. So we do age together, but I thank you, Raul, for being here. And I take Amru Siraj, that is the guy on the other side of the picture. That's not Raul, guys. That's Amru, that was our PI. Got a lot of hit because the way he designed Select2. He was bombarded, but he finished, he published, and I think he helped move the field forward. Again, Raul talk about this. Don't need to talk about this to this crowd. I think this is old news. What we did for early window, late window. We know that when we're dealing with large core, and we got slower on publication, and we published this as well, but Mark Rebo was faster than us. We knew that this concept of large core was vague. So this is our chief of St. John's County Fire Medical Rescue. He's giving a talk in front of his whole crew, educating his crew, and all of a sudden this guy cannot talk. All of a sudden he cannot move his right side. So he has a LVO documented and witnessed by his whole crew. So this guy, they drop a chopper, land a chopper at the soccer field of this school, flew him straight over other comprehensive stroke centers to Baptist downtown. He got there with an age of 16. I read aspects of 9. Our radiologist read a 7. He got TPA literally in 6 minutes from arrival. We were all there waiting for him, and we punctured the groin 14 minutes later, and 22 minutes later, he has a ticket trip. But this is rapid back then. Could be rapid, could be vis. This is calling. I don't have my glasses, so I'm getting used to this. It is a drag. So according to Rapid, he had an 86cc score. So that's what Mark published first. We got second to him. This is a false indication. It's a nice color map that can level the plane. Before this color maps vis and Rapid and vis on historical order. If you get somebody to read a CT perfusion, it was an act of Congress. Nobody understands what that means. So this simplified things a lot and help a lot. But big caveat, and we had these discussions at this exact forum with Greg Albers, this is not perfect science. And we proved, comparing our data from Baptist with Stanford data, showing that there is an indication for intervention at large core. And Greg Albers, there was a big proponent of this large core constant on CTP, folded and said, yes, I acknowledge that there is a mistake here. So this is this guy. Thank you for him. We show this is Calgary collateral circulation on the CTA. Mike will say we knew that before. So this is his, he has an M2 occlusion. So go back to MIVO. Is this a MIVO? No, it's not. It's a dominant M2. I would not call this a MIVO, but anyway, we went there and opened the vessel, semantics, and this is this guy's stroke. So he has an incomplete, Raul alluded to that. You see the DWI is not that bright, so we know there are cells alive intertwined with that DWI. And you see that volume before, and the volume of this on his DWI much, much smaller. And this is this guy in an age of 0 at 3 months, back to his job. So we know that the core can be fake news. So that was the major criticism to CTP, and that was the major rock that was thrown at Amru's chest, because these patients were supposed to be included on Select2. Thankfully, 75%, and Raul will correct me if I'm wrong, we played this memory game, who memorized more papers and who can cite more papers and page of that, what is written, so far and so on. But 75% of the patients enrolled on Select2 were aspect-based, were not CTP, and there's a big problem of doing CTP for core estimation. This is Noguera flag, so you see this is DWI is reversed. Raul published that. So this is Mark Rebo for CTP core reversal. This is Raul with Leticia Batista, that is a neurologist from Brazil that was a fellow here with Raul. Tudor also published on that. So you see the difference of quality of that DWI, and you see the follow-up and reversal of the DWI. And I'm going to accelerate here. So you see this is all Emory, Grady. Let me qualify that. Grady work. And you see this was there on Mr. Clean for cores greater than 70. On Hermes, there is a little bit of that. And you see this was not very well represented on Hermes, but it was there, 186 patients showing that. And I'm going to skip through all that because I want to show you where we are. So when I present this, and we struggle a little bit with that and discuss every single case, in spite of level 1 data that we have today, when you're going to cut and say, okay, I'm not going to intervene on this person. I think today, when we started, you see a lot of people looking for justifications when to intervene. Today, I can hear Mohammed on that order, Mohammed, Naraj, Yogi, and Jarna saying, okay, guys, let's go. We got to intervene. We got to do something. So we all struggle with some of this decision when to intervene. And I would love to hear Raul, Michael, and everybody on the audience. When you're drawing the line, okay, this is a large core that I would not intervene. But this is a snapshot that our research fellows put together a couple of months ago. Over a year of 303 thrombectomies, we treat 24 patients with large core. So even before the trials that are demonstrated here, those are the first 3 with the Japanese study, the SELECT-2, and the Chinese study showing that Raul showed this slide. You showed the inclusion criteria. You see that this is very balanced in terms of occlusion site. And you see that in all 3 trials, there was a benefit in terms of independence for these patients. So this is, they're working on this. I'm not aware that Magna is already published, but you see here that there's a significant benefit for independence, about a 20% delta on these patients getting better. So I just want to get to the Magna because they put this all together. You know, I'm intentionally going fast to this. So this is Magna. Is this published already, Raul? Not yet, right? So Magna is what Hermes is for early window, and Aurora is for late window. This is a combination of these initial studies under one, and you see here the benefit of treatment on the thrombectomy versus medical management. So there is a 20% difference from here to there in terms of being independent. Naturally, this is very different than somebody has no stroke or small core aspects of 7 and above or 9 and 10 versus an aspects of 3, an aspect of 5. So the functional baseline, you got to remember, you're starting at a lower ceiling. Yes, you're going to get 20% higher on the treatment group, but you're starting with a ceiling that is 3 feet high, is not 10 feet high. So you got to explain that to the patients and the families specifically here, because patients very often are not involved in that discussion. And you see here that the mortality is similar, and you're not, as Raul pointed out, you're not changing this severe disability. That's a major concern, right? You're saving somebody from dying, but you're keeping this person in bed for life. No bueno. So that's where we are. A lot to be discussed here. I think we need more information for this super or mega large core over 150. I think there's still a low number. Not sure how we're gonna answer that, if we need to answer that. Tesla, Raul alluded to that, got presented, and so I'm gonna skip through that because I want to get to discussion because I think that's more interesting than looking at this slide. Tudor present a couple of months ago this result on this lice stroke. I haven't seen, is this published already? Not yet either. And tension. Say it again. Tension is published. So the data is consistent and favors endovascular treatment. I think the fear that intracranial hemorrhage and we're increasing MRS of 5, I think that's not there. The question for me is who we're going to intervene, or more interest in who you would not intervene with a large core in April 2024. With that, I'll stop. We're doing this together with Raul, and the Turkish team. We're going to have a whole week discussing all these topics in stroke and their intervention in Istanbul next month. I hope you guys can log in and join us face to face if you wish. I'll stop here. I think we have how many minutes, Abby, for discussion? 2 minutes? No, we have more. Raul is going to make this last talk shorter. At what time is lunch? 12:15, right? Dr. Naval is saying 5 minutes. So, okay, guys, Raul, you have the microphone. Who today you would not treat for a large core?
That's that's a very, very hard question. That's probably the biggest struggle that you currently have, because theoretically, we now have green light to treat almost every patient. One of the things, so I was not surprised. We've been treating large cores for a long time. We believe on it. One of the surprises I had, Ricardo, was that even patients that are older than 70, 75, 80 benefit. That I didn't expect, right? So it doesn't seem that age is a treatment effect modifier. It doesn't seem that time, that's the other thing. Maybe it works if you get them very early. And yes, it's better if you get them very early, but even when you stratify according time, 0 to 12, beyond 12 hours, you look this in the trials or early and late in these different trials, there is no treatment effect modification. So the truth is we really don't know who doesn't benefit, but there is no therapy that every patient benefits, right? It just doesn't exist. So I think the things that I consider is expectations, right? If someone says, I need to be completely independent after this, and then I see a very large, dark stroke on CT, mostly at a higher age, that's someone that I may advise the family not to proceed then. But more and more what I'm telling my team and I'm doing is, this is a decision between you either treat the patient or you make the patient comfort measures on. The worst thing you can do is you don't treat the patient, but then the patient is still full care. That's the worst thing that you do, right? Because you are essentially condemning that person to be alive with higher degree of disability, right? And God forbid if you treat the patient dies and bleeds and dies, that's not the worst outcome. I think the worst outcome is an MRS of 5, not 6. And most people would accept that. So I think my main message here is I don't know who you don't treat. We are humans. And there are jokes about this that are commonly done. Who you don't treat 2 in the afternoon and 2 in the morning gets complicated. There is resource utilization. You are not like cardiologists. There are few of us, including techs and nurses, and these people leave because they work very hard. So you need to increase the workforce in order to really open the gates. But I think rather than give you an answer of who I don't treat because I don't know, the important thing here is you either treat or you make the patient comfort measures only.
Michael, your thoughts?
I think it's really important to distinguish between effect size that you can prove in a trial and prognosis, which is very much what Raul is emphasizing here. So you need to have a really good understanding of what happens to patients when they have significant disability. The second thing I would comment on is, and you really outlined it well in your talk, Ricardo, is that the definition of what is a large core remains to be well determined, right? Going back to the original stuff we did with way back with just plain CT and aspect score, there's been something recently, was it intention or I can't remember which one it was. Somebody looked at the Hounsfield unit decline on the scans, and that maybe we can help decide. But it's very clear that what you see as early ischemic change is not pan necrosis, right? And so, and what we see on CT perfusion imaging is not pan necrosis necessarily. So, you know, if someone has a really dark, obvious, well demarcated infarct, you're not going to save that. The only thing you can do is make that person worse. If it's large enough that they're so disabled, then you may decide, as Raul said, to palliate your patient. It's not always necessary to make the decision to palliate at the time you're deciding about endovascular. So we do this in other scenarios as well. Eric, you said this to me many years ago about subdurals. So 85-year-old big subdural, take it out, see what happens the next day, and then decide how it's going to go, right? So we have that option in stroke care as well, where we could offer therapy and then decide, well, geez, we're not getting a good result, and maybe the family can decide the next day with the patient that you're gonna palliate that patient. The last thing I'll say is that I think, and Nima, you'll like this too from the neurology perspective, we can use our knowledge of anatomy to help us make decisions. So I would argue, this is just an observation and I've yet to prove it. We'll see. And we're going to look at the scans and select two intention to sort it out. But you can tell where the motor strip is on a scan. And and we know in that certainly from the clinical side, the modified Rankin scale score is heavily motor dependent, whether you can walk or not. But the truth is, even in life, if you can't move, you're not mobile, you will not have a good outcome, right? If I look at patients who I have sent to nursing homes, SNFs here, who are hemiplegic, their average life expectancy is about 6 months. So if you send someone to a skilled nursing facility who's hemiplegic, you are in a sense sending them for long-term or chronic palliative care in a way, right? So if you look at the motor strip and the motor strip is completely gone, right? The probability that you're going to have a good outcome is 0.
Sorry, to that, just a quick follow-up to that question. So we have to deal with what information we have. So Raul, I'll ask you the same question. Would you take an aspect 0 and 1 occlusion?
So can one thing that is fascinating to me about this discussion, okay, I think I have my mic on, is that if you go, and I believe there are people who are in the critical care field here. If you go to a critical care meeting and they are talking about septic shock, this discussion does not exist. No one talks about it. You just treat everyone and you hope for the best. Fact, mortality in septic shock is 40%. 40%. Okay, only one trial had mortality of 40% in the control group. Select 2. All the other trials actually had mortality lower than 40%. If you go to a cardiology meeting, no one has the discussion about PCI coronary intervention in ST elevation. Oh, would you treat this patient? There is no such discussions. You go to an oncology meeting, they are talking about the new chemotherapeutic agent that costs thousands and thousands of dollars that improves survival by 2 months. And here we are trying to define who are the few patients that don't benefit from this therapy, just so you can stop treating them.
Sorry, Raul. Those are absolutely false equivalents.
No.
You talk about disease that almost been binary. I mean, if you recover from a septic shock, you have recovery ahead of you, but the functional prognosis down the road is good. We're talking here. So
No.
the message you're sending here is that every 80-year-old will come with, like, I don't care, like 2/3 or 3, half of their brain dark. We know those people. We know those people won't go home and start, playing Scrabble again. So at one point there is a bit of, in it, mostly in the United States, the easiest a lot of time is to intervene because nobody is gonna, have any, most of the time, money is not an issue. The consequence, I mean, acute, like, the consequence of that won't be a problem, but the reality is that, same too is true. We deal with that with decompressive and craniectomy. Most people who help sometimes guide this decision won't see those patients follow up. I could tell you what's happening. Young patient will do good sometimes, but older patients don't do well. And a lot of time, patient will show first follow up with their family member. On follow up after that, there's nobody. There's nursing home accompanying somebody from a nursing home. And those people, as a society, wonder, who have we helped there? So I disagree with your statement because it make it like, like we're preventing those people for full recovery. We're shifting the curve. Shifting the curve in the 87-year-old, you may not shift it to a good level either.
So I think we showed that, and you need to see the subgroup analysis according to age, right? But the reason I put that slide where you do not increase the number of people who are alive with 4 and 5, it's absolutely critical. I have no problems not treating patients, but then let them die. The worst thing you can do for this disease, and I'm gonna have to show maybe a couple of slides about this because it's easier to convey the idea. The worst thing that you don't do to this disease and is not treating and not letting them die. It's the between. That you can do. I have no problems. You say, I won't treat it. You should make comfort measures only. It's a bad stroke. Let he or she go in peace. I don't have a problem with that. But not treating and keeping giving support to that patient is the worst thing you do because your chances are you are not changing mortality, but you are increasing disability.
Define in your mind what is giving support. What is medical treatment for these guys?
Oh, this is a patient that if you are not going to treat, okay, should go to a room with the family hospice care. Palliative care, morphine drip.
One point, Raul, just, I think you made comparisons to septic shock, ICU, cardiology, oncology. We have to distinguish between discussions that are held where people are trying to push the boundaries in research versus what we actually do in real life. So even in real life in oncology care, there comes a point where you say, okay, no, we're done. We're going to palliate. And same with septic shock. We get to the point where we're done. I don't know how it does how it's happening at UPMC and Emory, but there is a point where people stop. So
when is that point?
Well,
is that point in the first 3 hours?
Just pointing out that you made the stark comparison, and I don't think it's not quite fair because there is a point where people stop, right?
When?
Depends on the situation.
After they give them a chance, right?
I mean, you can sometimes and sometimes not. It depends on this. Depends on
Mike, how many times have you seen a critical care doctor, a septic shape, a patient with blood pressure 8/4, and they say, I'm not going to treat this patient, the patient die in the ED with no treatment? How many times have we seen that in the history of US medicine?
Well, okay. What you guys do in the US is different. We do it. So we'll stop. No, I do agree with you. I do agree with you, though, that, there's the issue about that. I'll just say one other interesting thing, right? So far, one thing that was really, really interesting about the large cohort trials is it appears that the volume of infarct is identical in the treated and the non-treated groups, which makes one wonder about reperfusion and its role in subsequent rehabilitation. Really interesting.
But Tom Brott would say even with TPA, and he made this claim many moons ago before thrombectomy exists, even the patients on NEENs that did not revascularize with TPA did better because you're probably open the microcirculation and you are changing the quality of those glia, neurons, etc. Raul, you're going to have to do your ICAD talk in 30 minutes.
Okay.
If not, Abby and Aval are going to show me the 5 minutes. But I want to just go back to one point because I think it's too important. We're living through that. You said something before you arrived. Michael Hill said something else. Low NIH. So Mike said they finished a randomized trial showing the large vessel, low NIH with thrombolytics fail to show benefit. So no intervention versus intervention with thrombolysis fail. You are the PI for endo low, and you put all the rationale why we should be randomizing. So to both of you, and then we're going to move to ICAD. Shall we treat? Shall we treat? Is that you, Abby? Shall we treat large vessel occlusion NIH 6 or below? Pittsburgh or Calgary? Shall we not treat NIH 6 large vessel occlusion because at least with thrombolysis it doesn't make a difference? So I'm gonna let you start.
I'm gonna make it very easy. You need the randomized trials. If there is a group of patients that I'm not sure thrombectomy is gonna be beneficial as this one, there is a potential of harm. I compare this situation as a situation of embolizing a small paraclinoid aneurysm. Nothing can go wrong. If there is a treatment benefit, it's small. So I'm not sure you're helping these patients. What you want with endolo is find an answer. Is not to show that endovascular therapy works. Our initial work makes us believe that it works. I'm not so sure about that anymore.
I agree. Let's wait for the data.
So we're all on the same page. That's an easier discussion. And with that, we'll transition to a couple of slides of a rebate and then
I just want to explain what I mean with this, okay? This unique social impact of stroke. And that we had this discussion here with Eric. Yes, it's a binary disease, STEMI, sepsis, trauma, cancer. If you don't treat, these people die, right? Fact, right? Bad disease, sick people. However, if you don't treat a large vessel occlusion stroke, we probably don't change the mortality in most of the situations. There are some situations where you change. What you change is the amount of disability that these patients have. But if you treat them, you shift disability. You don't keep them alive with higher degree of disability. If I don't treat a STEMI sepsis, the patient dies, sad for the family. It's a very sad outcome. It's a bad thing. But for society, you stop spending money with this patient. If you don't treat an LVO, that patient is alive with worse disability. That patient is coming to the hospital all the time, recurrent hospitalization, caregivers, okay? You actually spend much more money. So yes, is a binary outcome that actually hurts you. But just to summarize this, there are very few black and white situations, I think, in medicine. I love the shades of gray, but if there is a black and white situation, it's a large core. You either treat or you make the patient comfort measure on. That's my humble opinion. I think you're gonna learn a lot about the subgroup analysis. In the interest of time, we will move into intracranial atherosclerotic disease. Sorry, it's now 2024. Just realize that. Here are my disclosures. So this is a fascinating topic. It's a disease process that endovascular therapy has been very disappointing. So I'm not gonna come here to sell the concept that you should be treating these patients because I almost never treat them. And I'll explain why. Why you need to still talk about it, because it's a relatively common disease and it has a very high recurrence stroke rate. And here is how common it is. About 10 to 15% of strokes in the Western countries are caused by ICAD. In Asia, it's over 45%. So that's why I think hopefully they will give us the answer eventually. And here is recurrence when you look at stroke subtypes. By far, if you have large artery atherosclerotic disease, whether it's extracranial or intracranial, you have a much higher recurrence rate. So what can we do to prevent this, right? Before we talk about the treatment of intracranial atherosclerotic disease, there are a few principles I would like to discuss. The first one is not every intracranial stenosis, not out narrowing, it's equal to atherosclerosis. You have to understand there is a differential diagnosis, right? So yes, it can be plaque, it can be atherosclerosis, but it can be on angiogram or CTA, partially occlusive thrombus. Sometimes it's hard to know, underlying vasospasm. When you're doing a case of thrombectomy, it's very, very hard to know what is doing that narrowing, okay? Obviously, other things like dissection, Moyamoya syndrome, vasculitis, RCVS, vasospasm, lymphoma, and arteritis. You have to think about other causes for your narrowing other than plaque, but plaque is the most common one, and you're gonna be focusing on these patients here. You have to understand and you have to respect the target organ, the intracranial artery. There are nuances about the intracranial vasculature that it's different than the coronary or peripheral vasculature. And the importance of that is you tend to adopt similar strategies and devices when you're treating both organs. First of all, the intracranial arteries are a lot more delicate. Okay, they lack the external elastic lamina. The tunica media, the muscle layer, it's also a lot thinner than the coronary or peripheral arteries. These arteries, they are flowing, right, in the base of the brain. So they're relatively loose and not supported by a lot of muscle like in some other areas in the body. Secondly, you have these perforator vessels that are quite problematic if you actually squeeze plaque into them because you can cause pretty disabling infarcts, which is something that it's not as common as, let's say, like in the coronary bed or in the peripheral bed. In terms of the pathophysiology, why does stroke happen? Part of the problems that you have in strokes is you tend to lump everything as the same category. Here you need to understand why does a stroke happen. Is this a thrombotic stroke? Essentially the plaque rupture. When the plaque rupture, I have the development of an in situ thrombus and then an alveole. Or this is a thromboembolic stroke, that thrombus travel and cause an embolic event. Is this a hypoperfusion stroke where that plaque just got to a point where it grew so much that it started limiting blood flow to a point where now you're starving for blood and having ischemic damage? And finally, and this is actually a pretty important one, is this plaque not causing problems in the parent vessel itself, but rather in the neighbor vessel, in the perforating vessel, because now it's growing into that vessel and it's causing a perforated ischemic stroke. Okay, and that's actually a potential implication that you need to understand very, very well when you decide who are the patients you may want to treat with endovascular therapy. So it's important that you understand these four very distinct pathogenic mechanisms, pathophysiological mechanisms. And in general, I think thrombus prevention works for everything. So do antiplatelet makes a lot of sense. Plaque modification works for everything. But the patients that had thrombotic and thromboembolic strokes probably will not benefit as much, right, from opening the vessel, because that's not really the main problem. And you definitely don't want to plastic this and squeeze this plaque in the perforator vessel if you have one of these lacunar perforator events. So it's important that you understand what's causing the stroke, and MRI imaging can give us some clue, okay, on what's happening in terms of the type of stroke. And here is a case of an atherothrombotic stroke that you did a thrombectomy, patient did well. Here is a case of an initially thromboembolic stroke. You had this plaque here embolized into the occipital lobe. Then it became from thromboembolic, acutely atherothrombotic, and then we treat that patient as well. It is a nice case of an M1 stenosis producing what you call Baudrillard strokes due to low flow that we fix with a stent. I think this is a good indication for a stent. And finally, this is bad news when you have a perforator type of stroke due to these. I actually think treating these patients with stents is a mistake. You are just squeezing the plaque in the perforator. But let's look at the evidence, right? We now have 3 randomized clinical trials, okay? And here is what you know from these trials. Stent is not beneficial in the treatment of largely unselected patients with what I'm gonna call the stable angina of the brain. And it's important that you understand what you treated. In these trials, you didn't treat the STEMI of the brain. This is not the LVO I had. In these trials, you didn't treat the unstable angina of the brain, the patient that it's in the ICU with fluctuating symptoms and getting worse in front of your eyes. In these trials, we treat, all 3 trials, patients that came to us in general, in clinically stable after having a TIA or a stroke, stable angina of the brain, no benefit. And yes, that's terrible and that's sad. And we kept finding excuse. Maybe it's the self-expanding stent that it's bad. Well, balloon-mounted stent also didn't work. Well, maybe Americans aren't as experienced or Europeans, and the Chinese, you figure it out because they do more. Well, that was not the case as well. It didn't work in Cassis, which was entirely done in China. Very good experienced people. What this trial shared is that they are very small, and you'll talk about why this is a problem. Perforated strokes, I told you, I don't think they should be there. The Chinese colleagues eliminate them from their trials, still had a negative trial. The other thing is we look at early time of intervention, late time of intervention. Why? If you wait and you let the plaque cool off, it's safer to do the procedure, right? And then you're gonna have better outcomes in the treatment arm. But guess what? The control arm, also you have better outcomes because a lot of the events on atherosclerotic disease, they happen during the heat of the plaque, right? That plaque is hot, is active, is angry within the first 2 to 3 weeks. We know that in carotid endarterectomy, the benefit decreases dramatically after 2 weeks, right? So yes, I can make my procedure safer, but at the cost of letting the patient have a stroke within those first few weeks. And you're gonna talk about that, okay? It's like doing plastic surgery in your results. You are over-selecting. You're improving your results at the cost of bad outcomes in the patients you wait for treatment. And yes, these patients, they had pretty tight stenosis in the range of 80% in terms of mean. Here is the main problem that I have with this. Doesn't matter which trial you look, you pay a price. You see the red is the stent group, okay? You have worse outcomes. These are the events, right? It's strokes, okay? Because the procedure causes strokes, you start worse. But the problem is it never crossed. It's like even though you stent, you never saw a benefit. This line never crossed this line. It's almost like you are not doing much. You pay a price for the procedure, but you are not preventing anything. If you look at SEMPRIS, you see this, begin and end, the lines don't cross. If you look at VISIT, begin and end, the lines don't cross. If you look at Cassis, begin and end, the lines do not cross. So you're hurting people with the procedure, and you are not preventing anything by having that stent there. And when you look at the data, obviously it's gonna look bad, right? Here it is, any stroke or death at 30 days, 1 to 3 years, it favors conservative management. If you look at patients with ischemic stroke within 30 days as endpoint or TIA 30 days endpoint, again, no benefit. And if you look at any ischemic stroke, 1 to 3 years, or TIA 1 to 3 years, things start to get a little better. Maybe later on, maybe there is a little more signal of a benefit. Why that's important? Well, you need long-term outcomes, right? Long-term follow-up in these patients. But here is something that I think it's important that you understand. The stroke in the same territory of the qualifying artery, okay, didn't really show much in terms of benefit, even at 1 to 3 years favoring medical management. So we are doing something wrong, right? And you need to understand why. Not only that, but you pay a price, you have significant more intracranial hemorrhage, you're hurting these patients, you're causing strokes, you're causing bleeds. They also die more, within 30 days with the treatment. So doesn't sound like you should be doing it, but maybe the stent type will make a difference. No, it doesn't. When you look at the two different balloon mounted versus a self-expanding, doesn't make a difference. And the time from qualifying event to randomization, early or late, also didn't make a difference. We have a problem. Can we find a solution? Well, before you talk about the potential solution, let's understand what you're dealing with here. Here is the main problem of this. You do a stent, right, to prevent a stroke in the territory where you did the stent. That's your goal, okay? How often does it happen in the population that we study? 1 in 10. So we treat all these patients, but only 1 in 10 patients, okay, will have that event. 9 in 10 never needed the procedure. And I think this is the main problem that you currently have. So problem number 2, the studies are not big enough. In cardiology, you see these studies with thousands of patients. We gotta do them in stroke, mostly if you talk about prevention, right? Because it's a recurrence, which is not like an LVO where, you know, a lot of people do bad if you don't do the procedure. Here, a lot of people do well. So if you want to decrease, okay, the event by about 35%, which is a lot of benefit, that's a lot of benefit, okay, from 10.4 to 6.8, let's say. Here is the sample size that you're going to need, over 2,000 patients. Okay, so we never stood a chance to prove that this therapy worked because we had the wrong patient population and you had very, very small studies, okay? But the better question is, who's gonna do a 2,000 ICAD trial, right? It's very expensive. It's very hard to do that. So the question then is this dead? Are we done? Well, let's dive a little bit into what we can do to show this works, at least in some patients. We need safer and more efficacious treatments, but more important, we need worse natural history. You need to find out who are the patients that don't have 10% chances of a stroke if you don't treat, but rather 20% or higher. And in terms of safer treatment, the WEAVE trial, which use Wingspan, they only treat patients with stroke. They had very little, actually, peri-procedure event rate, so very safe, okay? And this persisted even at 12 months, less than just about 5% events from between 1 and 12 months. So again, it's not that you go to 0, right? Between 1 and 12. It's not that if you put a stent there, no one will have a stroke. We need to understand that. But theoretically, if you compare UVEN, which is this registry with the treatment arm, right, you could show potentially a difference. Well, 2,000 patients would be required. But the big problem here is in SEMPRIS-R, patients who were treated early. This treated patients at a median of 22 days after the plaque cool off. So you are not comparing similar patients. This doesn't even apply. That's not the solution necessarily. I'm gonna skip this and I'm gonna talk about this, which I think it's really cool. This is why I have hope, okay? We have been oversimplifying our field that causes a lot of confusion. I want to trace some parallels between the heart and the brain, and let's try to follow their footsteps once again. When you look at the classification of coronary artery disease, you have asymptomatic patients, you have patients with stable coronary artery disease, chronic coronary syndromes. You can break this down in the stable angina, vasospasm, microvascular angina. Then you have the patients with the unstable symptoms, the acute coronary syndrome. You have unstable angina, non-STEMI, and STEMI. And then you have patients with heart failure, right? And we actually have all these categories in cerebrovascular disease as well, okay? But in here, PCI is not indicated. Coronary intervention for asymptomatic patients, obviously, even if you have 95%, 99% lesion, they don't do it, right? But stable angina, PCIs is sometimes indicated, sometimes. And the reason why it's sometimes is because they only do when the patients have bad collateral flow using a technique called FFR, okay? Acute coronary syndrome, PCIs, is indicated most of the time, right, in unstable angina and STEMI, okay? But now let's go from the heart to the brain. When you look at stable coronary disease, you have stable cerebrovascular disease, chronic syndromes. You do have the stable angina of the brain. Those are our stable TIAs. We do have the vasospastic angina, which is our CVS. We do have the small vessel disease, which is stuttering lacunar syndrome. So you have the same stable disease. You have the same acute cerebrovascular syndrome, that of the acute coronary syndrome equivalents. We have the unstable angina. That's the crescendo TIA, the blood pressure dependent patient. It's the patient that Ricardo has, that Nima has, and Eric in the ICU, and is every time the blood pressure drops, the patient gets hemiplegic aphasic, you put the patient on Levophed, neosynephrine, the patient gets better. That's not a patient that was in Sempris. That's an unstable angina of the brain, okay? You have the patients with the non-STEMI type of diseases like MEVUS, Botherzone strokes, and you have the STEMI, which is our LVO or the very severe MEVUS, right? So there is some equivalence. Even the heart failure, you have the vascular dementia, right? Which is now the end organ is affected beyond repair. So there are similarities here, okay? And when you clean these things up, asymptomatic, we shouldn't plastic. In stable angina, we know it's not indicated, right? But maybe if you develop a collateral flow detection tool, like they did in the heart, we may find a different answer, right? So the problem is you're looking at all unstable anginas. You need to find what, all the stable anginas. You need to find what are the stable anginas that have low collateral flow that may benefit. And obviously, if you have crescendo TIAs, unstable angina of the brain, we don't know. You don't have trials yet. None of those 3 trials apply to this situation. So I think it's very reasonable in 2024, if you have a patient who's having crescendo TIAs, who's blood pressure dependent, who's getting worse in front of your eyes, to treat those patients aggressive with plast and stenting. They probably benefit. You don't have data one way or the other. But let's not say, oh, you have 3 negative trials and not treat those patients, because it's a very different situation. Unstable angina of the brain has yet to be studied, okay? And it's hard to study those patients. They are not very common, unfortunately. But you don't know it. It probably helps, right? And let me go back here because I think I run out of battery. And then, ooh, we stuck, sorry. Oh, the computer froze. So the idea here, right, is to try to follow the same cardiology paradigm, okay, and identify who are the patients who may benefit. And I'll try to trace a parallel of what happened in cardiology. To see if you can get there in the future, okay? So in cardiology, there was a trial of stable angina called the Courage trial. They randomized patients to medical treatment, okay, or coronary intervention with stenting. And that trial did not demonstrate any benefit. very much like what happened in the brain. Okay, so when you look at these three trials, we shouldn't be surprised because pretty much the same problem we had in Semperis Cassis and Visit happen in cardiology. And let me go, and I'll just show very quickly that story, and then you can dive into the potential solutions. So we are talking about this, right? That we need to understand the different categories. And here is the Courage trial. Again, stable angina of the brain, very much like what you did. Negative, New England Journal of Medicine, putting stent does not help. So you shouldn't be surprised. We studied the Courage. Same thing they found in the heart, we found in the brain. What did they do? And look at the sizes, by the way, almost over 2,000 patients is still no benefit, right? So what they did, they look at the long-term follow-up, still no difference. Then they start looking at potential ways of getting these stable angina patients to benefit. So they try to look at imaging techniques to help. And despite using some imaging techniques, stress testing to stratify losses, they fail. But they kept trying. And it wasn't until they developed the FFR, which is, think of it as like a pressure wire. It measures a drop in pressure across a stenosis. And based on that, it tells you you have good collateral flow or you have bad collateral flow. Well, if you have bad collateral flow, you're probably going to get in trouble over time. So they did the FAME study. And in FAME, they were able to demonstrate a benefit. And then they did FAME2, and they were able to confirm that benefit. So it will take resilience. It will take better technology. It will take identifying patients at higher risk. But it's possible that even in the stable angina of the brain, as long as you identify patients that have higher risk, we're going to show a benefit. Okay. And you can see here the 5-year outcome of the patients with stable angina that were selected due to bad collateral flow. And you can see that the cumulative incidence of medical therapy, it's a lot higher than PCI. And you see the lines actually going like this, right? So it's a constant benefit of this treatment. So this is what you need to essentially do. There is some early work with FFR in the brain out of China. There is actually a very cool software company, Artery Flow in China. There are a couple of these companies that are using actually MRI-based techniques to calculate FFR. Our colleagues from Buffalo and other colleagues have done some work here on that as well. Another way to potentially do this is using MRI with the QFlow software, where you can actually measure in the basilar artery the speed of the flow. But how do you tip the balance? You have to find a higher risk population. And I think that's the key message here. So here is the slide I showed to you before, right? We had 1 in 10 patients have an event, right? And you have 35% relative risk reduction. Well, if you could double the event rate, just to 20%, it's not a lot. So 20% in the control group, right, would have an event. Assuming that you have a treatment that has a 35% relative risk, so you'd have 20 versus 13%, which is pretty doable, by the way. Our sample size would be less than 1,000 patients. That is a trial that can be done, right? Maybe not in US, but definitely in Asia, definitely in China. So I think there is hope. There is actually a trial that was just started in Shanghai called Direct ICAS from the same group that did Direct MT that it's doing that, okay? And again, the idea here is to look at patients with bad collaterals. So what to do in our center now? I don't treat patients that are stable. I just treat the unstable angina of the brain. and the alveoles, the STEMI of the brain. But if a patient comes with stuttering symptoms, crescending symptoms, and particularly if the patient has bad collateral flow and understands the risks and benefits, I think it's very reasonable to treat. Another way to identify the patients at higher risk is MRI patterns. Avoid the patients that have perforated strokes at all costs, right? You do not want these patients. They probably don't benefit and can be hard. Also, the wedge strokes, like they call here core MCA, probably have a lower recurrence on medical treatment. The ones that you want is the border zone, internal border zone or cortical border zone strokes. These are the patients that have the highest rate of recurrence, mostly if they have evidence of impaired collateral flow on your angiography. So when you're trying to find risk factors, again, age, the older you are, the higher, the lower is the chance of recurrence, the number of baseline DWI hits, and the location of the infarct maybe help. So you tip the balance by finding patients that have worse natural history, but potentially by having better outcomes, better treatment techniques. You have to understand the risk of the lesion. So this Mori classification is very important, where the type A, type B are a lot easier to treat, type C are a lot higher risk. You have to understand the stent selection. Here is a paper that you wrote to help with that. If you have a short lesion that doesn't have a mismatch in the landing zones, you see here a mismatch in the landing zones, short lesion, straight lesion, I think balloon-mounted stent is typically easier to do. But if you have a small vessel, the smaller balloon-mounted stent is 2 millimeters, so you can't use that. If you have a very long lesion, it's hard to navigate balloon-mounted stents that are bigger than 14 millimeters into the MCA. If you have a mismatch between the landing zones or very curved lesion, more type C, you probably want to avoid balloon-mounted. Submaximal angioplasty, going to about 80% of the vessel, has been proposed as a potentially safer way to do this. Is low balloon inflation is something I didn't used to do, but my colleagues from China advised me to do balloon inflation over about 3 minutes. So that's what I start doing more recently. There are now drug-eluting balloons that will not change the acute period dramatically, but may decrease the recurrence rate in terms of in-stent stenosis or lesion stenosis. Drug-eluting balloon-mounted stents, we can borrow them from cardiology. And just now I learned during my last visit to China that there are now 2 Chinese companies that have developed intracranial drug-eluting self-expanding stents. So that's pretty exciting. The first cases were started, have been done over the last three months or so. So in a year, we're gonna know if this helps decreasing recurrence in-stent stenosis, okay? The Credo system is a system that avoids the exchange, and it is a couple of cases just to show this technique where you had a very tight stenosis that led to acute occlusion. You did a thrombectomy. You can see a lot of ICAD in this patient, so you know this LVO is due to ICAD. You see the pinching of the trivo stent here. Oh, I'm good. I still have 7 minutes. So you see this, I love using, I think our stent trivers are great. They all work very well. I like the trivo when I think of ICAD because it really delineates the lesion very well. I can go and measure the vessel and understand the length of the lesion a little better. But here is post-thrombectomy. There is a vessel going by here. You can see this is actually pretty tight. So it's kind of a long segment of narrowing, relatively curved. So I decided to use a self-expanding stent. And here is what I did. I went with a mini track balloon. This is a chorion aortic over the wire balloon. So I crossed the lesion. I put my balloon. I plasted that segment. Then here is the balloon inflating that segment. Then I advanced my balloon a little bit. Okay, here is post-plastic. Then I remove the wire, and then you can put an Atlas stent through that balloon microcatheter. And here is a self-expanding stent being deployed through the balloon. Okay. In this way, I don't need to do an exchange length procedure, an exchange microguide wire procedure, which is one of the reasons why you get into trouble when you do something like a wingspan. So it's a nice technique that it's done with the system that it's available in Europe. We don't have it here. It's called the Credo Neurospeed, but we can have a Porsman adaptation of that. Here is good result, and they stand with a final nice result. And here is the MRI. Another technique that has been proposed is there is this dual layer stent with high radial force. It's like a stent in a stick, like a stent retriever that you deploy in the area of the stenosis. You leave it there for a while, and then you remove from the brain. It's a Japanese system for patients that have large vessel occlusion stroke with ICAD. It's promising because you don't need to leave an implant there. It's probably safer than doing ballooning. You don't obstruct flow, and you can see that it actually has very nice radial force. Here are some examples of this in Japan, where they did the thrombectomy, residual stenosis. They then use this dilator that does this stentoplasty with a good result. And even at 7 days, you see it's preserved. You see after, before and after here, in this case of ICAD LVO with the dilator. Finally, tipping the balance, it's fair to say that technology is getting better, right? Better devices. Also, medications are getting better, right? We are now looking at the, using different types of medications to prevent ICAD recurrence. The Captiva trial, I believe Baptist is part of it. I think it's an important trial. We may do better by using different combinations of dual antiplatelets or low dose anticoagulation and antiplatelets. More importantly, keeping it beyond then 90 days is something that I think it might be very important in this patient population. So to conclude, angioplasty stenting has not been properly studied in patients with unstable clinical presentation. And thus it remains possible that it benefits this population. So unstable patients, LVO patients with ICAD, they may benefit from stenting. However, the data does not support the use of angioplasty and stenting as a routine care option for the broader ICAS population, ICAD population with stable symptoms. I think we discussed as well. The rates of recurrence in these patients with stable symptoms managed with aggressive medical management does not seem to be very high. As I said, maybe 1 in 10 only, right? So I think conservative treatment is very reasonable. It's the approach based on high-level evidence for these patients. Additionally, multi-center randomized clinical trials, including safer devices, larger sample size, and patient at higher risk of recurrent events should be done. And I was glad to find out that it's actually happening in Shanghai as we speak. Thank you very much for your attention.
Okay, guys, questions for Raul?
Raul, very thoughtful. I appreciate it. You made the point at the end, but I think we should even elaborate on it further, which is when the stroke trials failed in 2013, we knew it was the wrong patient. Really importantly, it was the wrong technology. And I think we have a lot of work to do to define it, because I can tell you the purpose thing, right? And Giovanni's here, who's done a lot of work in the coronary circulation. The purpose of adding the stent is to resist elastic recoil. And we still have really very little understanding of intracranial atherosclerosis, primarily because the specimens have never been available to us. So we don't understand the biomechanics of it, and designing the right device. And by the way, I think they have to be coated in the future. I think they have to resist thromboembolism. So I think we can do a lot with the technology. I know you alluded to it at the end.
I fully agree, Matt. I also would add that on top of resisting the elastic recoil, and what Matt is alluding to is you dilate the vessel, okay? But these vessels, they are elastic, so they have the tendency to come back to where they were. So you dilate and then it comes back. By putting a stent, it holds that structure in place. The second thing I would add that I think it's a big benefit of stenting is when you plasty a plaque, you rupture the plaque and you can cause dissections of the plaque, which can lead to rethrombosis. And by putting a stent, you kind of tack down this dissection. So in general, there are people who are proponents of angioplasty alone without stenting. I like the stent concept, but I agree with you. You don't know what is going to work better in the brain.
And one more thing to add in the coronary, going with your analogy, I didn't make the analogy, you made the analogy. Intravascular imaging is essential. It's actually the American College of Cardiologists has said if you're going to do a PCI, you have to do intravascular imaging. And it's because you can get the plaque morphology and you can understand better how your device, first of all, understand the plaque morphology and understand how your device is how it is deployed in relationship to that pathology. And we don't have that tool currently.
Almost there, right? With your work and the work of others, OCT has been developed for the neuro field. I think Demetrius, Vitro have experience, you have experience with that. The problem is the OCT for the coronary, it's too stiff to use in the brain. I've done a couple of cases with the coronary system. It's not something you can use, right? But as everything happens in cardiology, a decade later, you have it in the brain or so. So fully agree with you. It's going to be very important in delineating what are the lesions, specifically looking at perforators, for instance, right? Should we, one of the was blasting a plaque close to a perforator and then having perforator events. So when you have those plaques in the perforator rich area of the middle cerebral artery and the basal artery, it's an added risk, maybe imaging us. I think vaso CT is something you plus finding those perforators if you have good vaso CT in your center.
Great talk as always. Appreciate your time. You have an acute stroke, you do a thrombectomy, you do the trevo, it's like a stenosis. So you suspect after. So what is your next move?
So we have this thing that we call the sprint approach. We wrote a paper about that. So first thing is to suspect. So how do you suspect? It's an LVO, right? You don't know up front, but you know, if the patient is African American, is Asian, is diabetic, is Hispanic, the demographics helps you, right? The patient doesn't have AFib or any risk for cardioembolic disease. That helps you think it's ICAD, right? The patient has strokes in the same territory, in particular if they are like scattered border zone strokes versus having wedge-shaped strokes or strokes in other territories that will think more like, oh, this guy probably has a fib or cardioembolus, right? The type of occlusion, if it's an occlusion that tapers like a pencil, okay, versus a blunt occlusion with, so you have to suspect first. If you suspect, then you can prevent. How do you prevent? Use intravenous cangrelor, tirofiban, eptifibatide to prevent reocclusion. The way we do it is we do our thrombectomy. If I think there is ICAD, I give eptifibatide, that's what I have in my center, and I watch. And I watch that patient on the table for at least 20 minutes, not less than 20 minutes. If the lesion looks like it's going down, right, then I'm committed to stent. At that time, the patient is fully therapeutic. Having said that, if this is a recurrent stroke in the same territory, I know it has already acted up, the patient was on antiplatelets, I make them just stent at that point. Or if I feel it's true and ugly of a lesion that I think is going to reocclude, right, or if I clearly see a disectomy in the plaque, I will use stent. I decide on the stent based on those principles of diameter, greater or less than 2 millimeters, different in length zone, length of the lesion, curvature of the lesion. And after I stent, observe the patient for another at least 10 to 20 minutes to make sure the stent is not going to thrombose. I then start the patient on a drip. do my dual energy CT. If everything is okay, I load with ticagrelor and aspirin after a couple of. And I think this is a procedure that is going to be done more, not only for ICAD, but I really think if you are giving 2-3 passes, maybe as opposed to keep trying, you should just deploy a stent. It probably doesn't matter if it's a bad clot or a plaque. It will fix both problems. As you know, there is a lot of excitement now about studying this in a randomized clinical trial. So we have collaborated with things like that in the past.
I don't know if Ivan, are you in the room, Lily? Maybe Ivan, you can talk about your, I don't know, you're not here tomorrow. So Ivan, you guys have done cases of OCT going back, thinking it was an atro. Can you tell us what you found there? Because I think this, you alluded to this, right? ICAD versus clot that is shutting down again. Again, we think is atro, but Ivan, what do you guys find on your OCT?
Yeah, we did a very interesting case with Giovanni a couple of months ago in which we treated a stroke patient with an M1 occlusion. We did several thrombectomies, I think 3 or 4 passes, and we had only a partial opening of the artery. We decided to stop. And a couple of days later, with Giovanni, we ran the OCT. And what we found was that there was not an underlying atherosclerotic disease, but there was thrombus, which we were not able to open. But OCT was really helpful in that case. I don't know, Giovanni, if you want to add something.
I think that would be the advantage. If you have OCT, which is very, very high resolution optical imaging, you can see very well the microstructure of the vessel wall. You can not only differentiate between normal arteries and a plaque, you can also differentiate the type of plaque. And like in this case, we didn't know if a stent was needed. And in that specific case, the vessel was completely normal. So you can rule out 100%, you know, that it is not atherosclerosis, and then you can treat the patient accordingly.
Yeah, so just to illustrate what you said, right? I think we'll get to the point that we're going to have a better standards, better approach for this lesion that we know it's atero, or is a sticky clot that is just populating again. And then the next one is, you alluded to this on your Atlas approach. We had exactly the same experience. You put a stent and in front of your eyes, in spite of 2B3A or cangrelor and a stent, the vessel still shuts down. So that for me is the question about design of these stents. Is this something that, you know, there are guys doing this Europe with Elvis Evo, so like a tighter mesh on the stent, just like on carotids with migrating to a dual layer or tighter mesh. With big fan of closed cell stents for carotid. I'm convinced, and there's data on that, that closed cell decrease thromboembolic complications. What is coming on new design for intracranial stenting for atero?
I just want to add that with Vitor, one of the cases we did was a wing span and an atherosclerotic case intracranially, and you can see, first of all, under expansion of the stent, but more importantly, the plaque component is just protruding through the stent. I mean, it was really ugly.
One of the problems with these self-expanding laser cut stents, their metal surface is just about 10-12%, 9-12%. It's very little metal, right? So you can get a lot of plaque extrusion. And then with the open cell designs, you also have struts kind of going to there. So this all creates like a thrombogenic environment. The only other thing I can't forget to say, in thrombectomy, okay, before you assume it's ICAD, so in thrombectomy, you do your pass, there is a residual narrowing. There is at least 3 situations, or 4 situations you need to think about. One is it may be residual clot. 2, and this is very important, it may just be vasospasm. So always think about giving vasodilators, intraarterial vasodilators, waiting a little bit, and that may go away, right? And then yes, it can be a plaque, and less likely it can be a dissection in the vessel. But these are the 4 things. Gotta think. I have an LVO, do a thrombectomy. Now I have a narrowing. don't think it's ICAP, right? Vasospasm first, because that's easily treatable. So give intraarterial vasodilators, have very little to lose, right? Residual clot, right? Plaque, and very rarely you see a intracranial dissection after the thrombectomy. It's very rare.
I think it's going to be very interesting to talk to Remover Money about coronary pathology. She's going to just give you a whole list of plaque erosion, plaque rupture, plaque this, plaque that. For the brain, this is mute, guys. We haven't done this. We haven't traveled this road. I'll bet on this. I'll bet, again, at Mary in Memphis, every week, there are like a 530 cadaveric heads there. Why we don't study these vessels? Again, any lab that gets fresh cadaveric heads, there's no reason. A lot of the times they don't even use the head. Why we're not studying these vessels? Why we're not saying what's happening to these vessels? I'll bet on these stents that you give integrally in an atlas. It's just a very shallow plaque that the whole cap disappear. What they call plaque erosion. It's just this whole massive exposure of yeah.
So as somebody who does research, getting fresh cadavers is actually not a trivial matter. Number one. Number two, the reason that we've studied it so well in the coronaries, and Renew has done amazing work, is because we've been doing bypass for how long? Right. So you have access to the specimens. You actually get them. Same thing with endarterectomy. So systemic atherosclerotic disease has been really well studied for decades now, going back to Syed Glagov and Chris Sarans in the 60s and 70s. We just don't have access to the specimens.
We have no effort on this problem. There's no access. People die from a stroke forever, and before thrombectomy, they're dying even more. What do you do to these people? Nothing. Give aspirin, NG tube. Thrombectomy is much newer. I agree, respect. We're just celebrating 10 years, but we need effort on that because these people continue to die. We don't do anatomopathological studies anymore. Again, there is value there. And we're trying to work with Giovanni and the team on that. We need to study better this disease and learn that. So we have to go for lunch in 2 minutes.
Great. I'm hungry, so I'm ready to go. But I just have to respond to that because we work very closely with our neurocritical doctors, and they are very reluctant to talk to the families about donating that patient to.
And just before lunch, from someone who do procedure to make a living, I think it's pretty short-sighted. We talk about this stent, blah, 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 blah. Keep in mind, if all of you in your life right now tell people to quit smoking, make sure they control their cholesterol, a lot of them maybe now on Ozempic or other medication, we're probably going to have a more tremendous effect from stroke from ICAT. So all this specialized discussion at the end of the day will make a little difference for a little amount of patient, while we have tools to treat all those patients and help them tremendously.
Notion that I can't wear.
All right, let's get some lunch. Thank you, guys. Back at.
Guys, please, 1 p.m. We have a master talk from Professor Pedro Lilic. Please, 1 p.m. Let's be here.
Are you talking? What are you talking about? You know what you're talking about, right? As a mechanism for.
All right, so just let me know.
That's gonna be a problem. With what-
Okay, right here, what would you recommend here?
Okay, you're connected?
Hello, 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 hello.
Yes, yes, you're connected, correct?
Thank you, thank you.
Yeah, there's two microphones on. You're connected? I don't know which of the three is yours. Which is your tech? AV tech. Number one, number two, number three. Oh, which tech should you need to unmute the tech, the correct video. AV tech. Number 1, number 2, number 3.
I have control of the screen.
Could the tech please arrange for the audio, correct audio, please?
I would like to go ahead. Thank you.
Could the tech please arrange for the audio, correct audio, please? We need the audio feed, please.
All right. Hello again, everyone. I'm gonna go ahead and get started with the exciting section. It's gonna be interactive case presentation. So sit down, get ready to be quizzed. Again, we're lucky to have great speakers and visitors here, so we like to use this opportunity to learn from them. We're just going to present some cases, but again, it's going to be interactive, so feel free to ask any question, and I'm happy to discuss this. To begin with, I'm going to present this case. It's an interesting case, 44-year-old with right-sided weakness and aphasia, NHF 27. Anybody in the audience on the right side, what do you guys, there's an impression, but what do you guys see on that screen, the imaging wise? What do you guys see? Where is the problem? Left MCA, very good. This is an impression. Usually we don't, obviously report may take some time, so we see the images on our phone. We may not see all the details images, but correct. So there looks like occlusion right here. You guys see that? So can one of our research fellows tell me what section of the MCA is this right here? Go ahead. M2, excellent. So, and it says right here actually, but you're correct, exactly. Left M2 inferior division occlusion. And actually we have some of our neuroradiologists here. So we rush this patient to angio suite and this is what happens. So this is the first run. So we put a catheter here in the carotid, we're injecting dye, and it's magged out. I call this a cheating view because you can see the intracranial vessel and the base catheter, so then you can go up rather than taking multiple images. What do you guys see here? So obviously the occlusion that I mentioned was right here. Is there anything else abnormal in this image? Whoever does not know this case. Can anybody tell me if there's anything else unusual about this view for this picture? Nobody? All right. One of our fellows, if you guys were in this case, could you tell me if you see anything abnormal? Yeah. Okay, so as a radiologist, you're going to tell me that there's something here that you may not see, right? So I guess what I'm asking is there anything unusual about this? So what Victor appropriately said, we had talked about the occlusion here, but there's this thing here. And at the time, obviously, I wasn't sure what we're dealing with. But then let's go back. The NIH is 27. Typically, that's unusual for a M2 occlusion. And that would be more like M1 occlusion. So correct. So there's something there. And the question is now, what are you going to do? Well, so here, the decision was actually, is Eric back in the room? No.
Show us the plain scan. How does his brain look?
Aspect was 10. He's a young guy, it looks really good. One other thing is, lateral is very helpful because in the lateral, if you look, you can see that this was not really M2. The point here was the whole MCA is not filling, so this is not usual. Actually, Eric was there and I saw this. I was like, Eric, where would you go? And he said, we'll just let the wire decide. And that's exactly what I did. So went through that M2 division, opened that up, and you can see that there. But then the other question is, what do you do after that? So you see that inferior division opened up. That is the branch that was also occluded. So this was a M1 in addition to M2 occlusion, and then went through there and opened that up. And you can see here that has been opened up. So there's a MCA coming out of the carotid. So here's your carotid coming up, MCA. And then there's the ACA, which then there's this branch comes out right behind the M1. That one. And Victor already mentioned the name of this. Victor, can you tell us again? What's the name? Correct. So that's an accessory MCA, which is a variant of the MCA arising from the ACA. It's different from duplicated MCA, which arises from the ICA. Prevalence about 2%, and it runs right parallel to the M1. It's just an interesting, obviously, normal variant anatomy that, I guess, as an interventionalist, when you see an M2 occlusion, you just get ready to go. You have to pay attention to the images. All right, I have another case. This is a 52-year-old who presents with progressive left-sided weakness over 4 days. He was ready. He was already started on medical management, blood thinners. NIH was 4 at the presentation, so no intervention was done. Then progressively worsened, right? So on day, 4? Yeah, it was up to 12. We already knew that there was an M1 occlusion. So what would you guys do next? Huh? Post it. I like it. Of course, if it was me, just post it. I don't even ask questions. Good. Somebody asked about hemodynamic. Very good. So these were progressive despite medical management. And I think, I ask you guys, what is optimal medical management, Dr. Hill?
For someone who's
Sorry, NiHO4, so you decide not to do a thrombectomy.
You're gonna double antiplatelets, right? Maybe a statin if he needs it, and you're gonna make sure he's well euvolemic, and you may actually end up treating his blood pressure because we're now 4 days in. You would maybe start him on depending on what his blood pressure is like. So you may have one possibility here is you over treated him.
Right.
We'll have to see. You'll let us know.
Yeah, so the important thing here, as you said, is, this is day 4, so don't bring the blood pressure down. But as Dr. Hill said, we all consider some sort of blood thinner. I don't think it's standardized, right? Heparin drip, do you use heparin drip? Actually, Raul, do you use, you have the M1 occlusion with NIH of 1 or 2. What do you do for medical management?
We hold the blood pressure medications, and you probably have this patient on aspirin.
Aspirin alone? No heparin?
Aspirin or more.
How did my picture get there? So optimize medical management, right? At the acute setting, permissive hypertension, blood thinner, statin, watch him in ICU, but the patient worsened, and we did not drop the blood pressure. So what would you do at this point? Anybody would hesitate to take this patient for revascularization, I guess. Right, so we got a CT. CT looks good. And here are the images. Now, what is unique about this image? Hopefully, I see Eric is back there. Anybody want to say what's unique about this image? I'm being vague. What is this image over here on the right of the screen? This one. Derek, would you like to tell us about this image here? And do we use this currently? Or do we do this, I guess? Right. I mean, this one, typically we use a map of the Viz or Rapid.
Process. Got a MC perfusion deficit.
Perfusion deficit in the right M1, right. So to Dr. Hill's point, M1 occlusion, perfusion deficit, and plain CT looked okay. There was some stroke, but not bad. What would you do next?
In terms of etiology, right, you should have a high suspicion for intracranial atherosclerotic disease. These are typically patients that have a higher likelihood of presenting with LVO and low NIH.
Do you mind using the microphone so everyone can hear?
So,
group of patients that has a higher likelihood of presenting with LVO and low NIH stroke scale is intracranial artery patients. And if you actually look at your angiogram there, you can see that the A1 is bigger than the M1, right? So I think
you guys see this right here. So this is the M1 origin and it's blocked.
Yeah.
So what he's saying is ACA is coming this way. There's some disease already at the proximal M1.
And even in the distal ACA, you can see some areas of ICAD. If you look at
Would you, so I guess the question is, would anybody, so this is 4 days out. Would anybody try to get the vessel open? Show of hands. Yes, yes. Okay, anybody would not like to open up the vessel, NIH of 12, 4 days out. So we don't care about American Heart recommendation, 24 hours for thrombectomy, right? Good. No, I mean, if the imaging looks good, the brain is salvageable, I think that is very reasonable. Raul, would you change your method with suspicion of the ICAD at this point, or would you just go for a thrombectomy?
I probably would start with a thrombectomy.
Now, what if this was
one question? Was there a dense vessel sign on CT?
No, but I'm not 100% sure. Now I'm gonna. What if this was 2012? In 2012, I wasn't a resident. See, it's about 12 years ago. What would you do in 2012, Dr. Savage? Good.
I would have intervened.
Same for thrombectomy, basically.
Yeah.
So I guess Dr. Hanel just came in. Dr. Hanel, we're talking about M1 occlusion 4 days out. Sorry, I put you. That looks good. Aspect is good. It's not a large core.
Why are you waiting 4 days? You're
Good.
trying to break a
All
world
right,
record?
No, I think that record is already broke. Is set at 6 days, I believe.
By
So.
Dr. Newman.
No, the patient came with NIH of 4, now worsened to 12. So we're talking about that. Dr. Savage just said that he would revascularize. The question that I ask is, what would you do in 2012? And the reason I bring this up is very interesting because as I'm going through this time history, do you guys see a name up here? So this case was actually 2012. I remember I was a resident. I had no idea what's going on. And this, I knew Raul or Dr. Nagora at the time. He called me. It was like 11 p.m., 10 p.m. I don't remember. And he said, listen, do you want to do a case poster for the conference? I'm like, sure. When's the deadline? Tonight at midnight. I said, sure, I'm about to go to bed, but obviously I was resident, I really want to get things done. I wanted to present something. So sure, what do I need to do? Here's the data. Can you just put them together and put it on a case? I don't know if you remember, but at that point, I was in Pittsburgh as a resident and you were at Emory. No, actually, I don't remember where you were. Where were you in 2012? Okay, because before that you were in Boston, right? Right. So, I mean, I knew Raul said, well, if he's calling me my cell phone, I would obviously get out of my bed and just do it. So from 10:15 or whatever p.m. till right before midnight, I put these cases together. I submitted, I believe that was SVI. And at that point, I was happy that I submitted this one poster, 2012. And what brought this up is, back then, he was already thinking about revascularization, not only M1 occlusion. The title is Endovascular Vascularization of Complete Subacute to Chronic Atherosclerotic Disease. So basically, we had total of 24 patients who had similar to this one, M1 occlusion or viscerobasilar occlusion intracranially, subacute, so over 24 hours, and had fluctuation of symptoms or worsening symptoms despite medical management. And we presented the cases that overall, when we revascularized them, they did well. And in those trials, actually, majority were either bare metal stent or balloon mounted stent. So none of them got a thrombectomy, which is interesting transition. Because now you said you would do a thrombectomy, and Eric said he would do a thrombectomy as well. Obviously, I did not do this case. I don't, probably was tutor, or I'm not sure exactly who did that case. And then this was from the paper. All right. I was going to ask you if you want to say anything about this.
Just the results, you showed the results, right?
Oh, results of the paper? Oh, yeah.
So what was the treatment?
This was a balloon mounted stent. Yeah. So out of 24 patients, almost half got balloon mounted, drug eluting, half non-drug eluting. Only one angioplasty was done. So majority was drug eluting stent, coronary stent. Anything you want? Do you remember this paper, or do you want to talk about this? Obviously, this is a small case report, but.
Can I just go back? Raul alluded to that, and we're running out of time, and we have good amount of time now, so we can go back to your stent selection. What I do a little bit different there, if I have a tough Mori C or D, and I'm forced to treat this lesion, I think angioplasty is a great tool for curvy vessels, long lesions. Yes, you have a risk of dissecting the vessel and be forced to use a stent, but it gives me peace of mind that I know this is a higher risk lesion. And if I can get away with an angioplasty, my feeling is that angioplasty, that's Buffalo, right? We published that 25 years ago. That was Nick Hopkins, suboptimal angioplasty, trying to decrease. And on that population study in Buffalo, that seems to be lower morbidity. So this is something that I think in perforator rich zone, something that you could add to your armamentarium of balloon mounted stent versus self-expandable stent. Here, what stent do you use?
It was a drug, either bare metal or drug eluting balloon mounted.
We have early in my career, I have 2 patients that I stent basilar. The vessel looked great. Both patients did not survive. Again, I create a circumferential. I shut down all perforators. So you do the MRI, the brainstem is white on the WI. That's again, I still have, I can close my eyes and see that picture of my brain. Because again, I'm trying to help that person. I hurt that person. So I think we got to strategize, try to avoid this type of complication. Because again, a marginal branch on a coronary, yeah, it's a 15-20%. They occlude. What I'm talking about, guys, when you're cleaning your road, if you live in Pittsburgh, Raul loves to come here because he's from an oceanfront community in Brazil. But when you snowplow Buffalo or Pittsburgh, the driveways, I don't care. I'm cleaning the road, driveway is yours. The driveway on the coronary is called marginal branch. Yes, a smaller heart attack. It's a muscle. Our smaller marginal branch are perforators on this area here or on the basilar. These perforators can be very disabling strokes that we are causing when there is no plowing the main road. We're shutting down the driveways, and on the brain that's really important. On the heart, maybe less.
Anything else about this case? All right.
One more.
Sure.
Or you? So Raul said he waits 20 minutes. Okay, now this patient is on integralin. You put a balloon mounted stent, so it's as heavy as you can do in terms of intervention. And now the stent shuts down. So what next?
So
chances are it shut down because you were not therapeutic. Because one of the things you do, right, is we are all afraid of going full dose in the acute setting because of the risk of brain bleeding. So you could be subtherapeutic. So what I probably would do is I would go as close to the stent or in the stent itself and infuse glycopotential B3 integralin essentially.
So you
in the
give
operation.
intra-arterial rather than intravenous addition at that point.
I think if I have stent thrombosis, yes. In the past I've used more intra-arterial tyrosine or integralin. I think the data actually it's not great. It doesn't seem that it's better. It may actually be worse than intravenous. So there is no big advantage. But I think if you have clot on coil or clot on stent, that's when I consider local intra-arterial.
Another thing, and Giovanni, are you there? No. So maybe Giovanni can talk a little bit why OCT is making a difference for coronary intervention. What is very interesting, we did this case that Matt was alluded to. There's another case that we did. We go to drop the stent. You look at your angiogram, you measure the plaque from here to here. So we all know we have to bridge the plaque or the dissection normal to normal, right? So you're covering the whole lesion. So you go on your angiogram and you measure normal to normal and you run the OCT, it's not normal. So I think one of the things I think we could be doing when we see this, and it's not a very common event, but we see that, it's quicksand, right? You're building a bridge and there's sand on both sides. So there's nothing for the bridge to hold on. And this is thrombosing because you didn't cover the whole extension of the plaque that is exposed from the plaque erosion that we talked earlier. So this is something that we have to keep in mind. Why does OCT makes a difference in coronary?
No, I think this is a very good point. So what we learn in the coronary artery space is that you have an angiogram with a plaque, with disease, with a stenosis. And unless there is a huge amount of calcium, you don't understand what the plaque is, what the morphology is, what the disease is. So, I mean, in the coronary space, you can use OCT to guide the intervention. So, for example, if you have a lipid plaque, like a soft plaque, you can do direct stent. So in the coronary space, people avoid to do balloon angioplasty followed by a stent if it is not necessary. So, lesion preparation is a big topic using intravascular imaging and makes a huge difference. There is a lot of clinical trials, randomized trials that show that stent expansion is one of the key metrics for success in the coronaries. And lesion preparation is key if you have calcium, but also calcium doesn't all look the same. 360 degrees of calcium versus 180 versus 90 degrees, very different when you implant a stent. The thickness of calcium is different. There are so many different ways to fracture the calcium, and the different type of calcium allow you to pick the best device. And then after you implant a stent, there are a lot of key parameters. Like if you have a big lipid plaque, you don't want the edge of the stent to land in the big lipid plaque. Is a very high risk for thrombosis. Then, for example, you can cause a dissection because sometimes the reality is, yes, you want to put it normal to normal, but half of the patient, they don't have really a normal segment. So you land in the best possible segment, and sometimes you land in the middle of a big fibrotic plaque. It's not a problem per se, unless you cause a dissection. Now you see a little bit of a dissection in the angiogram, but not all the dissections are the same. If you have like a dissection cutting all the way through the media, you have to intervene. If you have a little dissection that is just an intimal dissection, you can leave it alone and monitor the patient. So I think with OCT, with intravascular imaging, you can see what is the type of plaque, even within the same type of plaque, what's the actual morphology. So a lot of details there. You can then optimize your stent, and then you can also image after intervention to make sure that the results is what you want to be. And there is a lot of actionable information you can get from OCT. So in the coronary space, it's also pretty good now, 25 years later, because there is a lot of evidence, you have workflows, you have a very, very pragmatic way to use OCT. And that's what I hope to see happening, of course.
So do we. Sorry, Nima.
No, that's good. That's good.
So I think, so that's my analogy, quicksand right here. Giovanni was able to articulate on Italian English better than Brazilian English. No, I wouldn't do that to you. It's really unfair to talk about soccer with Italians. If Ivan is in the room, I don't want to talk to him, but everybody else, fair game. But it's stenting on a lipid plaque, that stent doesn't hold, right? Because it is soft. So that's what I think we're seeing on our stent occlusions is either you're subtherapeutic on your drug or you're stenting soft plaque and it doesn't cover the whole plaque.
Would you say malapposition as well would carry the risk?
Oh, absolutely. So this case that Matt alluded to, we have just 30 minutes for OCT tomorrow, so it's impossible to show all this. But this wingspan was a disaster because you see that the stent, there's residual stenosis. Again, all the struts of the stent are pointing to the lumen. So there's turbulent flow. There's no good all position. So you just keep adding that. So you just hear thrombus, thrombus, thrombus. So eventually you're gonna get that.
All right. Good conversation. So 79-year-old with expressive aphasia and IHO4, Salvador. What do you see on that CAT scan? Let me rephrase. Is there a large vessel occlusion? So NHO4 aphasia.
No, I cannot see any
Good.
large vessel occlusion.
Can anybody see any occlusion on that CTA? I know we have our neuroradiologist, but obviously it's not fair, right? Because I'm not showing you all the images. So NHO4, it's hard sometimes to see in occlusion, but one thing that I like about perfusion is it's easier to pick up distal occlusion. So you can then, when you see this green, for you guys, the green here suggests there's a penumbra. So then you can go back retrospectively, look at the CTA and say, oh, sometimes, most often you can then see the occlusion. So there is a NHO4 aphasia. It looks to be M2 occlusion. So Ottavio, what would you like to do at this point?
For your pointer. Okay, I'm gonna go back to this slide. There's a very clever neuroradiologist from Mayo Clinic in Rochester.
Yeah, I'll do it.
That you ask him. So you saw the CT perfusion, right? So you ask Dr. Brinjijiki Walid, where is the occlusion? He's gonna show there. What does that mean? Somewhere on that branch down the line, there's an occlusion. Can you point to the occlusion? No, you cannot. But the CTP is telling you there is an occlusion there, patient deficit. So it's very hard for us. Don't be too hard on yourself. You cannot see the occlusion, but the CTP and the deficit is telling you that. So once the MIVO trials are positive, it's fair game to intervene on that. Sorry, Neem.
No problem. Ottavio, what would you do at this point? Medical management? Okay, that's fair. 28 cc penumbra and NHO4. Okay, I think that's very reasonable. Dr. Savaggio.
I would intervene. I mean, that's pretty disabling. I mean, I would like to see the plain CT. That's true. I forgot.
I was looking for that.
I forgot. Yeah, I would include it.
I was coming to that. You should have waited.
But I would want to see the plain CT because
I understand. I don't have the images, but CT look good. Yep. Sorry, were you gonna say anything else?
no, I mean, so that being said, I think the trial is absolutely appropriate. That's what we should do. I regret my prior decision.
It's very hard for it's rare for Eric to retract his statement, but so I agree. But this is my case. I did not have family, so I don't know. I cannot get a consent, so I cannot put him in a trial. I'm sorry. I'll try. But Ottavio, to Eric's point, for me, the patient is not able to speak. And for us, obviously that's a disabling condition. It's a lot different than somebody's having numbness. So if somebody cannot speak, I'm very, very sensitive to that because, I deal with patients who have a stroke and then they cannot talk or understand. And you see them in a clinic and their life has changed for the rest of their life, obviously. So for me, in IHO4 difficulty speaking, if there's a target, I think it's worth trying to revascularize. As perfusion suggested, you can kind of appreciate there's some perfusion deficit here. Who should I pick on? Actually, Dr. Hannah, would you like to pick on somebody? I'm trying to find out. I want him to show where the occlusion is at what branch.
Preclinical fellow, pick any of the three.
All right. So Victor, John is not here. Dr. Sue. Oh. Oh. John, where is the occlusion? Okay, what, I'm sorry? What branch, which division?
Circle like.
Yeah.
It's over there.
Right around here somewhere. Right there. So it's not completely occlusive, but you know, there's a clot right here. You see that right there? Obviously, I'm not showing you all the images. Dr. Hill, would you, if you had the family, would you put this patient obviously in the trial, right?
But I agree with you. Obviously, you need consent, so.
And what branch is this? MCA, what division? M2. Derek or anybody else, what division of the MCA? I'm sorry? M2. Anybody else? Not M3? Yeah, I was more thinking about M3 because for me, there's an M1 and there's a bifurcation and then there's another bifurcation. And I think there's, anyway. What color? Yeah. Okay. But for sake of documentation, I guess, what would you document? M2 or M3, I guess. It doesn't matter for me, but just learning anatomy, I think. I call it M3, but I think for the trial, it should matter, right?
There's a lot of debate, right? I mean, we're in the trial, we're classifying them just anatomically at the branch points, right? So this would be an M3 because it's a branch of the M2 by just the, but realistically in real world, it's about what's the size of the vessel and how much of the brain is perfusing. So, you know, there's lots of debate about how to classify these things. So
well, a lot of discussion, right? There's a lot of classifications. Most traditional is Roton, right? So Dr. Roton was worried about microsurgical anatomy, not endovascular thrombectomy treatment for stroke. So the anatomical division goes lumen of the insula and yada, yada, yada. So for us, again, I think it's what Michael said is spot on, right? Is size and function. So if they're, okay, this is an M2 and the patient NIH of 1, they both agree. It's hard to get these two guys to agree. They both agree that if it's a low NIH, maybe don't do anything. This guy's aphasic, right? I think everybody in the room, other than enrolling on MIVO trial, thrombectomy is reason.
Raul, sorry, go ahead. I was going to ask you after what comment you have, what method would you use? Because you had talked about the tortuosity rather than the distance, and I think there is some tortuosity because you have to pull that back. So the question I had for you was, what system would you use in this circumstance?
So this is an inferior division branch, and I agree there is some tortuosity, but here I would feel comfortable with a 3mm stentriver combined with a small aspiration catheter. I would have not a problem if someone preferred to use aspiration alone as well. I would have a problem with stentriver without the distal support of the aspiration catheter. I think that's when you can get into torquing the vessel and having issues with detachment of.
So I understand what you're saying. You're saying that if you put a stent here, stent retriever, and your aspiration catheter is here, or don't have an aspiration catheter there, you don't prefer that?
No bueno.
And could you again explain, because I think that's very important, because I think that could cause a lot of problems.
So it's the issue of having distal support, Ricardo, is used.
So it is.
Oh, nice.
His body is the brain. This is the stem. If there is no distal support, I pull the clot and the brain, right? But if I put distal support, I'm able to just pull the clot and leave the brain alone. Okay, so this idea of giving distal support will improve the force vector and you respect the brain structure better. You have less issues of detaching vessels and straightening and stretching vessels.
And technically here too, right? Again, we keep talking, joking, size matters, size matters. And 88 is not going to do you any good here, guys, because you're going to barely get on them one, maybe. But again, you got to be targeting. You're going to talk about an aspiration catheter here. Now you're talking about a 45, maybe a 35 or 38, whatever. I would probably try aspiration first, a subocclusive. I'll try to get my small aspiration catheter there. If it doesn't open, then I would go with probably for me would be a 13 and a smaller aspiration catheter.
Nice. So, yeah, we talked about all that. So Mevo, we had talked about M2, M3s, obviously smaller M2s. These are medium vessel occlusion, unlike our large vessel occlusion. And there's a trial, multiple trials for this, obviously, as you heard. Anatomically, we talked about this. So I just put this together like this because I actually was trying to demonstrate what Raul just tried to pull Dr. Hanel's arm out. Please don't do that again because I need him to, and Eric, because otherwise I have to say call more often. So I use a 13 Tiger actually, which you had mentioned, with a 46, I think it's a 46, yeah, Vector 46. And as Raul mentioned, I brought it here. You can see that this is our aspiration catheter. So the clot is here, and the aspiration catheter there, basically working it. And the Tiger 13 worked well, to be honest. Here, I gave it less credit prior to this. Now maybe I'm giving more credit, but the idea is I just wanted to make sure this does not change the vessel shape as I'm doing this. And I don't know if you appreciate, but here I feel like the vessel did not change as much as the stent was deployed. The angle did not change much. And obviously the vessel opened up. And interestingly enough, there was a occlusion here. What you didn't see was there's a branch that's coming right out there. So the clot was sitting right there. And we did not, or at least I did not know that there's a branch going that way.
And Nima, I think that for the younger in the room, right, you got to remember that clots are not going to stop in the middle of the road. They said, I'm here. They typically going to stop on bifurcation. So you're seeing one branch because the other branch is totally occluded. So we all have in mind our settled PE, right? That everybody can easily remember that from pathology lectures. Again, in general, all clots, majority of the clots would be settled clots. There are exceptions, but very often you're not seeing the other branch. So here it looks like it's subocclusive. It is subocclusive to this branch. Can you point the other branch there? So
the other branch is coming out this way, which you're not seeing.
But can you show that on the post for the team? So you see that other branch right there, right? So that branch that is coming at the 3 p.m., right, Dr. Nima?
Right. So the clot was here. This branch
was,
right
so
there.
look at the size of that guy. So that is a good chance that was the stroke, right? Ongoing. Right.
So this branch was coming out right here. And there's a clot right there. I was in the stent. Any comment, question about Mevo treatment or anything else to discuss? Very well. Start talking actually right after. Interestingly, I like to go back. Most of the patients with high NIH, they don't even remember anything. But obviously the Mevo patients do remember. And I remember the next day, it's like, man, I knew everything. I just couldn't bring him out. And then he's talking, and that's very rewarding.
Local anesthesia or general anesthesia for this?
For this case, I believe it was local. But would you mind telling us why you're asking that question?
No, I wanna hear from I don't know, Mike, if you have an opinion, Raul. Mevo, local versus general. What are you doing in Pittsburgh?
Local.
So we've been over the last several years being very much against general anesthesia. That has changed dramatically. After the data, I think I'm not convinced general anesthesia is better than sedation, but then convinced it doesn't hurt people as you used to say. Like in the past, we did everything to avoid general anesthesia. Now I think if it's a MEVO case, I think if it's an intracranial stenting case, if the patient is combative, my threshold to intubate is very low. I'm doing a lot more intubation now than I have ever done because that's what the data shows. It doesn't seem to be harmful. It's a good topic for a discussion though.
Do you have do you have any, like, do you tell anesthesia, or does your anesthesia
Absolutely.
team know, like, the importance of what you need to do or what they need to do?
Yes, so things to tell anesthesias, you can't drop the pressure, right? And also, and that's the other problem, right? So you can't generalize the results of studies to every location. You have to understand that these studies were done in general in the hands of good anesthesia teams. So you have to be quick. You can't drop the pressure. We actually have published about this in the past. If you drop a map by more than 10 points, that is independent predictor of worse outcomes despite recanalization. So quick, not dropping the pressure. I think it's very reasonable. And I'm doing more of it. I'm actually happier doing the procedures under general anesthesia. The commentaries are, there were 3 trials of general anesthesia versus sedation. They were the first trials to show that general anesthesia was not bad and was potentially better. However, they were all single arm, and they were done in centers that had low experience without general anesthesia, right? So if they did general anesthesia, that's what they did well. And then their recanalization rates in the no anesthesia arm was worse, which shouldn't happen. But because they were not comfortable not doing general anesthesia, they didn't do the procedures well. So I think there was a good reason to criticize those data, but now we have had multi-center trials, right, done in many centers, including centers with good experience with general anesthesia, that show that there isn't a big difference. So I think we just need to embrace the data, and if you have fast, good anesthesia at your center, it's very reasonable to intubate, if you so prefer. If you don't want to do it, fine. No reason for debate.
I think one thing that was missed or has not entered discussion as much in the trials that were done, they were German and Dutch and stuff, is that they compare general anesthesia to pretty deep conscious sedation. And a lot of what, I mean, certainly what we do in Calgary, and probably what you did before, Raul and others, is that there are some patients, they're 78 years old and they're a right M1 and they're just sitting there totally quiet, and you just have to anesthetize the groin at the femoral artery, and that's it. You don't have to do anything. And then you do the procedure, and then they're awake. And so we certainly find there are cases like that where you just don't need to intubate someone or even sedate them at all. Or sometimes we just get away with very light sedation, a little bit of midazolam and fentanyl, and that's it. You don't have to use propofol or dexmedetomidate or anything. So I think those kinds of patients have been missed in the trials. And I just would be cautious that there's certainly a big advantage to having a patient who does not require, an overnight stay in the ICU with a tube down their throat, right? You're avoiding ventilator-associated pneumonia risk and other things like that. So where possible, it seems to me that from a medical standpoint, critical care standpoint, it's great if you don't have to, but like you said, if difficult case, stents, patient's agitated, don't be shy to intubate your patient.
And Mike, I think it's the allude to an important point, which is if you do general anesthesia, there is no reason for not extubating the patient immediately after the procedure. Right?
So if you do general anesthesia, you extubate the patient immediately after the procedure.
Just re-emphasize, right? Local anesthesia, conscious sedation. So this is your colonoscopy. That's a deep conscious sedation, right? It's general without endotracheal intubation. That's no bueno on this patient. So they're going to vomit, they're going to aspirate. I have to say what Raul said again. I think I'm getting older. I'm going to be less patient. Do you guys agree? No, I'm kidding. Don't answer. Don't answer. Don't answer. I think sometimes it's, you know what, the patient is poor patient. She is struggling. She cannot hold still. Don't lose your cool because of that. She cannot hear what you're saying. You hear like 53 people, Mrs. Jones, don't move. So guys, she's aphasic. It's not gonna help. So if she cannot hold still, I think we have a lot of young people in the room here that are gonna be starting their own practice. Don't struggle. There's data to support that general anesthesia is safe with the caveats that Raul mentioned.
Yeah, I think that's one of those things that's going against what we're used to, at least in training and earlier. We've been keep getting saying, no, it's bad, it's bad. And I think it is shifting.
And before Naval, I don't know if they're in the back of the room, Naval or Chimasani say, and then this patient, you didn't intubate, this patient gets there with a CO2 through the roof and yada, 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 and the patient has to be intubated when he arrives to the ICU because the perioperative management was less than ideal. So we have to keep this in mind.
All right, we have just few more minutes to go. So just real quick, let's see. I think we already talked about intracranial stenting, so we'll skip that one. This is a case similar to what Raul had shown. Trevo does kind of, you see that pinching. Again, the question is whether or not that's athero or not. That's to be discussed. And then this last case, I wanted to, I guess this alludes to what Dr. Hanna was talking about, because patient is moving, and as you're pulling things, that tells you that number one, it's hurting because you're pulling the stent, and number two, the patient is agitated, so you have to be careful. And then last case, 66-year-old with the right leg weakness. I saw this patient in ER the next day, and the patient cannot lift up the right leg. The patient had come the night before, and apparently the leg worsened. Here's the CT perfusion, and this patient had a ACA occlusion. For the sake of time, even though it was next day, I look at the plain CT, there was already some stroke, but there was a mismatch between this perfusion and the plain CT. Again, not being able to lift up the leg means you cannot walk, similar to aphasia, disabling condition. I discussed that, it's perhaps reasonable to try to get this open. Past the clot, apparently use the target 13 again. I don't know why, but it did not open, so I had to place a stent. And you can see that on the MRI, there's some area that was saved, and more importantly, and this stent, by the way, is a self-expanding stent that is not indicated for stroke. But more importantly, the patient was walking, and I saw him in clinic and was able to walk, and I like walking. Thank you, guys. I believe if you want to present the next.
Yeah. I'm gonna show you guys. Can you hear me? Can you hear me without the microphone? Do I need the microphone?
We can hear you well.
No, that's okay, man. I can. So this is a patient of Dr. Nima that he treated for a symptomatic carotid stenosis on the left side. I don't control that, guys. Somebody, can you show my slides, please? I am, yeah. I am. I think there are two different cables. Let me try this one here. It's a Mac. Yeah. No, I presented that cable earlier, sir, today. So that's okay. Whatever you need.
And you just have to clear all that out.
Just hit back. It's quick.
It's okay now.
Go to presenter mode.
It's a quick time video, sir. There's no presenter mode. It's not a PowerPoint.
Cause I'm getting the feed from your computer.
Yeah, so do you mind if I try the other cable? Because I present that earlier with this, so let me try. So this is a 50-year-old lady that got a carotid stent on the other side. So left carotid was treated many moons ago. There was Dr. Neiman, and then she got lost in follow-up. Nope. I'll try the other one because it's detecting both, right? So it's just not showing the. I can copy this in a PowerPoint and see if they'll work. Display. System setting. Yeah, please. But it's not a PowerPoint, right? That's the only thing. It's a quick time video. Can Okay, sir, any thoughts? Our IT guys, Otávio, Salvador, any idea? Yeah, it gotta be. I'm just trying. Control center. Yeah.
Just drag it over. Same with mine, right? If you
Just drag it over there.
Just,
Drag where?
no, but can I just show you guys? Can I just
Yeah.
go to, go there, settings, where's your display?
I could not find.
Hold on.
Try general.
Sound wipers under general. Displays. And then you arrange. Using that one, right? Color profile, advanced night shift. Isn't there a way to get them so it's just showing your
You're my background. Right?
Drag it on the other side.
Can you go on your PowerPoint, Ricardo? Go on your PowerPoint.
Miro, yeah. I think you got it. Perfect.
There you go, bud.
There you go.
That's why he's the big scientist guy. So here. Thank you, Michael. So this is, she got laryngeal cancer, so she was not a good endarterectomy candidate. So she got treated elsewhere with a TCAR. And again, I would love to hear Michael, Raul, and everybody else. So this is her post TCAR treatment. So she has an asymptomatic disease, laryngeal cancer post radiation. This picture didn't make to the publication, but she had about a 60% stenosis, female, asymptomatic, non-invasive imaging. Thoughts to treat or not to treat? Since you guys are the most senior here, Michael, would you treat her in Calgary? Send to somebody to treat her? Medical treatment. So I think you gotta be very careful, right? Where you're sending somebody for treatment, because this is borderline, right? They agree with Michael completely, 60% non-invasive. I joke with the fellows, we always give a 10% discount. So if you look at the standards of carotid revascularization, they came from diagnostic cerebral angiogram. So if somebody has a Doppler and CTA showing 60%, if you go do an angiogram, you're gonna get at best a 50%. Asymptomatic 50%, no indication for revascularization surgically by stent, ENDART, or TCAR. And I'll pause and give my caveat on TCAR. I think it's a great procedure, but we have level evidence for everything that we do in the carotid revascularization. TCAR is mostly based in large volume database without randomization. So unfortunately, this person underwent a TCAR and the colleague that did the TCAR revascularization had problems. Raul, what are you seeing there? Do you mind grabbing the microphones right there?
That one. You want
Comments about TCAR are important. There is always a hype about any new treatment or technology. I think we need to be very careful because you have two great options in endarterectomy and stenting that have been proven over time to work well. I think TCAR is a great option, but in my book, it should be used for patients that are not good candidates for endarterectomy or stenting, which are not common, but they do exist. So I think it's a procedure that deserves credit. But yes, in this case, it looks like the stent is malapposed, probably should have been a little lower than what it is. And you have clot formation in.
So unfortunately, this lady that had no strokes before, after the procedure, she developed.
How long after the procedure is this?
I think she came to us after 2 or 3 events, and I think the TCAR was 4 months before. So options here. Raul, I know I'm just giving you one picture, so it's unfair. But what happened here, you see that better on cross-sectional. And when we have to do TCAR, and we published this because we had a similar situation in one of Eric's patients. When we puncture, you do a blind puncture to get to the true lumen, and then you advance your wire. If your wire is subintimal, you may not see that. So in Eric's case, Eric, do you want to talk about that case?
Yeah, so if you look at TCAR literature, I mean, it's extremely, I wouldn't say dishonest, but it's mostly self-adjudicated database that are filled by providers. So the value of that is quite limited. We do a lot of carotid disease treatment. So, endarterectomy, we do a lot, high volume, angioplasty and stenting, we do a high volume. And this new tool arrive and, you don't want to miss the boat. And there is some area that you could see that soft plaque, not really accessible surgically. I mean, this is all the way endovascularly. We don't have a perfect way to make sure that there's nothing going north. So reversal of flow makes sense. So I think we kind of embrace that. But I could tell you, I could give you a beautiful talk on all the complication possible of TCAR. And it's someone, I do think that we do a good job with endarterectomy and all this, but there is a little caveat to that. And the angle that you puncture the carotid is really steep. So you have this small needle, and it's really, really easy to not, you would think it's easy because your carotid is exposed, but it's really easy to be subintimal when you get your access. So you have a small wire that is really, really small, and it's really easy for this wire to go in basically you create a dissection. Now, it's easy to recognize if you pay attention to this, but you could easily see that somebody who does not do endovascular, that, the wire go north, you push a little bit more, it go north. And sometimes you could go from your dissection flap back in the true lumen. And that's what happened here unrecognized. So basically the stent more towards the common carotid is in the dissection flap. And then the stent go back in the normal vessel. But basically you have a stent that is in a dissection flap. So you're basically putting a stent across the normal vessels. You're basically like, putting a filter through that carotid. So that's definitely something that needs to be carefully looked at and recognized.
So you're doing this, and again, the imaging sources that we have vary in quality, and they vary in number of X-ray sources. So if you have just one X-ray source, you have just one direction. So it could be full, thinking that you're going one way, and when you look aside, everybody has seen that slide from Prince Harry's, William, whatever, one of them, going like this, and you look at the side, it looks like he has middle finger. When you look like that, those are 3 fingers. So that's just because of the projection, right? And the quality of the X-ray. So what the colleague ended up doing here, he went subintimal. And again, peripheral vascular surgeons intervention, they do that all the time. They don't care if you're in the true lumen of the vessel or not. They want to get from point 8 that is normal to point B that is normal. If you go subintimal, you cannot go outside the vessel. If it is lumen or parallel to the lumen, they don't care. Here it matters because you're creating a speed bump on the road, and the end vessel is not the foot, it's the brain, much more sensitive to that. So what happened here, unfortunately, this guy put a stent on the wrong location. He starts some implant without noticing, and then he went to the internal, and so that's a mess you're going to see here in a second. So this is a poorly placed T-car stent. We talk about the quality of the data, and number 2 is, we alluded to this before lunch, the type of stent. The stent that we use for T-car is an open cell, is a version of the precise stent, good stent available in the market. But if you ask a lot of interventions, do a lot of stent for carotid, and there's data for that, closed cell stents do a better job in plaque protection compared to open cell. So what happened here is a stent that is placed subintimal, and I'll show you a couple of options. She's already on aspirin, Plavix, and failed medical therapy. Discussion about going there to crush that stent outside the lumen. You're going to have to go through the struts of the stent, angioplasty that stent. So be a lot of metal potential to give her emboli. So quoting my former boss, you should have done the right operation first. And that's what we did for her. If this place here. So this is an endarterectomy approach. We clamp the carotid. This is common carotid. This is external carotid. This is internal there. And intentionally, we are allowing for back bleed. So I'm opening that. And you see the stent struts through the wall of the vessel. And we're opening there. So we're going to see stent here soon. So this is a carotid endarterectomy approach. You expose the whole extension of the carotid. So you see the stent right there. Now we're going to do something we don't do very often, but it's not that hard to do. We're going to cut the stent. So we're cutting into the stent. You see the wires look like barber wire. So now I'm seeing the plaque. So there's a super nice, we know this from all carotid surgery, super nice separation from what we call the intima to the rest of the vessel. And now you see how much clot she had on the lumen there. So you see the clot right there. So I'm going around that and I'm opening towards the common now. And you see clot. So all this, no wonder why she was having a stroke, poor lady. So I'm taking the stent out. So you see here where there's good stent position, you see there's a nice endothelial layer forming there. So now I'm pulling my stent out. And here the stent is rolling. And you're going to see, if I will pause here. Hurry up. So this instrument here, this is the lumen of the carotid. This is the false lumen. So he came through the false lumen and reconnect. So this is, my instrument is on the true lumen of the carotid. And you see that again when I play. See my instrument there is going on the true lumen. And so that's where the true lumen, I'm going to open, this is the true lumen there. So I'm opening that towards the common carotid. And now I'm going to have, instead of having 2 layers like I have up north, I'm going to have 4 layers because the intima is separated from the rest of the vessel, the other layers. And now this stent coming out full, look how much junk there is on that. So this is what a stent malapposition does. So it's here, stent malapposition plus plaque, plus the stent itself. And then we have to fix the mass. And thankfully, just more graphic. So now I'm going to close this. So now the upper part is easy. So we have super nice 2 layers, just bring them together. Here I'm going to tackle the intima to the outer layer of the carotid. So I'm putting a stitch to hold this together. And luckily here for me, I'm on direction of the flow. So the flow is my friend here, is going to tackle those 2 layers or 4 layers, 2 on each side together. So the footprint of the stent on the intima is super cool. We like that stent, so we're going to show it again. It looked like they were not going anywhere here, but that's okay. It looked like we're playing in circles here. But just to show what it did with the way you finish. So just let it back bleed, and it's, I hope that's not what we publish, guys, because it's playing in circles here. This is published. So this is post. Yeah, definitely is playing circles. So this was the post angiogram there. So this is it. You see where the stent finished, and you see here where I had to tackle that plaque, and so the stent is out and the vessel is clean. This is not to pick on TCAR. It can happen with any intervention, but I think we're talking about this at lunch, right? Setting the bar level. I think it's kind of sad that very soon we're going to have CREST-2 published, and TCAR, they're going to run with the flag. Oh, TCAR was not assessed on this, so we should be doing TCAR for all asymptomatic disease, because ENDART and stent are as good, if we look at the SPACE-2, are as good as best medical treatment for asymptomatic disease. TCAR was not studied. TCAR is better than the stenting, so we should do TCAR for everybody. I think that's we're going to have to debate and combat that analogy because we know it's flawed. So I think this for us, although we are intervention, this should be what is the best for each and every person that comes through our door. Any thoughts about, any comments about rebates or response to TCAR data? Michael, Raul, Eric, Nima?
Just for everyone in the room here. So frequently, like on Friday afternoon like this, we'll get a call from providers saying, you know, I have this patient who I hear a bruise in his neck and he has 85% stenosis. Could you see him emergently this afternoon? And I think it's important for everyone to understand that carotid stenosis, there's a huge difference. So what we need to know is whether it's symptomatic or asymptomatic. Asymptomatic disease, get back to what we talked this morning about a lot of disease in the blood vessel that is asymptomatic. A lot of time is best treated medically. Even if it's anxiety generating to think, oh, 85% of the artery is blocked, you have to remind yourself that this did not happen overnight. The other thing to keep in mind is that the majority of people, even if you occlude a carotid artery, it's the minority of people, if you occlude it in the neck, that will have a stroke. So the majority of people, mostly people who slowly develop stenosis, that have collaterals, which will prevent them from having a dramatic stroke. So in the past, we thought that everybody with carotid stenosis, if we go historically, in fact, Canada did a fantastic job defining who should be treated or not. But if you look at the data historically, and a lot of the data we still have was before there was Crestor, Lipitor. So we know that now somebody who has carotid stenosis that is not symptomatic, the risk of stroke is really low on an annual basis. In fact, it is, if you look at contemporary study, the risk of stroke is pretty much the risk that it was with surgical treatment. So the real question now is that, is there still a benefit in people who have no symptoms to proceed with an intervention? This patient is an example of that. This patient probably would have been best treated without any intervention. And now she got tangled in this mess because of a bad surgical indication. I think what is almost most concerning, that's what Ricardo alluded to, is that still people this day will operate on carotid Doppler. Carotid Doppler is a decent tool for screening, but it's an awful tool for that is not really sensitive. So you could have people, happens, in fact, yesterday, I saw a patient in clinic, was sent to me for 85% stenosis, got a CT angiogram, and there's 0% stenosis. So it's not infrequent, that is absolutely misleading. So unfortunately, there's still people who operate on patients who are asymptomatic only based on carotid Doppler, which at this point, there's absolutely no justification.
I have a question.
Results should come within the next year or
I
a year
know
and a half.
you,
That's going to help
yeah,
us
you
define
probably
whether
don't
asymptomatic
have the
patients
background. Could I
now,
speak to a
for
nurse? That would be nice.
symptomatic patient, it's quite different. Symptomatic patient benefit tremendously for treatment. And that, you know, we have two good modality, angioplasty and stenting and endarterectomy, and it depends of different factor which one is best. So I think that's about it.
So I just to illustrate where we are, and then we get Michael. So this is from September when I gave this talk at our national conference. And endarterectomy, the trial is done for asymptomatic CREST-2 We're all payers for that. If you pay for CREST-2, raise your hand. This is an NIH, is a taxpayer. That's why I present to the patients. We are paying. This is so important to know that we as US taxpayers, we're paying for this study. So do you want to be part of that? Yes or no is your decision. No question there, endarterectomy is one of the most common surgical procedures in the United States, in the world. And there's an abuse of the intervention being done. There's more endarterectomies and stents and TCARs being done than what is needed. CREST-2 was a study designed for that. The surgical arm is completed. We just enrolled a patient on the tail end. Carotid stenting should be done very soon. What is very interesting, going back to what Eric discussed, asymptomatic disease is a moving target. And this is the study that I was telling you about. This was published in October 2022 from Europe. They stopped the study early for many reasons, but one of them is you see here the division of that between stent versus best medical treatment, 40% of the stent and endarterectomy and best medical treatment, 200 patients, stent and best medical treatment, 200 patients, 113 treated with medication. And if you look at the results of about 60 months of follow-up, you look at those numbers, 2.5 for endarterectomy, 4.4 for stent, and 3.1 for medication. So no difference if you're treating these patients medically or surgically, stent or endarterectomy. Again, TCAR was not part of this. We discussed that. Don't need to waste or invest time on that. I think TCAR will be around the ballpark. Very hard to beat that 3.1 number. But what is very interesting, I think we're going to learn from that, and who in the future, once CREST-2 comes to completion, who should get revascularized for asymptomatic disease? And one of the things that we are part of that, we're on the top enrollers on CREST-Age that is looking for hypoperfusion. So we're doing a basic CT perfusion on that. And if the patient has a hypoperfusion, then you randomize for revascularization or best medical treatment, and you measure a very basic cognitive assessment of this patient at baseline. And you see if in a year down the line, these patients are worse cognitive or not, because there are hints on the literature that maybe that could be a sign to follow who to revascularize, people that have hemodynamic significant lesions to prevent cognitive decline. Michael?
Two bits of data, Ricardo. So I think in the US, about 90% of endarterectomies and stenting are done for asymptomatic disease. And in Canada, it's 90% for symptomatic and 10% for asymptomatic. And TCAR isn't paid for, so no one does it.
Yeah. So I think it's a super valid point. And that's the Achilles heel of pay per procedure. There is an incentive. The procedure is incentivized to do procedures. So I think what Michael has described, we see in our practice is not a criticism to the colleagues that are on the other side. Our endarterectomy practice and stenting practice, I think is about 80-20 in terms of symptomatic case. We do a lot of treatment for symptomatic disease. We're the stroke guys. So everybody with carotid disease comes to us. But there's a whole lot of asymptomatic disease being treated. And that's why the NIH put money behind this, because they ideally, I think we're going to see this. Look, time out. I think we got much better medication. Raul talked about ICAD. I think for asymptomatic carotid disease is on the same. Medications got much better last 20 years. Curb your enthusiasm, stop operating people that don't need operation. And I think that a great point, Michael. Thank you. Any questions, guys, about carotids? Anybody? Any more comments about anything that we discussed? If not, I think we're going to break and we'll come back for the last two talks of the day. And we're going to enjoy the afternoon with rain.
Hello. I wanted to give a quick reminder to the nurses, please don't forget to complete your evals. You can leave it at your table whenever they're done, but I need the evals from the nurses. Just a quick FYI. Thanks.
Oh, shit. Oh.
The first prospective clinical trial on the topic. With that said, Santi, appreciate you making time away from your beautiful family to be with us. Gracias.
more than I expected for sure. I don't think I deserve as much, but it's great to be here. Thank you for inviting me. These are my disclosures, and the main conflict I have is, as Ricardo mentioned, I am the vice chair for the initiative Mission Thrombectomy, which is going to be the topic we're going to talk about over the next 20-25 minutes. But before I start, I want to thank also the directors for the course to inviting me. I think I have a little bit of story to tell with every one of them. Obviously, Ricardo has been a mentor, and now even the last few years a partner in research, and definitely anytime I have a complex case, he's the one I'm going to call to get advice and get good outcomes. But also with Nima, I have a very good memory. I think I finished fellowship 2 years before him. He was starting just, I think, the first week of his fellowship in UPMC. And he actually visited because I was going to start the program, the thrombectomy program in Iowa. And I just wanted to get some exposure since UPMC was a beast at that time before the clinical trials. And Nima not only just welcomed me, but I kind of worked with him for almost 2 weeks, taking calls, seeing the patients. And even in the first 2 weeks of his fellowship, he was actually puncturing kids with 3 years old, getting access. And I was like, if this guy is doing that in 2 weeks, I cannot imagine what is he doing at this moment. I have to ask him what he's doing here in Florida for sure. And then with Eric, I had much less interaction, but I still remember I was looking for a job, and he was actually a faculty in Ohio State. And I was visiting there. He was a partner, one of my mentors, and I was very excited. I thought I knew everything, right? I came from New York, trained with a very strong program with Alice Bernstein. And then he kind of presented to me a case, and he's like, oh, you look at this stroke. This is a really cool stroke. And I was so excited. I said, yes, we can do this. We can do this. And it turned out that he just tricked me, and it was a tumor. And I had it all the way wrong. And then I don't know if you remember that, Eric, and I think that's why I didn't get the job at that time. But anyway, that's kind of little stories to share. But anyway, over the next 20-25 minutes, I try to just talk this outline. I'm going to talk about the stroke pandemic, which I think everybody is aware of. I think the access gap to mechanical thrombectomy, a little bit of the global picture, and one of the studies we recently did about the disparities in a stroke. And then I'll share with you the basics, because we could be here talking almost like a day entirely about Mission Thrombectomy, but the basics of the initiative, the goals, and a little bit of the achievements that we had over the last few years. I don't think I need to share with you that stroke is a pandemic. Basically, there are 13.7 million. We always say 800,000 patients in the US, but outside the US, there are tenfold that number. And it's actually responsible for 5.2 million of strokes per year in 2017, and it keeps increasing. Also, it affects tremendously the working population, with almost 116 years of a healthy year of life lost, which means basically people cannot work when they get a stroke. And in the developing countries, these numbers actually duplicate and triplicate. Just to give you an example, everybody knows about how horrible we had encountered the last 3 years of our lives with the pandemic, but a stroke actually causes the same amount of deaths that the pandemic caused in the entire pandemic in only 1 year throughout the world. Also, the stroke has major macroeconomic consequences. And this is a very nice study that was a collaboration between Mission Thrombectomy and the American Heart Association. And actually, it turns out that the expenses of a stroke are 1.6% of the global, the entire world GPD. And that, obviously, there's a lot of disparities between the different areas of the world. But about 0.7 are due to ischemic stroke, and the other 0.8 is due to ischemic stroke and subarachnoid hemorrhage and intracerebral hemorrhage. The bottom line is that with these expenses, it's very justifiable to invest money to reduce this cost, not only in the US or Canada, but throughout the world. It turned out that in 2015, we had a wonderful therapy. We had one also not as powerful, but also very efficient for other type of strokes, which is IV thrombolysis. But definitely in 2015, the game changed, right? And we were able to actually support or treat patients with the most devastating stroke that actually accounts for 90% of the disability, now up to 24 hours. And it became a standard of care in appropriately selected patients. However, and not only that, but also this therapy, despite some of the devices initially were expensive and they remained a little bit pricey, it was cost effective in developing and developed countries. This is a very nice study from Saudi Arabia, in which they show that the impact of treating strokes in a couple of programs that they developed really have cost savings, substantial cost savings of several millions over 10, 15 years of practice. Then, okay, we have a great therapy for the most devastating stroke. A stroke is a pandemic. Then what do we do about it? Why don't we treat them all? Well, you know, before the trials, there was an estimate, right, that these most devastating strokes, LVOs, represents approximately 4 to 14% of all the strokes in the US. Now we know pretty much that we have about 150 LVOs throughout the country, and approximately 1.3, 1.5 millions of LVO throughout the world. Unfortunately, there is a huge gap, and this gap basically in the US in 2016, only 20,000 of those 150 were treated. And in the last year, as far as I know, maybe Dr. Hills knows a more updated number, but we are treating about 50%, 40 to 50% of those. Also, if we look into our own country, there is tremendous disparity among the US. And just to give you an idea, in rural areas where I practice, which is pretty much 80%, 90% of my population, only one, at least in data from 2018, one of 6 LVOs are treated appropriately. And the population in the US, about 30 to 40% don't have access to a thrombectomy capable or comprehensive stroke center within 60 minutes. If we go outside the US, those numbers are even more remarkable. You know, in Asia, there are several countries where we don't even have data to support that the thrombectomy is performed in patients who need it, and the percentage of usage of thrombectomy is very, very low. And if we go to Africa, that sometimes a non-continent, the data and the publications are pretty much lacking. Then one of the first really strong projects is to kind of understand really the disparity and the use or the treatment of LVOs throughout the world. And this is one of the papers that's published last year in Circulation, in which we basically did a global through mechanical thrombectomy, which I'm going to talk a little bit about the initiative itself, but we actually took advantages of the infrastructure and really prepared a 17 very specific questionnaire about quality metrics shared by our regional committees and the experts in each specific region that was working with us in 75 countries, and really try to understand the number, the percentage of procedures, the ability of proceduralists, as well as the capability of the centers and how many centers per population. And it turned out that with about 1,000 responses, the global access to mechanical thrombectomy, roughly, and this is not just, this is a survey, it's not quantitative data, but it's approximately 2.79%. Only 3% of people who could be treated are treated, you know, 3%. If you go in some of the countries, it's even less than 1%. And there's a huge difference between developing and developed countries, low income, middle income, and high income countries. In addition to that, if you look at specifically country by country, you can see this graph, which again is very striking. The median was 2.79, but look at the percentage, the median percentage of treatment in patients who have an LVO in low and upper middle income countries. It's like in the low countries, even less than 1%. Then definitely it reflects that there is a lot of work to do. And when we looked into the operation availability, considering about, and as well as the center availability per population numbers, about 100,000, 200,000 to cover, we realized that definitely there was the same kind of disparity, and it was primarily run by the classification of income in each individual country. Then we classified among other groups and other initiatives, different potential targets or barriers to really get this access to treat acute stroke, and primarily focus on LVO. And we divided the barriers in diagnostic, physical access, diagnosis access, which is basically LVO capabilities to really know that the patient has an LVO in a quick manner, including in the pre-hospital state, physical access for mechanical thrombectomy, which includes availability of angio suite, of procedure list, and financial access, which is a very important problem in countries with low and middle income, in which some of them, they don't cover the procedure nor the devices. Then, okay, then how can we deal with that? It's a problem, right? There are so many factors, physical, financial. Then if we go back to more basic epidemiology concepts, treatments that can be considered for a need of a public health intervention that has a significant impact in populations are usually have to have several criteria. One is that they have a large health burden. Well, I told you, right, that the amount of strokes we have throughout the world, that they also are distributed unfairly, which I just show you the disparities we have not only in the US, but throughout the world. That is highly effective. I don't think there is many treatments in medicine that have the impact and the effectiveness that we can see with mechanical thrombectomy. And as well as I show you cost effectiveness. And then you can have evidence of some upstream preventive strategies that can cause an impact in this treatment. Then I think stroke qualifies perfectly. However, if you look into the regular models to apply public health intervention, this takes several years. And this is basically, if you consider all population, it's going to take about 5 to 10 years to really implement this therapy efficiently. There's going to be a very small percentage of innovators that will get it right away, early adopters, but it takes a lot of time. And we are, all this time that we are losing, basically are patients who are pretty much dying or getting very disabled throughout the world and depriving them from something we know it works really, really, really well. Then that's kind of the purpose of why Mission Thrombectomy kind of was born, if you wish. This is an initiative from the Society of Vascular and Intervention Neurology that several crazy visionaries, Raul is here on the audience, but Dilip Javakal took the lead on this one and basically decided that we need to do something. It's not enough to kind of treat patients in the US. We need to have a responsibility to do something outside, especially with the big disparities that are occurring, right? Then Mission Thrombectomy basically is an initiative that aims to accelerate worldwide access to rapid emergency mechanical thrombectomy treatment due to large vessel occlusion. We are more specified in the large vessel occlusion because there are many other great initiatives that focus primarily on different types of stroke or stroke as a whole. And how do we do that? Well, integrate the knowledge of barriers, study the barriers worldwide and in specific regions, unify multiple efforts, but with the key with working with local champions, local people who know their environment the best. We think we know, we don't know anything. We don't know anything how in Bangladesh stroke is taken care of. We don't know anything about how in Jamaica stroke is taken care of. And we need the champions who know the environment, who identify the barriers and help them out to maybe implement public health interventions to really get a couple of goals per year and really mitigate that problem. And as I mentioned, the way we do this is implementing public health interventions with the teams based on the goals that each region really select every year. And then basically this is what we try to do. That implementation that is going to happen, instead of being 10 years, 15 years, 20 years, we reduce the time as a whole. And not only in developed countries, but more importantly, in the developing countries that we know the percentage of people treated is so low. Then how do we do that? Well, the structure is a little bit cumbersome, but this can be kind of simplified in this scheme. We have a group of crazy volunteers that meet every week, which include myself, and we think we can make a difference, and we believe we can make a difference, and try to really work together in the different projects. We have US liaisons, which usually are people who identify very much with the region of study because they are from there, or they have a family member, or their parents are from there, and they want to help. These are all volunteers with no salary or anything like that. Then we have global co-chairs, which are people who are well known from other societies. I think Michael Hill has been very supportive to us. We have Sheila Martins, obviously Raul, and many people who really can give us and have tremendous knowledge on global health and stroke. And then we have the key members, which are the regional committees, which are the ones, the champions that really kind of take the task of identifying the problems and really implement the interventions. This is a more complex scheme of this, and this chart evolves every 2-3 years because obviously people get reelected, but it's a very big, strong group of volunteers with tremendous credibility in the field. We also have not only the society supporting us tremendously, but also liaisons with advisory committees, with other societies, including the American Heart, the European Stroke Organization, the World Stroke Organization, and we have a management company that also help us to manage all these now 105 regional committees that we work with to implement this task. And when we work with each individual region, we try to focus on several aspects, not only just to let's find out, let's increase the number of people who can do this. If that's a problem, we focus on that, but we try to kind of tackle the 3 pillars. Do a little bit of research, primarily focus on metrics and lack of resources is why the stroke is not working, training and education from everyone participating in the stroke care, and then something very, very important, because money is sometimes is the limit, focusing on really working with policymakers and the Minister of Health for each specific country to really help out to understand what are the limitations in those instances. And then this is just a little bit more specific about the regional committees, which, as I said, these are the soldiers that really make things happen. In each specific region, we have one neurointerventional co-chair or 2, one stroke co-chair. We actually, in the last years, we also want to have someone multidisciplinary from neurocritical care, from emergency room, on one of the nurses participating. We have one coordinator, which usually is a nurse practitioner, which that concept is very rare outside the US, or another member of the team, and then the valuable stakeholders for each specific region. And what they are assigned to do, if they want to be part of this, is number 1, we have a paper, which is the white paper. Now we are working on the second revision or second edition. And basically that really is distributed through the health ministers and the policymakers to really it's not a medical paper. It's just talking about the statistics, the importance of why stroke is a burden, why, what are the numbers, how it's efficient, how we save money for countries. We also share with them as a tracking app in which they can, to know how many strokes they are doing and how much improvement they can make after we institute the interventions. And then we also ask them to really identify, and this is the most important part, do some research, identify the problems in their own system in a very simplified way. We only want 1 or 2 per year, at the most 3, and then really come up with a potential plan for an intervention in which we can really help them out somehow by advice, by helping with the metrics, and or by providing resources that now we have available through registries that we work with or have a MOU with, and really kind of quantify performance and see improvement of these specific goals that every region. And without going too much into details, those actions could be just, for example, workshops. If there is lack of knowledge, a lot of places, for example, in LATAM, which I have a very strong footprint, other than Brazil, but for example, in Argentina or in Peru, in Ecuador, in other regions, they have amazing endovascular people that do a lot of hemorrhagic disease. They can do any kind of aneurysm that we do here, but they don't have the resources or the knowledge to do thrombectomy, and the integration with the stroke teams is not that great. Then we go and do workshops, explain to them the mechanical thrombectomy techniques, the type of devices, and obviously our partners from industry help us tremendously to get that achieved. We also try to, when we do visits, we do also symposiums like this in which we educate all the team members that really participate in this, and during this also we try to see if we can access to policymakers or ministers of health to really explain, invite them, and really make them participant of this. And then we also have a lot of formal alliances with World Stroke Organization. We are now have an MOU with the rescue registry, which is a very basic registry, much easier than get with the guidelines, but really can be distributed to these regions and really help them out to measure the metrics. And this is something that was studied in the European Stroke Organization task force. And then now we are helping, or we are participating, and they allowed us to be part of it and get access to this. Angels is another one, and there are several of them. And right now, this is a little bit, is not updated. We have 105 regional committees that we interact with them in monthly basis. Our management company does most of the interactions, but we try to do at least one or twice per trimester meetings virtually to really kind of identify problems, progress, etc. And we have over 600 volunteers from all these, not only from the US, but also from all these regions that are actively involved in the initiative. This is the white paper. As I mentioned, this is distributed automatically to everyone who wants to be part of this, and it includes a lot of good education. Right now, the white paper has been translated in over, I think, 20 or 25 languages, including Spanish, which Pedro, by the way, who is here, helped tremendously with me and my wife, and then Mandarin, Arabic, and other languages. Chinese is also now available. Then these are some of the conference we had to distribute in India. We have a strong presence, and it's tough to kind of summarize everything we have achieved, and I have 6 minutes left. But basically, since 2016 to now, we are trying to do the best we can every year. And some of the major achievements is we basically, in 2019, we got a structure the way I reported to you. The white paper came in 2020. With the pandemic, things slowed down, but we continue gathering data. And we actually have a couple of papers about the influence of pandemic in the different regions of the world. We now have 105 regional committees, and most importantly, over the last 2 years, 3 years, we've been quite active. And I'm going to show you a couple of things that we have been doing in 2023. I think now we are part of the advisory board of the UN, which I think every time there is a kind of problem or a discussion about a stroke, we are down on the table and really help out to really discuss the topic. Also, we are very involved with the WHO in recognition, and now mechanical thrombectomy has been recognized not only because of us. There are other players on the table as an essential surgery, which is a big achievement. Collaborations with the 4G Alliance, American Heart, WSO, it's on daily basis. As I mentioned, we have a registry that we can provide now to the regions to really collect data and see progress. We have started a train, like many others, with the advance of technology, training program, which is virtual, in which there is a two-direction communication. They can see what we do, and they can see live cases that we perform in some of the hospitals that have the technology, and at the same time they can ask for advice or supervision. And this is now in process. It started in 2023, and now this is the year we are kind of developing this more intensively. And then also servership to people who have been trained already. We are not trying to train people because that's not the purpose, but people who have the training and the basis, but they want to acquire additional knowledge in mechanical thrombectomy. We are also developing that. And then resources is, again, the resources are limited for all of us. We definitely partner a lot with industry. We are also getting some grants and applying for foundations, and everybody who here asks for another country or feel identified with the mission, let me know, because we have plenty to do and plenty of room to get more help. And the approach is usually from basically we go from bottom and up. And we start with just basic education. This is a campaign we did in 2022 with Be Fast Challenge, in which basically throughout dancing, which is something that is not a language, it's like a way that we express ourselves in different type of dances. We try to educate people about the different deficits that a stroke can cause. And there I can show you some cool videos from different types of dances, from tango to any other dance in Asia, in which you can really, people really can show how, some deficits can be mimicked, and people can learn from this. This is actually the same campaign in the World Stroke Day. in Bangladesh, which is a country that in 2018, they were, at least in the public sector, they were not doing thrombectomies, working with one of the hospitals. The number of thrombectomies with some support is been increasing. Now, with this data from 2021, but now we have 2023. In Indonesia, which I think Ricardo visits once in a while, we also work with some of the champions over there, identified that there was a very important shortage of neurointensivists, and also the distribution of the centers for the amount of population that the country has, which is 280 million, 208, almost, you know, the population we have in the US, right? And basically they had only 13 mechanical thrombectomy capable centers. Then working with some of the public sectors, we were able to duplicate the number of thrombectomies in those centers, start a fellowship program just to train more local endovascular people, as well as improve and help them out to improve their hyperacute stroke protocols. In the Caribbean, there's several people have done tremendous job. We have done a couple of also due to the proximity workshops, one for the English speaking Caribbean, one for the Spanish speaking Caribbean, in which basically we brought a lot of people from nurses, as well as techs, as well as proceduralists, and really kind of work with them in the different techniques and devices that are available for the techniques. With China, with the limitations, obvious limitations that we have in terms of access, we have worked with several committees. China, due to the population and the huge extension, we have 4 different committees in there, and the numbers, not only because of that, obviously because of they are doing a great job, but we have been involved in some of the development and help them out with the protocols. And as I mentioned, the observership program, which now we're working very close with some of the companies that provides the technology in some of the US hospitals, and we are also evaluating a couple of people from different regions that are interested in kind of getting this observership to work with us. And we have started already 1 or 2 cases that were actually recorded and actually were live and presented to the team. And then I mentioned about the UN and the WHO. And then one of the things that now is in the process is we have built a mechanical thrombectomy access score, which basically was the research we did over the last 2 years, and the paper is now under revision. Hopefully will be published, but basically the idea is to apply a measurement of, to really evaluate what are the countries that need more help, less help, and in what areas or what specific domains, and really try to implement. And then the empty glass 2, which instead of being just a survey, we are trying to get more granular data from different registries that now are implemented throughout the world to really evaluate the disparities and the areas that we need to work on. And I think, and I talk about the rescue the rescue registry, which is a basic registry of mechanical thrombectomy, but really helpful to really measure and evaluate. This is a project also very interesting that we are also having under review now, in which working with engineers, we are trying to come up with the geomapping assessments of big regions. This is actually India. The whole country is being geomapped, and then you can really evaluate the distances from different strokes to the different hospitals with different capabilities. And that might help the governments to really identify the regions that need more mechanical thrombectomy or comprehensive stroke centers. And I think with this, I'm going to finish. The conclusion is basically, and it's perfect timing, but just we know that we have a very effective treatment. Fortunately for us, but unfortunately for the rest of the world, is not available to everyone. And even in the US, we have a lot of work to do to make it better. We know that with public health interventions, especially when we sustain them, they can make a difference. And we have a lot of work to do. And working with multi-stakeholders, collaborators, our industry partners, we hope that we can really, and the policymakers, to really make them understand that this is a problem worth to invest, because it will save them money down the road. Hopefully we can make a difference and keep improving quality of life of many patients with acute stroke. Thank you so much for your time. I don't know if there is any, is there room for questions or?
Santi, that was a great talk. And again, thank you very much for coming and giving such a provoking and interesting talk. Few things. The way I look at it is, some countries you say it's less than 1%, right? So basically, you have not much to lose, right? Even if you bring that up just a bit, that can help so many people. In the world, 3% penetration of thrombectomy, it is sad, although we're early in this stage. The question that I have is, obviously, there are going to be many, many challenges to come. The devices that we use, that we take for granted, and I appreciate that, obviously, but that is a challenge, right? So how can we work with the companies to provide these kind of devices to the third world country where obviously, money is going to be a problem?
Yeah, that's a very good question. I don't know if any of our industry partners wants to answer that one, but I think this is a very important. There are two things. One, the decrease in the prices, and two, the government to believe that this makes a difference and really, buys it. For our Brazilian colleagues, it took almost a decade to convince their own government, and they have the best champions in LATAM to kind of create, build clinical trials, right? Then it is a difficult problem, but I agree with you. I think maybe the margins for profit in these countries need to be revisited. And I'm sure companies do this all the time, but remember, the biggest market is always US, right? Because the prices are higher, but also quantify the amount of people and amount of strokes that you're going to treat in India, in China, in Pakistan, in Bangladesh, in Indonesia. It's tremendous. Then I think definitely prices need to be looked at. So that would probably help tremendously for the policymakers to consider covering those expenses. And then we need to keep bringing evidence to support that this is a cost-effective therapy, even in the developing countries down the road, because of the ability to people for recovering from it and go back to work and produce, not being with the family, because there are no facilities over there. Being with the family a burden for the rest of their life. Good question.
Last year, I was in the Philippines, and very organized, planned guy that I am. I called Santa like at 2 p.m. in Manila. So I think 2 a.m. here, and he answered the phone. So, can you give a talk about MT 2020 for a group of people in 2 hours? Santa, oh, sure. So fast forward a year, Santa, is MT 2020 represented in the Philippines?
Yes, it is.
Okay.
There is.
So there'll be an opportunity June 24 to 28, a little more advanced than
please,
2 hours.
Please.
And so we can organize time zone. I would love if you can share with me, and I'll share with Phil Aldan, is our pediatric neurosurgeon, goes every year to the Philippines in a mission, bring a resource from here to there, all kinds of ideas. Again, products that expire and we throw in a trash can in this country. The really a stent retriever expires. Don't know that. So all kinds of ideas that can come from that. But I would love to know who are your champions in the Philippines, because we focus a lot of research from this foundation there. So I think it'd be great to help ignite that, because again, that's another small 180 million people country that has
small.
The problem. Another problem is like 53 islands. It's not like this is one massive body of land. It's like all this. How do you bring patient from point A? But again, having the brains and the support, the political support, hats off. You heard that before, but I think it's a phenomenal initiative that you guys are doing. But the industry is behind this somewhat. I think they need to be more behind this, because the patients benefit first, the industry benefit second, because for them this is stockholder dollar amount. Again, they have to put money on the table. And it's our job as physicians, as healthcare practitioners, to push them on that. Again, I think that you guys are doing that.
And there, as Nima knows, there is some initiatives to really kind of build infrastructure in a very cheap way to really overcome these difficulties, especially in countries that cannot afford these devices. And the thing is the margin, right? When they do the calculations, we always calculate the margin for developed countries, right? And how much are you going to invest and how much I want to pay in return. I think we need to think about those numbers differently when we are talking about the other part of the world, which represents 80%, 80% of the world. I mean, we are only 20%, and I think we forget that sometimes.
Any other questions, comments? I must say, I had forgotten about those 2 weeks, but I hope that I wasn't running around too crazy, but
It was a pleasure.
I sure have, we've come a long way, so thank you for that. Do you want to introduce the next one?
Thank you.
Yeah. For the next speaker, Professor Hill will be back for more.
How are you doing over there with slides? Good? Okay. Does this point this? Is it this one or is there a different one for advancing them? Okay. No, I don't think so. Oh, here, it's under here, is it? Okay. There we go. Thanks a lot. Okay. So I have a nice picture of a mama moose with her calf, because Mevo's like the baby for the LVO, right? And moose are always like this. They always look at you like they point your bum at you and they look at you down the length of their body. Anyway, pretty fun. So there's disclosures again. Okay, so I was asked to talk about the medium vessel occlusions, and we're in the midst of our nearly completed trial in this area. So I just thought I'd say a few things. I'll pick up on some of the history that Raul talked about very quickly, and then we'll slow down a bit and get into what we're doing with this medium vessel stuff, and tell you some of the approach that we've taken as we go through. So here's a little fun quiz, right? So who knows the answer to this? When's the first published case of thrombolysis? 84, 76. Anybody else? Pardon me? Well, someone's got to connect the other ones, right? It actually is. It's actually 1958, remarkably, right? And this is the one guy, just we'll put this in because it's pre-CT. Actase or fibrinolysin with streptokinase. And this was angiographically guided intravenous thrombolysis, right? So no CT, patient has an angiogram, looks like this, no DSA, right? Wisconsin had not invented DSA yet. So you had this stuff and they gave intravenous thrombolysis. They did it to 3 patients. 1 patient did well, 2 others didn't, and we don't know what happened to the other 2, so they probably bled. Anyway, just to show you, it's a long time, right? And remember, the reason that it's taken such a long time is, and I think, Nima, you mentioned this, or Eric, you mentioned this earlier, right? In neuro, we needed imaging, right? Imaging was our enabling technology, right? We didn't have it. We were, cardiologists had the ECG, right? The ST elevation, straightforward. We needed imaging. This is Jeffrey Hounsfield. For those who don't know, he invented the first scanner in his garage. He was an engineer who worked for EMI Records. And the of course, as many of you may know, the legend, of course, is that EMI Records, of course, was the recording label that the Beatles used to make Abbey Road. So in a way, we're indebted to Paul McCartney because we have CT scanners because of EMI Records, because the money was used to fund Jeffrey Hounsfield, who built a CT scanner in his garage. Right? Anyway, there you go, just for fun. So, and then the other thing that happened, right, for EVT was, remember that EVT was predicated on the fact that we were doing interventions in the brain, right? And so, but this was the first really big trial of intervention in the brain, right, which was coiling of aneurysms, right? So this is the Molyneux and the group in the UK that led this trial, but it was this trial that put neurointervention on a firm footing, right? We actually had a randomized trial showing there was evidence in favor of intervention. And it wasn't until this that neurointervention, like it didn't really exist. It was sort of, it was there, it was developing, there was angiography, but it's 2002 that this was put on a firm footing, and that's when the innovation started. But we didn't have any of that until of course, as you know from stroke, it took a lot of time, right? The stroke stuff started earlier. So although we had 1958 was intravenous thrombolysis, that was picked up in Germany. Those who do neurointervention know Hermann Zeumer, who worked in Heidelberg, the grandfather perhaps of stroke neurointervention. They started doing interventions by dripping in urokinase in the basilar artery, showed that some patients did well. And this was picked up with PROACT, right? PROACT 2 was published in 99 with pro-urokinase dripped at the face of the thrombus in the M1 occlusion. There appeared to be a benefit. There was a planned PROACT 3 to try and get the trial going, but that never took off. And we can jump into it. And then, of course, we had a period of about 10 years where we had tons of innovation. And one thing that, for those who were sort of, we witnessed this go through, was there were lots of controversies about, who should approve what, should the FDA allow it, and all this kind of stuff. But the truth is, if we didn't have that 10 years of befuddling back and forth about who would approve what, we probably never would have had all this innovation in devices. And I think it was probably essential that we were so messed up with regulation that it allowed all these companies to innovate, do things. So you had the Mercy Retriever, there's Pierre, Penumbra. We had other things that failed, like this ultrasound catheter, right? That was used. And then we had the 3 trials, which were MR Rescue, Synthesis in Italy, and of course IMS3, which were all neutral in the long run. And certainly our group was part of this in IMS3, and we saw these things going, and others were innovating. We all believed that this would work, and we ran that in Calgary. We did the ESCAPE trial. It was interesting, though. I'll tell you, after this was amazing. After IMS3 was published, we were getting ESCAPE going at that time. I went to our equivalent of the NIH, which is CIHR, 4 times to get funding for ESCAPE. And every single time they said, it's been done, it doesn't work. Why do you want funding? So amazing, right? Just the way the granting system works. So, you have to, anyway, we made it, and we showed it. We were 1 of 5. And of course, the greatest thing that happened there from an epidemiological perspective is that there were 5 trials. So, in epidemiology, or it's the consistency of effect that tells you something's real, right? 1 trial can be an outlier. But 5 trials, then there were 7, of course, because there was PEAST, and there was the TRACE trial and others. So these trials all confirmed this. And of course, that was for this, right? For large vessel occlusion. And Bill Powers wrote the guideline, right? And Tor was the chair of the guideline committee in 2020. And some people are like sticklers for detail. And Dr. Powers is a stickler for detail. So he wrote LVO, and that means M1 occlusion and ICA, and that's it. And that's what the guidelines have said, right? And so, of course, people want to innovate and move on. And so since this time, lots of things have happened, and people have started to treat patients with more distal occlusions. There's been an explosion of innovation in devices and what people can do, right? Smaller devices, different techniques have been applied. And so people are starting to look at this. And I guess that, the thing that has happened is we now need to put this stuff on a solid footing, not to say that it probably doesn't work in some types of patients. The question is, in which patients, and what's the magnitude of effect? What's the actual benefit? How do we choose them? And what's this balance between safety and benefit? And that's what the trials are going to sort out. So the first thing is, what is a MEVO? Right, a medium vessel occlusion. We've talked about this. We were, in Nima's case, we were talking about how do you define what's an M? Where do you define the artery boundaries? The anatomic boundaries are what we've chosen to call it, but realistically, I can certainly foresee a future where it's really going to be what's the size of the artery and what's the area of brain which is subserved, and that's going to decide who we intervene on and who we don't. Right, it's not going to be what's the specific branch point of an artery. Nevertheless, currently that's what we're doing. And we've, this is what we've done in our trial in Escape Mevo, is looked at these A2, M2, P2 and distal, and then said people have to have at least a moderate, or at least a deficit that's disabling in extent. How much that's going to be, we're going to see. One thing that is observed is that you can make a distinction between what's a primary or a original occlusion versus what's a migrated one. And again, we talked about this a little bit earlier in the day about the fact that if you give thrombolysis, sometimes you see thrombus fragmenting, or if you go and do an intervention, particularly with an aspiration catheter, you see thrombus fragmenting and going more distally. So, we see this, the location changes. So a primary one is the initial occlusion was always in a distal branch, or a secondary one is it was originally in the proximal carotid, and or so maybe that's the occlusion, and then it's now an M2, or it was originally an M1 and now it's an M2, for example. And the distinction is that you sometimes see differences in where the infarcts are. So we know this, that branches off the proximal middle cerebral artery subserve the basal ganglia, right? Medial striate does the caudate, the lentiform penetratus comes. So if you have infarcts in the lentiform, you probably originally had a proximal M1 occlusion, and now you can see it's a more distal MCA occlusion. So, where's the overlap? So you see discrepancy in infarcts. And so there's overlap in looking at these cases. And you have to be careful, because if someone has a so-called secondary MEVO, they've had deeper ischemia, they're less likely to have a good outcome. And you can see this here from case series that we presented from two of our cohort studies, that in the patients who had secondary MEVOs, they had a lower probability of having an independent outcome, depending on how you define it. Stroke severities are less, right? So you can see here the median score is around 6 or 8 there. In the MEVOs, and this again is from the two cohort studies, Prove It and Intersect. Interestingly, in Escape Mevo, our median NIH stroke score is 9. So I'm actually hopeful that's actually probably a good sign in terms of proving an effect size, because the more severe the effect is, the more you can actually show that people are going to get better, right? So we're hopeful, but that's the kind of things you're looking at. And then you can see the outcomes here. What's the rationale for doing the trials? Well, there are patients who don't do that well, right? So I think certainly with treatment, half people are doing well, but there's a good chunk of people who aren't doing well, and I think probably this to some extent depends on location, which branch is affected, right? If you get a superior M2 branch, it goes up to the Rolandic area of the brain, you're going to have a lot more likely to be hemiplegic compared to inferior, where you're going to have a Wernicke's aphasia, right? So on the left side, and if it's on the right, maybe it's less important, et cetera, et cetera. So localization might play a much bigger role in deciding what we're going to do with these more distal occlusions. If you treat patients, with thrombolysis, yes, it's great and everything like that, but it's not perfect, because really 10 minutes left. Great. You can see the numbers, right? So the actual, just like we talked about, the recanalization rates, early recanalization rates with thrombolysis are not perfect, right? We're not getting to the 80-90% that we need to see people getting better. So yes, thrombolysis is good, but we certainly either have to make it a lot better, or we're going to be moving to opening arteries with intervention. What else can you do? Well, we don't have the current guideline stuff that drives change, right? So I think one of the things Mike and I thought when we were, pushing to develop this trial was that and we've seen it with the other trials, right? That if you have a couple of randomized trials which show you what the actual effect size is, it allows you to drive change everywhere. It allows regulatory change. It allows companies to innovate and use those data to develop new tools, and we'll see funding follow those kind of guidelines. So that's what we're trying to do. We're trying to show this balance. We surveyed people and asked who is treating, and you can see that many people would offer different therapies, but not everybody would treat. So we surveyed a bunch of people, about several hundred neurologists and neurointerventionalists across the world. found that depending on, you know, what scenarios we presented people with M3, A2, P2, some would treat for sure with endovascular, some would treat with only intravenous thrombolysis, some would treat with both. And so, but it certainly wasn't overwhelming. And so we felt this was enough equipoise to go on. And then, of course, we've had evolution in imaging again. I think, you know, you talked about this, I think, Nima, in one of your cases as well, that one of the lovely things about CT perfusion is it's really a great MEVO detector, right? So we'll wave the line around the occlusions over here somewhere, and you can see it, whether you use it doesn't matter whether you use the baseline imaging off a Siemens or GE software, or whether you use Viz or Rapid or any of the other systems that are post-processing these images, you can see clearly where the problem is. We've typically used multi-phase CTA for the same thing, and you're looking for the holdup of contrast. Here you can see a distal occlusion, and where the blue, there's a blue circle there in the middle image on the there, and you can see where there's a holdup of contrast. Same thing applies. Some of the here's another example in the left hemisphere with holdup of contrast, and that helps you identify where the lesions are. There's a couple of companies, I think GE's got this one, and there's a couple others too, have looked at the direction of flow in arteries, and so you can pick up where the occlusion is by the color viz technology. And we've been working on trying to do a color map based on the same thing, just to show you where the lesion is. Really simple, and the advantage of that is essentially speed. So the challenge though with these things, of course, is a little bit about safety, right? So when you're out there in an M3 and this also intersects with the discussion we had about general anesthesia, right? You need a still patient for safe navigation in some arteries. Some arteries are straight and easy to get at. Some are tortuous. These vessels are small. You're into the 2 millimeter kind of range at maximum, and sometimes 1 millimeter arteries. So you have to be very, very careful. And we certainly have seen more superficial or not superficial, but Sylvian Fisher subarachnoid hemorrhage in these trials. So far, that doesn't appear to be substantially problematic, but it's definitely real. We have to choose the right patients, right? So patients who have the right deficits. We need experienced people doing these treatments, right? You need technical expertise to get out into some of these distal arteries, and so being careful has been definitely part of it, and choosing who you can get at. Sometime, and I've had cases where I thought I would try and enroll the patient, discussion with my interventional, with Will Morris or whoever, and they've looked at the case and said, that is not a good technical case to put in the trial because it's going to be super challenging to get to. So we've had discussions like that. And I think the other thing is when to stop. Sometimes you have to decide, you know, how far do you go in opening arteries? It's definitely true. And we've seen this over and over again, that the more reperfusion we get, the more likely the patients are going to go well, but you have to be smart about it so that you're not causing harm. And so being thoughtful is critical. Sometimes that's where not having the patient anesthetized is useful, because you can examine the patient, decide if they're okay, and decide whether you want to chase that distal occlusion or not. So we're nearing the end of this trial. We've and the group in Baptist, as you guys have been part of it. Escape MEVO is like other trials in the air. The distals is happening in Europe as well, and Frederick's got the French trial is going as well. So we're going to have a number of trials with data fairly soon. Escape MEVO is a simple, straightforward randomized trial, 530 subjects, 90-day outcome. And we've used the Solitaire as the first device in this particular trial, in part because we had grant funding from Medtronic as well as funding from our public funding body, CIHR. The study's pretty straightforward, right? You have to have a stroke, you have to have a MEVO defined as A2, P2, or M2 or distal. It has to be a symptomatic lesion. You have to be an adult, 12-hour window, a reasonable scan, and then off you go and treat the patient. We expect people to get thrombolyzed according to best care. Some will get thrombolyzed and transferred in. Some will be thrombolyzed directly at the main study center. We're doing this in 5 countries around the world. So in North America, Canada, US, and 3 sites in Europe. And well, I guess UK is no longer Europe. So UK, ex-Europe, Germany, and Hungary. 2 sites in Hungary. And we're at 425, 530. I understand from Marios Skogios in the distal trial, they've enrolled 450. And from Frederick, they've enrolled 190 in the French trial. So I expect we'll be finished enrollment in about 3 or 4 months, and then outcomes will be available for the February stroke meeting. I'm hoping. We'll see, and I expect the same will be true for Marios in the distals trial. We'll see how they do as well. So it's going well, and I think hopefully we'll have some nice data. I'm hoping it'll really help us understand. I do think it hangs in the balance, right? We had a DSMC review. We certainly weren't stopped for overwhelming efficacy, but the safety was okay, and that's good. That was obviously important for us, and we'll see how it all plays out. That's it. Thanks so much. Any questions about Mevo? All good? Thanks.
Don't run, Michael. We have 3 minutes. No kidding. How hard or how easy you expect this going to be to generalize A2, P2, non-dominant M2?
Yeah. I mean, I think ultimately, like so many things, right? Ricardo, we'll end up, using judgment to make decisions about cases, right? This will provide some broad average information about the balance between safety and efficacy. Most of our cases will be in the middle cerebral artery because that's where most of the occlusions are. And we'll use nominal effect sizes to make distinctions about what's happening to people. But I think it'll be again, it's like judgments about hemicraniectomy and judgments about the large cores. That for me, that large core data are on the edge of where we should be doing EVT, and we're going to have to make judgments about who is a good candidate. If you're 80 years old and you have a large core, it's not so good. But if you're 40, get on with it, right? And the same will apply here, right? Inferior left M2 with someone with a Wernicke's who's a 45-year-old lawyer, go, right? 85 years old, right M2, no, right? You're not going to do that, right? So like it's going to be that kind of stuff. We're going to be relying on some judgment. That's what I expect it will get to, right? And then there will be those who, like I was talking with Greg the other day, but a case he had in Stanford, or one of his new young people joining his team, took someone with a complete wipeout, aspects of 0, well demarcated infarct, and opened up the M1. And, the next day the patient had a malignant swelling and died. So it's like, well, why did you do that? But, right, people will still do that kind of stuff, right? Good.
Any more? Beer time?
Beer time.
Okay, Dr. Nima has one. Dr. Nima is the last thing between you and your beer.
I think before we suppress our frontal lobe, just to conclude that, you mentioned localization, which is interesting. We got to the era, say, oh, you're just going to get an MRI. Why do you have to localize? I think looking at the patient is very important, and Mevo will be more important. For example, we have our M&Ms and there's a P2 occlusion. And guess what? Door to puncture is delayed. I expressed that is good, because that way we'll start thinking about it. As much as I like the speed, when it comes to Mevo, I think you need to pause and really start thinking before you're just rushing and go to the vessel. So interesting stuff. We're going back and forth. But again, thank you very much for a great talk. And let's get some beer, wine, or whatever you want.
We'd be really grateful if Baptist would get us about 4 or 5 more patients by the end of July. What do you think?
We are working on it.
Thanks, Nima. Fantastic, guys. Thanks so much.